I mean, the fact that we're getting 80% improvement is actually very, very, very good. To the fact that there's probably some element of placebo, which is not a bad thing. It's just how much better than placebo, is GAE. So I certainly agree that we need to get better at patient selection, because I think it's probably inappropriate to treat everybody who's, mild or moderate OA that's refractory. We have to really identify who are these inflammatory OA patients. So I think to answer Sunny's question, I do see, I think MRI is not there yet. There's just so much to look at. But I think, UG presented some very interesting data at Venti, looking at, some things in terms of the type of meniscal tears, something called the subchondral bone plate, and if there's disruption of that. So I think there's these types of things that I think really help identify, to your point, who won't do well. Complex meniscal tears, really bad, mechanical access, like very bad valgus varus deformities, and then subchondral bone plate disruption, that sort of stuff.
Yeah, I agree with that. I mean, on the same note, I've been doing this for a few years now and never saw any good correlation between the blush on the DSA to the pain and to the relief. So again, I use MRI in some cases to exclude patients who may not benefit from GAE, rather than trying to qualify them or assess if they will have a very good response. So it's mostly at this point like a rule out test.
Thanks, guys. So I'm going to start. I thought that was an excellent session, so thank you very much, speakers. I'm also going to start my question by giving you a disclaimer that I work in the United Kingdom. Now, NICE, which is a controlling body in the United Kingdom, is happy with GAE in its safety profile, but is still yet to be convinced about its efficacy. NICE says you can do GAE, but it has to be within special arrangements, which means randomized controlled trials, etc. So we're not allowed to do GAE in clinical practice yet. Now, I can sort of vaguely see their point as well, because if you look at the level 1 evidence out there, it's less than convincing, I would say. What are your thoughts?
No, that's a great question, and I think that we're still learning with GAE, and we're still trying to identify which are the best patients where we're going to get long-term durable results. And I think some of the challenges with particularly the early trials is that I feel that we almost got into these trials too early. We conducted these trials as not really quite understanding what measures we're looking at. And I think that's one of the challenges we have, is that we've got to then undo some of that, or at least explore some of the data that we found in the early stages. But I certainly think that we've got some indicators that seem to give better results, such as patients with proven synovitis tend to do better than those without. Those with less advanced mechanical damage to the knee tend to do worse than those. So we've got some indicators which favor positive results, but we're still learning. I think there's still a long way to go.
And an after question to that, how do you convince your orthopods to send you patients? In the UK, you go to your orthopod and say, dude, we want to start GAE. He'll show you the door. Essentially because you're stealing their bread and butter.
I can take the question. I work in a hospital which started off as a big orthopedic center. It's still a big orthopedic center. So that's actually it worked out to one of my advantages, because they do 3 or 4 knee arthroplasties every day. They see like 20% of the OP's knee pain. But a lot of these patients whom they recommend TKA, they don't want to have surgery, in India at least. So they refuse surgery, but they have a lot of pain. So usually they're given NSAIDs and sent off physiotherapy, but they're not happy with it. So when we told them that we can offer something, an alternative to that, at least can give them a stopgap pain relief for 1 to 2 years, they actually bought that option, and then they do send a lot of patients to us. So that's how we tell them either a patient is not willing for surgery, then they don't have any option, because the patient keeps coming back to them saying pain, but they don't want surgery. So they don't know what to do with them. So then they just see us as another option. Yes, yeah, that's one option you can use. You don't say it's a replacement for TKA. It's not a replacement for TKA. It's just it's a stopgap measure or interim measure. Some patients of us say that I want to wait when my daughter gets married or graduated, I want to have 1 year, or I want to retire and then do my TKA. So it does help that way. So yeah, talking to orthopods. Thank you.
I think the one thing to add to that with respect to the NICE guidelines, and I completely agree with Professor Gerard too about the indications for GA and what we've learned over even the past 10 years plus has been inflammatory clinical symptoms end up doing better in terms of patients than structural issues. But the way that the studies have been performed with such a varying degree of embolic use and target vessel, quantification for success, age of population, previous indication, the NICE guidelines are very similar in GAE as they are with hemorrhoid embolization, as you know, in the UK. More than 17 studies and still the same lack of positive recommendation. That being said, the way that this moves forward is with these studies that Murthy put on the screen, and at least getting some consistent recurrent outcomes, because there's just been too much discrepancy, I'd say, within that area. But to build on orthopedic surgery volume in terms of referral, and to add on what Karthik said, is there are so many patients who don't benefit or cannot benefit from TKA. So if you look at patients, it's definitely a bigger problem in the United States, but it's not absent in the UK, is BMI patients over 35 the surgeons don't like, fructokinase levels over 280 or hemoglobin A1C levels over 9 predict a poor outcome from TKA. Peripheral vascular patients who can't tolerate or have multifactorial disease in the UK, the orthopedic surgeons are not huge fans for long prolonged clamp times or tourniquet times. So when you look at a number of options, those are the areas that we went to with orthopedic surgeons even 10 years ago to say, these are really a good subset of patients to get.
And then to add to that, there's about 15 to 20% of patients who undergo TKA and have persistent pain. So that's another demographic.
My question is basically when you are trying to set up a service, we obviously have to be as good as orthopods in understanding the mechanics, pathophysiology, and actually the pain, assessment and things. So what I find interesting is what Dr. Keith Pereira has talked about the ablation. So where do we stand here? Should we actually escalate, or should we just straight away offer GAE, or should we also have hands-on experience with GNA so that it's more of a comprehensive service rather than just a technical service? Because when we want to talk about it, we want to be in that comfortable position, talk the same language as they do. There's no point in me saying that I can do GAE, but I don't know about it. So my question actually is to Dr. Keith. I know that you increase this, you do this procedure so that they can actually come back for your GAE cases as well. So where does the evidence stand here? GNA, injections, and also the embolization. So just a brief consensus so that for us who want to do cases, we have some idea where should we start?
I'll give you the quick answer on the GAE, GNA steroid injection debate. We published a meta-analysis on this looking at level 1 evidence for all three at 12 months, and the best outcomes at 12 months was genicular nerve ablation. But it had the highest degree of variability of symptom improvement. If you took the mean symptom improvement at 12 months, GNA had the best outcomes at 12 months, better than GA in all published studies. But, and this is one thing I mentioned to Keith when I was sitting there, is I'm somewhat of a chicken with GNA because, or at least we call, I don't know, in America I say chicken, but in any case, I am, because I find myself more technically comfortable in the evaluation of someone to find out if they have synovitis, and then from the GA procedure perspective. But I do have colleagues who are excellent at GNA, and whether you learn it or one of your colleagues does, or your partner in your group, I think it's important to be able to talk to that and do that. But I'll let others I know speak who do GNA, and you guys can speak to that as well.
Yeah, I mean, it's all good points. I mean, I think the way that I view it, one, the idea of interventional radiologists kind of owning the disease of osteoarthritis is a very relevant one. It is a space that we can offer, not just be one-trick pony. So you could obviously do everything from viscose supplementation, steroid injections, nerve ablation, arterial embolization, and then we've even started doing neuromodulation as well with peripheral nerve stimulation. So you can do all these things. It's all within our skill set. I don't view them personally as competing therapies. The reality is almost all these patients, they will progress to arthroplasty, at some point in their life if they, sort of live long enough. And the reality is that, you're never going to kind of cure them with one thing. There is no cure for arthritis. So I have found, at least personally in my practice, that I will use embolization for patients who are primarily, as Sunny said, inflammatory synovitis type pain. Whereas if it is more structural, then I would probably err towards more of a nerve ablation. So that's just kind of my personal algorithm.
Okay, good. Pradeep, it was a good point you brought up. When your patient, the orthopodist sends your patients to you with knee pain, when you can't operate, you need to have all the armamentarium, not just offer GAE. So actually, I started doing GNA after doing a lot of GAE because some patients came with really bad knee and they couldn't operate because he was too obese, BMI more than 45, and she was limping and valgus deformities there. So no way GAE is going to make improvement for her. But the orthopod told her, go and lose weight, go on Ozempic, do dieting, and then come back in 6 months. But they want pain relief for 6 months. That time I offered them GNA because I started doing GNA for these patients. And GNA does offer 6 to 12 months of pain relief for these patients. And it's a fairly simple procedure to do compared to GAE as well. So I offer both. And now my practice is like, if it's very advanced OA, a lot of structural changes, bone on bone, I do GNA. If it's grade 2, grade 3 OA, then I do GAE because there's some evidence that GAE reduces the progression of the osteoarthritis as well. So that's if that answers your question, yeah.
I think one thing with GNA has been in there for a while, right? Like GAE is new. GNA has been there for a while. It's been studied by non-IR physicians for a long time, and their data sets are thousands of patients, controlled, randomized control trials, sham trials, so much. So I think the evidence is so strong that there is no doubt that in the community that GNA works, right? So that's one thing. I think the second thing is, as a complement to other therapies, right? Like the only thing is we don't know when to offer it. Like how GAE is all of you perform GAEs, right? GAE is not like the ambulatory therapies we have performed, right? You go into a post-procedure clinic for fibroids and prostate. 90% times they're happy. They're going to hug you, right? For GAE, I'm always skeptical. Like I enter the room and either they're hugging me or they're telling me, what the hell have you done to me, right? So in that point of time, I think we need some options, right? So steroid injections, they've already failed. I think that's where Oceanic has a role because now you tell them, hey, this is not the end of the road. I have some more hope for you. And the data with GNA is pretty strong that I think it's a good adjunct.
I think that when we are referred these patients, is that we need to have a good understanding of all the different procedures. And so whenever I get a referral, I make sure that have the patients try conservative measures first. It's about making sure that they've had the steroid injections, how did they respond? And I think that it's important that even if we don't do GNA, or that we should be able to refer for GNA, because we need to treat the patient as a whole rather than saying, oh, I only do GAE, and if it doesn't work, I'm going to send you away. Because patients are quite often have this long journey of pain, they're in a lot of disability, and they rather have a clinician look after their entire pain journey. So certainly I think it's very important to be aware of all the options, but also not to be afraid of saying, well, we're going to try GAE. We know it doesn't work in some cases, but there are some other options, and let's explore these options with you.
Sir, I have two questions. One is regarding the GNA. So can we, just like RF ablation, and instead of RF, can we do chemical ablation, where sometimes like we do lumbar sympathectomy with using absolute alcohol? Can we do that? Because it works cheaper in the Indian setup. And we do usually, I have done few cases, and results are like 50 to 60% of the patients have, they have responded, but only 2 to 3 months. So.
Yeah, chemical ablation. There are studies showing that people use alcohol or phenol, and it does work good as RFA. I'm not sure there are studies comparing RFA with alcohol. I don't know, but there are enough literature, as Keith mentioned, for using alcohol or phenol, chemical ablation, and it's cheaper as well, and it does provide pain relief. Yes. Yeah.
And second question is, can we offer GA in case of secondary osteoarthritis, like a rheumatoid arthritis?
Yes, if it's osteoarthritis, there is significant degeneration. Yes, you can offer. If it's very active rheumatoid, they still have to be on the disease-modifying agents, all these things. But if it's like burnt out and it's osteoarthritis, yes, you can offer. Yeah. We have done a few patients. Although GA, when it's initially indications where rheumatoid was no, but there are some patients who have like degenerative changes. You can offer. Yes. Yeah.
Thank you.
So I have two last questions, and then we'll conclude the session so that we stay on time. Usman, can you talk about, in a minute, I know it's short time, but what's your preference for embolic agent? What are the other options, and how does it change from one embolic agent to another in the context of GAE?
Yeah, I mean, I think Alex did a really nice job, obviously, going over every kind of embolic agent that's currently available and or coming onto market. I think it's pretty, I wouldn't say conclusive, but I think it's pretty, I think it's pretty strong that the field is moving towards using temporary or resorbable embolics due to the sort of, as Alex mentioned, the profile, and I think ultimately this is a outpatient elective procedure, and so safety really has to be at the top of our list when we treat these patients. And I think we're seeing efficacy results that mirror, if not better, than permanent agents. So, I think that the answer of what agent is the best is still clearly hasn't been decided yet, but I think it's encouraging that most, if not all, agents have a pretty equal efficacy across the panel if they're used sort of appropriately.
Are you using more of lipoidal now, right?
Yeah, I mean, I think most people probably know me as the person that uses lipoidal. So, I would say almost exclusively I use lipoidal.
Got it. Have you used imipenem cilastin in your practice?
I do. I would say the other agent I use is imipenem, but infrequently. Honestly, it's just more of a, we have a registry, so I just like to kind of use different agents just to understand outcomes.
Are you seeing less of complications compared to permanent embolics that we have been using in the past?
Absolutely. We just published our experience from when I was at University of Chicago comparing microspheres to lipoidal, and the safety profile is much, much better.
Are your volumes, embolic volume, is it more now given that you're using temporary embolics?
Yeah, I think in general with temporary, the idea is more vessels, go to stasis, and like higher volume as a result.
Thank you. And the next question for Dr. Bagla, can you tell us about your endpoint, how many vessels you embolize, what's the evidence, or what's an ideal situation? And we'll conclude it with that answer.
Yeah, it's a tough one. So looking across all the studies, which has probably allowed us to really make sure we don't, Eva, I was going to avoid her in my next talk. Looking across the studies, I would say our target is minimum 3 vessels. If we're targeting a joint, we're typically targeting medial or lateral. If it's a midline area, such as like infrapatellar pain or suprapatellar pain, it's maybe a minimum of 2, like inframedial, infralateral, collateral pathways, but 3 arteries, I would say, is a minimum. With permanent embolics, we don't go over 4 arteries because it ends up being pretty painful. It's not that somebody won't necessarily have a blush in 4 vessels or 5 with associated pain, or they might have hemarthrosis and need 4 or 5 vessels treated, but I think we wouldn't go over that. With imipenem, I would do 4 or more vessels, or any of the other resorbables that we are currently running trials with. Yeah. So I think more is better with resorbables and with embolics in terms of target vessels. I think it's very important, whether you mentioned too, going either getting into the primary target and or if you cannot, through a collateral pathway into that region of the joint.
Awesome. Thank you panel, and I appreciate it, and we'll move on to the next session on TAME. Thank you.
Thank you all the panelists. Next we are moving ahead with the TAME topics. I would request Dr. Sandeep Bagla and Gerard Go to chair the session. First talk is on frozen shoulder, anatomy, technique and outcomes by Dr. Sandeep Bagla.
So thank you very much. It's my pleasure to invite Sandeep Bagla, who's my co-chair of the session, to give the first presentation. And we're going to venture away from the knee to see other applications of musculoskeletal embolization.
Thanks, everybody. We are going to switch, as Professor Gerard said, over to shoulder embolization. And I'm going to talk about frozen shoulder. I'll talk about really what the clinical outcomes are, some technical considerations, and then what the outcomes are with what we refer to as ACE, which is adhesive capsulitis embolization. It's just easier and shorter for me to say ACE than it is to say frozen shoulder embolization. By show of hands, has anybody in the room ever had frozen shoulder? Anybody? It's pretty painful. Yeah, I see someone raising their hand over there. Usually they can't raise their hand. I think that was the indication here. And for those who have never had it, generally affects about 4 to 6% of the population. It is a progressive, limiting range of motion shoulder disease. And the hallmark symptom, and this is important when you're selecting patients, the hallmark symptom is nighttime pain. So they wake up in the middle of night with pain. And usually that's diagnosed because somebody wakes up in the morning and says, I thought I slept on my shoulder incorrectly, and then the pain doesn't go away and it progressively gets worse. And there is an early inflammatory phase. That phase then continues to progress where you get fibrous adhesions in the shoulder. The hallmark sign is really limitation of passive external rotation of the shoulder. So someone else moving your arm outwards to rotate your shoulder externally, and that is limited. And so that is because there's inflammation in the capsule. It leads to an extensive hypervascularity in the shoulder. So if you're an orthopedic surgeon and you do an arthroscopy of the shoulder and you put a camera on the inside, the shoulder capsule will be incredibly red and hot. And typically the treatment, most people know, is just giving NSAIDs, physical therapy. Sometimes they'll use hydrodilatation of the joint, even shoulder release surgery or capsular release surgery later on. But one thing to know before I get into the technique and the data, when you look at all of this data, be a little bit critical, because if you're an orthopedic surgeon, the natural progression of frozen shoulder is for pain to go away. It starts, it gets worse, and then it goes away. And what we're really doing when we're doing frozen shoulder or ACE embolization is that we're actually just shortening the length of time that the patient has pain and getting them back to being functional earlier. So when you start to look at long-term results in clinical studies for frozen shoulder, even if you look at people who never got treatment, if you look at their pain score at baseline and at 24 months, you'll see 8 and it'll go to 2. And that's because it's a natural progression. So when I start to show you some of the data before going into the technique, keep that in mind. So the first key study that was performed by Dr. Yuji Okino in Japan. This was back in 2017 that he published it. It was probably performed somewhere between 2014 and 2016. It was only 24 patients that really went through follow-up. And he used imipenem-cilastatin to perform this frozen shoulder embolization. These are patients with diagnosis of adhesive capsulitis. And when you look at the outcomes of these patients, look at the rapidity in symptom improvement. 1 week, 1 month. Very quickly, 87% of those patients, by just a month, already have significant improvement in pain. It was durable out to 36 months. There were no major adverse events, and you'll see that recurring theme that there are not really many adverse events associated with frozen shoulder embolization. But now that I've explained that background, hopefully you understand it is unlikely for frozen shoulder patients to recur in the same shoulder. They may, but it's more likely for them to have a new presentation in their contralateral shoulder, okay? And the patients that typically come in with this have thyroid issues, either hypo or hyperthyroid, they're diabetic patients, they oftentimes have other things, subarachnoid hemorrhage history in the past, Dupuytren's contractures. So these types of patients present with these symptoms, but in this particular study, which was the first, he did have very rapid pain improvement. The midterm results that were published by Ana Maria Fernandez Martinez and her team also showed, if you look at this whisker chart, you'll see that the pain improvement here on the left side really improved very rapidly and then continuously gradually improved out to 6 months. And the functional scores on the right-hand chart, those are functional scores in terms of the ability to extend and abduct the shoulder. And those are really, like we mentioned, the limiting clinical signs that you see in frozen shoulder. And that was also demonstrated to significant improvement. So improvement in pain, improvement in range of motion, no major complications, also performed with what I call a rapid resorbable agent in imipenem. We performed this study from 2017 to 2019 in the United States, followed those patients out for a year afterwards. The follow-up at the last follow-up was somewhat interrupted by the COVID outbreak, but suffice it to say it eventually got published in 2022. In our particular study, because of, at the time, performing a clinical study with a resorbable medical therapy or imipenem, an antibiotic, we chose to perform the procedure with a permanent embolic, and we chose 75 micron Terumo hydropearls at the time. And when we looked at these 20 patients, they did have some minor complications, which are all skin related, and they were skin discoloration over the top of the shoulder. And they also presented very frequently with itching after the procedure, and that itching in the skin also resolved over just 48 to 72 hours. There were no major adverse events. But if you look at these three columns, so first column is for visual analog score, which is pain. Second column is really a single indicator of function of the shoulder as told by the patient. And the third column is the ACEs score, which looks at function, pain, disability associated with the shoulder. And the pain rapidly decreased in these patients. These are pain improvements. When you look at the knee studies, right across the board, you might say there's a 60% improvement in overall pain, 65%. When you start to look at shoulder studies, you start to see pain improvements that are usually higher, 75 to 85% in terms of the relative improvement of their pain score. Functionally, they did very well also, and that was with a permanent embolic. Ana Maria Fernandez Martinez's group also looked at stiff shoulder, unlike frozen shoulder. So these are not necessarily idiopathic cases. These are prolonged cases of stiffness in the shoulder. They may be post-traumatic, which is most common, or post-surgical cases, and found that in this patient population, she also had, and their team had, clinical improvement in symptoms, albeit it was not as high as in the idiopathic frozen shoulder group. And then a systematic review, just to go through the data very quickly on this. If you look in terms of both technical success and cohort of the patients, really the only real difference is maybe half the studies are done femoral, half of them have been done radial. The majority have been done with resorbable imipenem. And our study was performed maybe with permanent embolic in the United States. But suffice it to say, when you look at the results, if you look at the chart on the left, which really just focuses most centrally on visual analog score or pain improvement, you'll see that rapid improvement in pain. So I think with frozen shoulder embolization, if a patient has idiopathic frozen shoulder, there's very little debate in my mind, unlike what we talked about in the last panel with respect to GAE, where you're not sure if a certain patient may do better. I think with frozen shoulder patients, if they truly have the disease and you get them in their inflammatory stage, they have a high likelihood of seeing an improvement. Adverse event-wise, not really something you should be too concerned about, especially if you're going radial, potentially femoral could in terms of aortic arch-related plaque, but from a femoral standpoint, mainly skin discoloration and or itching. How about anatomy? Lots of anatomy in the shoulder. There are 6 arteries. I'd reference you to Yuji Okano's first paper where he looked at the anatomical pathways. He numbers them 1 to 6. I will go through them with you. They typically supply a certain region of the shoulder. This is really, in my mind, if you were doing the procedure transradially or transfemorally, place the catheter in the proximal subclavian artery, do your angiogram, and you will see these 6 arteries. So suprascapular, easy to recognize because it really has that, it goes to the suprascapular notch. The thoracoacromial artery usually has this reverse curve and then is straight towards the AC joint. The coracoid artery is a very, very small artery. It is probably the only reason that you'd want to use a 2.0 catheter, 2.0 French catheter or microcatheter. The circumflex scapular artery, which really supplies the axillary pouch, and then you have the anterior and the posterior humeral circumflex. The anterior humeral circumflex is always the smaller one, and the posterior humeral circumflex is always the larger one. So if you look at this in an angiogram and you're trying to identify these arteries, you know, that thoracoacromial here is just going to go up. It has some branches towards the AC joint. It's going to go over the front. You'll see here this big swinging posterior humeral circumflex, anterior humeral circumflex. And then when you look at this when you look at the subscapular artery, sorry, this artery that's going here, what you'll identify is that's the artery that ends up supplying the axillary pouch. So when patients have pain underneath their shoulder joint or in their axillary pouch, that'll be important to target. So we typically get MRI in these patients prior. Why? MRI in frozen shoulder does depict the disease very well. It also rules out other issues like slap tears that you don't want to really get involved with when it comes to embolization. But we typically get MRIs, routine labs. Physical exam is very important. So patients will do this. If they're a woman, which is much more common for women to get frozen shoulder, they will tell you they can't put their shirt on, they can't scratch their back, they can't take this hand and put it behind their back, and they usually have difficulty brushing their hair. They will also tell you that they have pain, like we talked about, at nighttime, which is the worst. In terms of technique, 2.0 French catheters, 2.4 French catheters, those are our 3 favorite wires. They just tend to work. I don't think there's much from a wire, super advantage in this. I would say that you should know that getting into these arteries from a radial approach, because they're going the opposite direction, because as we know from from fetal embryology, your arms extend, your buds extend. So when your arms extend, that's why the arteries go in that direction. And so when you look at this, you're often having to make these turns. So when you make these types of turns, they can become challenging because everything wants to prolapse from a radial approach. Everything wants to go back up towards the neck. So if you take a wire, and this is where we first discovered this wire shape that we use so often in PAE, but we actually discovered it in shoulder embolization back in like 2017, which is put a secondary curve on the wire. So make like a typical C shape on the end of a wire, then go back proximal to the C and make the curve the opposite direction. And what that really does is it allows you to buttress off one wall and it allows the catheter to track well. So we don't typically use pre-shaped catheters, but you can if you'd like to. If you're using 75 micron hydropearl or any comparable bead size, I would dilute it 10-to-1 contrast to beads by volume. If you're using imipenem, you'll take your imipenem dry powder vial and mix it with 10 cc's of contrast. You really put it back and forth like you would through a 3-way stopcock. And it's dose dependent, as Alex mentioned. So typical doses are somewhere between 0.5 to 1.2 cc's per target artery. In a smaller artery like the coracoid, you might only get away with 0.5 cc's, and the arteries will look completely, if you will, occluded. They will recanalize, but like Oz mentioned in the last session, the goal tends to be more about occlusion with temporaries than it is otherwise. I got 23 seconds to avoid Eva. So this is a 43-year-old female. She's got edema in her a rotator interval right here, diabetic, no RA, no autoimmune disease, limited range of motion. And she failed medical therapy. She failed NSAIDs. Her pain score is very high, 82 out of 100. Her main target artery was the coracoid artery, right in front of the joint, okay?
Last 2 minutes.
You can see the pre and post. This was done with hydropearl. So I show you this because that pruning is what you typically see. If this was done with imipenem, it would be a stumped artery. So you wouldn't see any of that microvascularity at all afterwards as you push out. An 82-to-9 in terms of her clinical improvement. And this is what I meant on MRI too for a different patient. So 52-year-old female, left shoulder pain, worse at night. She did have a history of thyroid disease. She was very tender anteriorly and posteriorly. But on her MRI, she had this, which is very, very significant increased thickening of the axillary pouch. So when you look at this axillary pouch and it's 4 millimeters or larger, this is very abnormal. You should not see this. And this is one of the earliest signs in patients with frozen shoulder. So look for this if you're looking at MRIs. She failed a steroid injection. Her pain was 74. This was, I think, the anatomy I might have shown you on the initial. And here, because she had axillary pouch thickening, what we did is we targeted this circumflex artery, sorry, this subscapular artery here, went all the way around, and you'll see the hypervascular blush that's underneath in that axillary pouch. Pain decreased to 14. Okay, so last slide. What do you expect afterwards? So we send them home. If they have gotten permanent embolics, we send them home with NSAIDs, Toradol, ketorolac, or Motrin or ibuprofen. If they get temporary embolics, we do not send them home with any medication. We do tell them to expect to have some itching or redness over the shoulder that'll go away in 48 to 72 hours, for which they can take Benadryl. In frozen shoulder patients, their pain typically improves in about 2 to 3 weeks. It shouldn't take longer than 4 weeks for them to start noticing a significant pain improvement unless they have radiating pain down the arm. Then that might take another, say, a month or so after the procedure. With that, I'll thank you, and Eva, it's your time. Thanks very much.
Time is up.
Thank you, sir. In the similar note, we have talk on plantar fasciitis by Dr. Osman.
All right, I'm going to try to talk fast to avoid the AI alerts. All right, so that was a really, really great talk on shoulder embolization. We're going to go ahead and now turn our attention to the foot and talk about plantar fasciitis embolization. So a little bit of background. So plantar fasciitis is the most common cause of plantar heel pain, accounts for about 1 million patient visits annually in the US, and it peaks in incidence in sort of the middle-aged population, 45 to 64 years of age. The plantar fascia is actually like an aponeurosis of 3 bands of tissue from the medial, central, and lateral, and sort of originating at the calcaneus and inserting onto the MTP, or metatarsal phalangeal joints. Its purpose is essentially to stabilize the longitudinal arch of the foot, and essentially when you start getting repetitive overloading, this induces microscopic tears and degeneration of the tissue. And this most commonly occurs at the medial origin of the plantar fascia. And risk factors for plantar fasciitis include elevated BMI greater than 30, along with decreased ankle dorsiflexion, prolonged standing, as well as excessive foot pronation and running. Now, the classic symptoms of plantar fasciitis are really described as pain that occurs with the first steps in the morning and or after prolonged sitting. And the pain is typically concentrated at the medial aspect of the heel, so much so that it elicits tenderness to palpation. The pain is exacerbated by passive toe extension, and that's a physical exam test called the windlass test, where essentially if you take the toes and you passively extend them and induce pain, that's pretty characteristic of plantar fasciitis. And the diagnosis is primarily clinical using tests like that. Imaging is rarely needed unless the patient isn't responding to conservative management. And typically you can obtain either an ultrasound or an MRI. Ultrasound, obviously being cheaper and easier to do, will show a thickened plantar fascia. Typically we diagnose it as greater than 4 millimeters at the heel insertion. But the plantar fascia will also be shown to be hypoechoic and heterogeneous with increased hyperemia on Doppler. And this is just a visual graphic showing you that windlass test where, again, if you just passively extend the toes, you essentially exert a stress on that plantar fascia, and if that induces pain, that's classic for plantar fasciitis. Now, as far as treatment goes, similar to frozen shoulder, this is a self-limiting disease. However, again, similar, the symptoms actually may persist for months to years, so much so that in literature, the mean symptom duration is actually listed as 725 days. And so much so that 80% of patients have symptoms at 1 year. So while while this disease is self-limiting, these patients are actually sort of suffering for quite some time. Fortunately, conservative management is successful in up to 90% of patients, and that includes some combination of plantar fascia-specific stretching, activity modification, orthotics, arch taping, night splinting, as well as basic pharmaceuticals like NSAIDs and analgesics. If patients are refractory, then second-line therapies for sort of persistent symptoms are attempted. And this includes things like steroid or PRP injections. It's important to note that steroid injections do have an increased risk of plantar fascia rupture of about 2.5%, as well as fat pad atrophy, which is, again, important for sort of cushioning of the foot. And then you can also try shockwave therapy. And surgery really is reserved for refractory cases that last 6 to 12 months despite this conservative management. It's important to note with surgery, however, that patient satisfaction rates are pretty heterogeneous, and they can be anywhere between 48% all the way up to 89%. And this is where the opportunity with plantar fasciitis embolization sort of enters. It's been offered or is offered as an option for plantar fasciitis patients who are resistant or refractory to these first-line therapies. And it's predicated on the same idea as all other musculoskeletal embolization that we do, which is to target the abnormal neovascularity that occurs with plantar fasciitis. And again, the goal being to sort of reverse the inflammatory cascade that causes pain and disability. The anatomy is a lot more straightforward than the knee or the shoulder. The primary vascular source to the plantar fascia is via the posterior tibial artery, which supplies the plantar surface of the fascia. The DP or dorsalis pedis artery supplies the dorsal aspect, but typically that's not what we're concerned with. Now, specifically, the artery that is of concern is the medial calcaneal artery. This, again, supplies the fat pad, the muscle, and the fascia. And again, as we talked about, most pain with plantar fasciitis tends to be along the medial aspect of the heel. And then there's also other perforating branches that may serve as a supply. Typically, we're looking at the medial and lateral plantar branches, looking for that medial calcaneal artery. So here's just a cartoon graphic, again, showing the lateral plantar artery as well as the medial plantar artery that, again, supplies the sort of plantar surface of the foot. And these arteries, again, typically will supply the calcaneal branches, both off the lateral as well as the medial plantar artery. Now, as far as the technique for plantar fasciitis embolization goes, there's two methods. There's sort of the traditional method, which will, again, typically sort of involve a femoral approach and sort of involve selective embolization or catheterization of these neovessels. And then there's what's known as the Dochu method, which is what Professor Akuno described, and we'll get into that, which is a more non-selective, sort of a simple, more like a steroid injection approach. So the traditional method involves, and this is just my approach, but sort of probably similar for most people, it involves femoral antegrade access or equivalent. And for me, I've actually evolved into just using a microcatheter only. So this is, again, done still very minimally invasively. And the idea is to take the microcatheter down to the posterior tibial artery, perform angiography, and then proceed with selective catheterization of the blush vessels to the plantar fascia, which again will ideally be these medial calcaneal branches. And then again, proceed with embolization with the endpoint of pruning. Now, predominantly the literature has reported the use of temporary embolics, whether that's imipenem or Lipiodol. And this is a very, very small amount of embolic, typically less than 1 cc that's needed to achieve the embolic effect. So here's just an example of the traditional approach. This is a micropuncture access into the SFA, and then we proceed by placing an 0-8 wire, and we directly place a 2.0 French microcatheter. We guide that microcatheter down to the posterior tibial artery, perform an angiogram to confirm where we are, and then take that down into the distal posterior tibial artery. And you can see here, from the distal posterior tibial artery, we can identify this hyperemic blush. It's a pretty straightforward thing to see. And then we'll proceed to catheterize the lateral plantar artery, and you can see here the medial calcaneal branch originates right from the proximal origin of that. just zoomed up here, again, really showing you that blush along the plantar fascia, again, arising from the medial calcaneal artery. In this instance, we proceeded to embolize with Lipiodjoint or Lipiodol emulsion, and you can see here we're injecting the Lipiodol and again taking this to stasis to sort of occlude these vessels. The other method that's utilized is the Dochu method, which, again, as I mentioned, Dr. Okuno has described, this is a direct posterior tibial artery puncture. With this approach, we can place the inner component of the micropuncture and perform angiography from this, from the distal posterior tibial artery. But instead of going and selecting these neovessels, we perform non-selective embolization of the posterior tibial artery. To basically sort of temporarily occlude flow to the foot via the posterior tibial artery. And this requires more embolic, as you can imagine, usually about 1 cc. Again, you can still go to stasis with this approach because you're using a temporary embolic. And the true Dochu method, as Dr. Okuno's described it, actually can even just be done without any angiography at all. You can just inject the imipenem directly under ultrasound with the needle in the posterior tibial artery. So here's an example of the Dochu method. So you can see here we've directly stuck the posterior tibial artery in an antegrade fashion. We'll perform a distal posterior tibial arteriogram. Again, you can identify here, you can see the plantar arch there, so you're seeing opacification of the dorsalis pedis. But you can see here, this is the blush that we're focused on. And our catheter here is in the distal posterior tibial artery. There's the medial plantar, there's the lateral plantar, and then there's the hyperemic blush from the perforator there. And this is the initial angiogram. We'll proceed with injecting 1 cc of imipenem, and you can see here we've essentially created a static sort of appearance to the vessel. Fortunately, that's a very temporary stasis, and you can see there's non-selective uptake into that plantar fascia. And this is what it looks like immediately after. You can see the embolic distribution is in a much more non-selective fashion. You can even see imipenem at the distal tip of the catheter there. And then this is a post-embolization angiogram. So this is only a few minutes after that injection, and you can see here that blush to that plantar fascia has resolved. Just a side-by-side comparison, pre and post, showing resolution of that blush. So where's the data? There's a small amount of data, and it's very encouraging, but there's still not as much as there is obviously for the knee or other joints. As you can see here, this was actually first described in 2013 by Dr. Okuno, again with the idea that blocking these abnormal neovessels that feeds inflamed tissues can lead to reduced pain and improve disability. And then if you look at this, it took about 8 years later, was a follow-up case report from Dr. Okuno where he treated a 51-year-old woman with embolization twice, and that led to resolution of pain and improved outcomes. Then this was followed by a study out of India, actually, talking about outcomes for plantar fasciitis. Again, this was using imipenem, and you could see here the baseline VAS scores were very high in the 8 or 9 range, and the 12-month follow-up was in the 1. So very nice outcomes here in a total of 13 patients. And this was probably arguably the most important study that we have published to date from Dr. Okuno of 66 cases with up to 4 years follow-up, again, where he described that Dochu method as well. And you can see here the NRS, which is basically like a VAS, decreased significantly from 7.9 to 0.7 at a mean 30-month follow-up. And only minor self-limited AEs, no major ischemic complications. They also had imaging correlation showing that on ultrasound, the thickness of the plantar fascia also decreased. And then this is a relatively recent study in the European Journal of Radiology, a Turkish study that looked at super selective embolization of that medial calcaneal artery in 32 patients, similarly decreased the VAS at 6 months with improved function as well as decreased thickness of the plantar fascia. of note, nobody required a repeat embolization, whereas in the prior studies, in Dr. Akuno's study, had an average of 2.2 interventions per patient. So, in conclusion, plantar fasciitis is a common MSK disorder characterized by heel pain exacerbated by passive extension of the toes. I'm going to pause here very quickly to listen to the 2-minute warning.
Last 2 minutes.
So conservative therapies can be effective up to 90% of the time, but for those medically refractory patients, plantar fasciitis is a nice alternative to steroid injection, which has a risk of rupture. And the technique includes both the traditional method as well as the Dochu method that we just talked about. And the existing data is early, but it's very promising in terms of safety and long-term durability of therapy. All right, thank you for your time.
Thank you, Dr. Osman. Next, we have a talk on pre-op tumor embolization by Dr. Kunal Kala. We will take the questions during the panel discussion like we did for GAE and GNA session.
So, very good afternoon. Okay, it's still good morning. Good morning to everyone. And first, I would thank the organizers for inviting me to deliver this talk on pre-op embolization. So, the topic was vascular control before the knife. That means it is because it's like pre-operative embolization. Yeah, so the slides are loaded. Thank you. So coming on to this is predominant my agenda. One is background and rationale and types of embolization that we perform, indications and patient selection, preoperative evaluation, imaging, angiographic finding, embolic agent, timing of surgery and clinical outcome, that's predominant thing, and complication and safety, and what do we take home message. So coming on to background and rationale for pre-op embolization, it's basically MSK is a heterogeneous group of disease right from benign to malignant condition, and this was first started as a pre-op embolization by Friedman in 1975. And far more bone metastasis is more common than primary bone tumors. And when surgical resection of these tumors are encountered for predominantly hypervascular tumor, there is significant intraoperative blood loss which is there. It prolongs the time. There is no R0 resection which is possible, and there is increasing transfusion hazards which is possible. So what do we do in trans-arterial embolization? Basically, we devascularize it. There is ischemic and necrosis which happens over a period of time, and there is demarcation which happens during the surgery, and resection is possible. So this is one such thing. In preoperative, we actually embolize the tumor bed rather than the parent vessel that is generally embolized, and it is generally for hypervascular bone metastasis. So there are different types of embolizations are being performed. Coming on to definitive embolization, that means we are doing as a one-stop short treatment predominantly for hypervascular tumors like ABC or GCD. Preoperative, just before the surgery. Serial, as in case of sacral GCTs. Pain palliation in the end-stage disease when patient is on the palliative therapy. Emergency when there is significant amount of blood loss or when patient is bleeding. So what are the indications? So indication depend upon the histological stratification, and this is one of the most strongest predictor because hypervascular mets bleed more than the non or avascular metastasis. So predominantly RCC, thyroid and hepatocellular carcinoma, these are generally hypervascular metastasis, and they have high vascularity and neovascularity which is present. Primary bone tumors, giant cell tumors, aneurysmal bone cysts, these are predominantly expansile lesions, and they generally have some amount of soft tissue, so there is high capillary density. That's the reason we do preoperative embolization. Preoperative is even done for aggressive vertebral hemangiomas and osteoblastomas to prevent massive hemorrhage during the surgery. And in malignant primary bone tumors like osteogenic sarcoma or Ewing's, many times we do preoperative or just to decrease the tumor burden. So these are for metastasis from hypervascular bone, mets from thyroid metastasis, and this is ABC in the bone. This is predominantly whatever I have told, it's summarized in this chart. So coming on to indication, so anatomical and location is most important because we can't, whenever the surgeons can't tie tunicate, that's the indication for us to do either a preoperative embolization. So for example, in case of sacral tumors, the tunicate cannot be tried. Upper humerus is another indication, or upper femur is also one of the indications for doing preoperative embolization. So these are considered high risk site because they bleed a lot during the surgery. Tumor neovascularization, whenever it is close to the spinal cord or neurovascular structures. And on angiography or on CT scan, what do we see is predominantly hypervascularity or intense enhancement with some amount of flow voids on MRI, which will be T2 hypointense, and that's what is hypervascularity. On angiography, there would be arterial blush, and what is the aim of embolization is basically to reduce at least 70% of the tumor bed which is there. So this is one such hypervascular bony lesion which is embolized, and then we do embolization. Coming on to contraindications, coagulopathy, severe renal dysfunctions, whenever there is critical structures, that is artery of Adam-Kavich which is present, cervical tumors which would be supplied by posterior circulation, which would be difficult to do preoperative embolization. So all preoperative tumor embolization go through the MDT tumor board. They decide upon the clinical history lab, and depending on the surgeon comfortability, we can do preoperative embolization for most of the patients. So coming on to angiographic findings would be transarterial, it would be transarterial or transfemoral access, any diagnostic catheter 4 French or 5 French, along with that microcatheter, and super selective into the tumor, predominantly towards the nidus of the tumor, and mostly either polyvinyl alcohol particles or embospheres can be used, taking care about the skin, muscles and nerves to be preserved as far as possible. So the aim of a procedure would be to embolize at least 70% so that there is good amount of benefit preoperatively. So here is basically tumor bed embolization. So this is a case of sacral giant cell tumor. Significant amount of vascularity is present, and the tumor bed is embolized, and what we see is a preservation of the major large vessels which do not get embolized when you are going selectively. Coming on to the embolic agent, what do we prefer and why do we prefer? It is predominantly either polyvinyl alcohol particles, because we need to embolize distal to mid-level, and these would be semi-temporary to permanent kind of embolic agent, and their predominant risk is either aggregation, clumping of these particles which can happen. Microparticle, they go more distally compared to PVA or polyvinyl alcohol, and there is risk of non-target embolization. Onyx onyx is generally is not performed unless we are not doing preoperative embolization, and gel foam can also be done because this is generally preoperative, and we do generally at least within 72 hours of the surgery, and coils are generally avoided because proximal embolization is not is always a risk. Rather we need to perform as distal as possible. Coming on to the timing of surgery. Timing of surgery is pretty much critical because intraoperative blood loss will depend, and overall success of preoperative embolization depends. So ideal case scenario is like 24 to 72 hours. So whatever meta-analysis I went through, most of the meta-analysis indicates that whenever the patient undergoes surgery within 24 hours, there is complete embolization, and it causes less intraoperative bleed, and surgeons are much more comfortable operating, and which is statistically significant. Coming on to till 72 hours, it's the embolic effect is great. After 72 hours, there is no much benefit, or the benefit goes on declining as the number of days after embolization goes on. So, this was one of the article, preoperative embolization in tertiary care center. So, impact of intraoperative blood loss. So, in primary bone tumors, there is definitely reduction from 1800 ml to 1300 ml, and in some in this paper also there is blood loss in at least 70% of the patient. So, this is another article, systemic and meta-analysis, which showed that mean blood transfusion decreases from 1400 ml to 700 ml during the surgery, and it actually impacts the mortality, which is almost 7%. It also causes less operative time, so the surgeon also takes less time compared to non-pre-op embolization, from 124 minutes to 90 minutes. So it significantly decreases. So coming on to few of the complications that can be encountered would be stroke if it is near the posterior circulation. There will be spinal cord ischemia or paralysis if there is inadvertent occlusion of artery of Adam cavis. There can be gluteal necrosis in case of sacral artery embolization, and a wound breakdown can also happen because many times skin and subcutaneous tissue are being embolized. Coming on to literature in meta-analysis and systemic and meta-analysis, this was the optimal time of embolization and surgery of hypervascular spinal metastasis. So when I compared, there was no statistically significant. So timing of embolization is predominantly between 24 to 48 hours, and that's what is more important. Complete embolization and early surgery within 24 hours really helps, and which is statistically significant in this meta-analysis. And degree of embolization, complete embolization is always preferred. So this is another case control which also showed the same things. Coming on to few of the cases which we had done in our institute. So this is giant cell tumor, upper end of humerus. So this was 25-year-old male. Pre-operatively we did embolization, and this is post-embolization. There is no blush or vascularity, and post-operatively there was blood loss of just 900 ml, which normally goes on to at least 1.5 to 2 liters, and which has reduced to 900 ml. This is another case, aneurysmal bone cyst, embolization was done and the blood loss was reduced to around 1000 ml, and this is post-operatively. On follow-up there is ossification, calcification after curettage. This is again a giant cell tumor. Many times we get references for hypervascular metastasis from either thyroid or renal cell carcinoma, and these would be having predominantly either impending spinal cord compression or just spinal cord compression with no bladder or bowel. So patient needs to undergo emergency decompression post pre-operative embolization. So this is what we had done, pre-operative embolization of the vertebral bodies, and then there was a reduction in the blood loss to 1.2 liters. So many times when they are not operable or not, so patient is not operable. So this is RCC meds. These are generally hypervascular. Embolization is performed, and many times surgeon is refusing to operate because of multiple metastases, and then since patient is having pain, so RFA vertebroplasty is another option for stabilization with minimal risk of and patient had a good survival in case of RCC because it's clear cell carcinoma. So this is RFA vertebroplasty. Pre-operatively we do RFA vertebroplasty if surgeon is not operating. So coming on to take home message, angioembolization can be considered as one of the algorithms in treatment of primary and secondary hypervascular bone tumors. Doing pre-operative embolization actually reduces the bleeding during the surgery whenever it is near the spine or neural encroachment, and surgical tourniquet cannot be tied. So that's where angioembolization really helps. A0 resection is possible with this, and whenever there is awkward surgical location and surgery complications during the surgery are anticipated, preoperative embolization can be considered as one of the treatment options in the algorithm. And this is with that I conclude my session. Thank you.
Thank you, sir. Now we have case-based discussion and panel discussion on TAME. I request Dr. Alex, Dr. Sandeep, Dr. Osman, and Dr. Rosil to be on the stage. Audience questions can be taken now. If anybody has any questions, can come.
Hi, I'm Dr. Vritika. Thank you for those amazing sessions. So I just wanted to ask, as in case of genicular artery embolization, can TAME for shoulder joint be, the application, can they be extended to inflammatory arthritis as well? And are there any specific cases of inflammatory arthritis that you did? Because there isn't a lot of literature regarding the same.
So, thank you for that question. So the question is, with respect to shoulder,
Yeah.
can it be used in inflammatory conditions? Gout, rheumatoid arthritis, or do you mean tendinopathies, or inflammatory tendinopathies or inflammatory joint-space disease?
Inflammatory joint-based diseases, for example, rheumatoid arthritis.
Yeah, so, and anyone here is happy to jump in too. I would say that I would use the same approach for inflammatory arthritides in the shoulder as I would in the knee. By that I mean the data we have to date, and we don't have much in the shoulder, just to be clear, and we have a mild amount in the knee, minimal, case report level data, is that it does work in terms of reducing inflammation and pain. However, the recurrence rates anecdotally tend to be higher in those patients. That being said, I think in the last session, Karthik might have mentioned too about those patients who are on disease-modifying drugs. So many of the patients who we would see, and we've had this recently with patients with knee Lyme disease, shoulder-related, what appears to be like a frozen shoulder, but it's not really, it's just a shoulder arthropathy from rheumatoid arthritis, is that some of the rheumatologists need to give these patients a holiday from their drugs for 6 months because they either get thrombocytopenic or they get fatigue. And so in these patients, they will not necessarily tolerate whether it's methotrexate or more significant therapy. And so that's where I think we can jump in and benefit these patients. We've seen it in, like I mentioned, particularly in rheumatoid, to a degree in Lyme disease of the knee. But yeah, I would say that avoiding the DMDs are still something that we can't do, right? And what you're seeing angiographically tends to be the same as well. I don't know if anybody wants to share in terms of shoulder, or Oz, if you want to share something too. Or in other joints as well too.
No, I honestly, I don't have much to add other than just a little bit of a personal experience. We, in working with our rheumatologist before I left the University of Chicago, we all do a lot of liver cancer work, and there's an increased use of immunotherapies for that. And what we started seeing is there's actually immunotherapy-induced inflammatory arthritis, which we started doing embolization for those patients and saw some really, really good outcomes. So that is another possible avenue, I think. So there is definitely a mechanism where embolization works, but I think to Dr. Baglow's point, it has to sort of be done in a sort of systematic fashion where the other therapies have to be their first line, and if you really only do it when those have either burned out or aren't working, or they need some, like a chemo holiday from it.
All right. Thank you for your inputs. Do you want to say something?
I kind of agree. I don't have any experience of the inflammatory arthropathies, but certainly having spoken to Yuji Okuno about it, there is some interest in this area. I guess it's very different from the degenerative diseases we heard from Dr. Bugler, in that a lot of these inflammatory conditions have got systemic underlying causes. And so we would expect that perhaps the rate of recurrence will be slightly higher. We don't know, because you've still got that systemic inflammatory effect. But I guess we'll just need to wait and see when the evidence comes out.
Right. Thank you so much. I had just another question. So as you mentioned in your paper, you wait for 4 weeks for the conservative management to see whether the conservative management with NSAIDs works or not. And in cases of refractory, in cases with the patient having refractory pain, you go ahead with TAME, transarterial embolization. Is that protocol fixed for every patient? Like, do you routinely go ahead with transarterial embolization after 4 weeks, or does it vary from patient to patient? And if so, what exactly are the determinants which help you decide?
So with respect to shoulder and TAME, I think it's important to have early intervention and a shorter period of following with conservative therapy, or even any minimally invasive therapy, steroid injections or NSAIDs. Early physical therapy in inflammatory phases of frozen shoulder are actually associated with a worsening outcome. So avoiding PT in the early phase of frozen shoulder is important, and we avoid PT for 2 weeks minimum after shoulder embolization as part of our protocol that we have with our orthopedic surgeons. That being said, with knee and other joints where take knee pain and applying TAME, with respect to degenerative arthritis, I mean, I think everybody here would probably say waiting 3 months or even 6 months is not as big of a deal, because the natural progression of knee pain is to progress over time, with, I would say, these periods of troughs and peaks that, knee pain doesn't really progress like this. Anybody who has a mother-in-law knows that they'll tell you they have pain every time you see them. And so every time you don't see them, they seem to be doing fine. No, I'm kidding. So I would say that, by the way, it's no different for American mother-in-laws and Indian mother-in-laws, because I think there's both. Okay, so, but the truth is, I think that duration of time is okay with the other, and we don't rush the other ones either, right? I mean, with plantar fasciitis too, I have plantar fasciitis. I wake up every morning and I hobble to the bathroom, It's definitely better, otherwise I'll be seeing Oz for my embolization. But I don't think there's a rush, right, in some of these, and I don't know how anyone thinks on that too. Shoulder, I think there is a rush. I do think getting that person in earlier, if you're going to consider embolization, is much better. And I tend to avoid treating patients. My magic cutoff is 8 months. So in my head, if I see a patient who comes to me from the orthopedic surgeons and they said this pain started more than 8 months ago, I may try it. I need to be convinced by the orthopedic surgeon that they've kind of waxed and waned and now they're in a bad phase. I tend to turn them down after 8 months of shoulder pain.
I definitely agree with that. I think the way I think about frozen shoulder, at least specifically, is there's a very active acute inflammatory phase. There's the freezing part phase, the second phase, and then there's the frozen shoulder. I feel like when you're in that frozen shoulder where it's already, then you're almost too late. You really want to try to catch it when it's actually active inflammation or starting to freeze to try to get most benefit.
So basically what we get in our practice is shoulder pain since many years. 1 year, 2 years, 3 years. And these are kind of bad patients. That we think that we have done a great procedure, but the pain relief is not there.
Right.
But in a rheumatoid arthritis, we get good pain relief, but we explain the patient that there will be recurrence, we can do it once again, but the best thing is to continue the drugs.
Yeah. Thank you. Thank you, everyone, for your inputs.
I think with, just before we move on to the next question, I think also with shoulder patients, if you've got those patients who have already developed that fibrosis, that have already got some limited range of motion, quite often what works for those patients is hydrodilatation and physiotherapy. And so I think there may be a role for shoulder embolization in these patients who are undergoing these rehabilitative processes, who then get flares of pain during them, just to allow them to have a little bit more pain relief to then progress with their physiotherapy, because I think it's really the physio that helps break up some of those fibrous bands once it's been established.
Before we jump to the next question, I just had a technical question for Oz. You showed some great cases with your plantar fasciitis talk. So what microcatheter do you prefer, and like how's that evolved in your experience?
Yeah, no, thanks, Alex. I'm definitely, and I think the trend probably for most people is going smaller with microcatheters. So I think the cases that I showed, those were with, I think 2.0 microcatheters, but even then with the 2.0, you can see how it's almost the same size as that medial calcaneal. So, you know, I think not to make any promotional shout outs, but I know like Asahi has some really nice small microcatheters, the 1.7, which I've started to use, the Volute. And then I know most other companies are, you know, I know Merit makes it as well, but I think definitely a sub 2.0 microcatheter may be of use, especially for the selective embolization.
Thanks again, guys. Thanks. I enjoyed that. Now, my question is, we're just about to start off with plantar fasciitis. And the plan is to use temporary embolics. The Dockru method is very scary in that you stick a needle into the posterior tibial and stick a cytotoxic drug into the artery. Is that okay?
I wish Yuji was here to defend himself. I mean, the short answer is yes. I mean, I've done it. I will say I've moved away from it primarily because he makes it, I mean, he's probably just much better than I am, but he just makes it very easy to stick the posterior tibial artery in an antegrade fashion. I've found it to not be the easiest thing for every patient. So I've just found it's just easier for me to sort of efficiently stick the SFA every time, you know? And I think in general, I feel more comfortable to your point of just selective catheterization of the abnormal vessels. But I can tell you I've done both, and I haven't seen necessarily one being better than the other, but I also don't have very large samples.
Yeah, great question. Dochu is something that I don't personally do either, but having been to Yuji Okuno's clinic and seen these patients, I think one of the things he really pushes for is correct patient selection, because you don't want to choose the patient with peripheral vascular disease. I think that's a contraindication to most GA procedures and TAMI procedures. But Yuji also does it for decurvanes in patients in the dominant right hand. I've seen that. And he says that the complication rate is extremely low. So at least in his expert hands, it seems to be quite safe.
Any other questions from that?
Thank you for the excellent talks. My name is Dhruv, one of the IRs in Brisbane. I do actually very minimal MSK, and embolization I've never done, but just a question thinking about it. Do you have to repeat these procedures? I'm talking about shoulder, knee, plantar fasciitis, anything. And if you repeat, do you find any difference in the efficacies on the subsequent attempts?
So we have repeated many times. This kind of patients have pain relief for 3 to 6 months, and the pain recurs again. So if the pain goes away for 10 days, 15 days, 1 month, we don't repeat it. But because we were using temporary agents before and now we have shifted to embospheres, we repeat the procedure if the patient has good pain relief for 3 to 6 months and we see the same kind of blush as before, and we embolize them, and they have good pain relief afterwards, long lasting.
We rarely repeat procedures, maybe unless there's a technical reason we think we can potentially improve the outcome. So I would say in a shoulder, we tend to find this more often, where we might under-embolize a particular artery that was responsible for that site of pain. And I would say in the shoulder, we aim to embolize all 6 arteries, if not 5 out of 6, in every case. Where in Yuji Okuno's original data, he really only embolized artery number 2, which was the thoracoacromial artery. And before he published that paper that was published in 2017, I think Oz was showing he was doing embolization before that since like 2011, I think. And early on, he was only embolizing 1 artery. And when we traveled there, it was it was right after that time. So before that first shoulder paper came out. And that's when he was saying, I think I need to go from more than one artery. And so, at that time, and even currently, if you do a shoulder embolization, everybody knows you go in and you want to embolize these arteries, but you also don't want to overdo it. And there are situations where you get out and someone's like, oh, my pain's better here. And you see them in 1 month, 3 month follow-up, but they still have pain on the posterior aspect. I think those are better probably repeat patients, in my opinion, versus the ones who get better and then recur. I've had lower success rates with those types of patients, personally at least, when bringing them back the second time. Yeah. I had a quick question for everybody up here. Maybe we could just go in order. I'll go last because I've been asking the question, which is, obviously everyone here is doing a lot of MSK embolization, and what is a trick you wish you knew when you first started? It doesn't matter the joint, or even with respect to patient selection. It could be technical too, or device. But what is something that I think you know now that you honestly would have liked to have known when you first started? We can go on either side first. Whoever wants to pick up the mic first, Gerard or Oz, then we can work our way down.
You want to go ahead, Gerard? Sure, I'll go first. I think I'll be very real. I almost quit doing MSK embolization after the first 3 months of doing it, and I think one of the reasons was, I think somebody talked about this. We do UFE, it's like 90% effective. You do a PAE, it's 90%. We're so used to like doing something, it's really effective. And my first 3 months of doing GAE, there was a lot of my knee's worse, it hurts more, it's all this stuff. And so I wish I could tell myself, recalibrate yourself. These are patients that, you're not going to get 90% success. And then also the whole concept of overembolization, which I think, again, in embolotherapy, we're always going to stasis or we're trying to kill tissue. In this situation, it's like almost the opposite. So those are probably the two biggest things.
I think for me, or if I'm telling myself, the earlier me, the bigger thing I would say is bringing the patient in for GAE specifically, bringing the patient in for an exam or doing a thorough exam prior to doing the GAE. If you can really reproduce that pain, especially whether it's medial or lateral pain, and really target those vessels, I've found I have a better outcomes with those specific patients. If I'm just going off of a consult and they're telling me this is what their pain is, some patients are better historians than others. But if you're pressing on their knee and they really jump when you palpate in that region right at that joint line, that's a really good predictor, at least for me, for picking good patients for GA.
So we shifted from temporary to permanent embolic agent. So that gave a good clinical percentage, good success rates. That was the thing.
Actually, a follow-up to that. So you switched from, I think, like Oz mentioned and Alex mentioned, it's a big trend in going towards temporaries, but you switched from temporary to permanent, which I have a lot of respect for because we didn't use temporaries for the first 7 years of doing MSK embolization. But so that you wish you had done earlier.
Yeah. So there are many patients who are bad mouthing the procedure because pain returns after a few months. So
it's great.
Probably for me, I think is really spending that additional time setting patient expectations. I think, as Oz mentioned, a lot of us come from doing procedures where we expect technical success 100%, clinical success 90%. And I think for GAE, because it's such a complex process and there are so many different factors involved, I think spending that little bit extra time counseling the patient, telling them that whilst you're going to do the procedure, it might not give them as good an outcome as they think it is. It's not a magic bullet, but it will help improve their symptoms. And I found that my patient satisfaction anecdotally has been much better.
Yeah, Gerard took mine. So I think setting expectations is something that early on, when you first get started, and I think, the first GA I ever did was in 2008, and it was for a patient that the orthopedic surgeon said, just try doing this for hemarthrosis. And I pulled up case reports, there were 3, and He's like, just give it a shot. You can embolize anything. Just figure it out. And I'm like, what size beads do we use? And you know, how aggressive should we be? Should we take it to stasis, et cetera? But in that type of situation, it's very easy to set an expectation for a patient that you don't know how this is going to, how it's going to result. But you can guide them based on some basic principles of what you're doing. The challenge as more and more data comes out.
Last 2 minutes.
Is that, she's right above me now. The challenge as more and more data comes out is as you learn this from, you know, reading a journal, going to ISVIR, learning from this panel, the challenge is you want to take those outcomes and apply them to your practice. And you can't do that. It's just not as easy to do because in his population of patients, permanence might do better in his hands and his comfort level. And in Oz's hands, it might be better with Lipiodol, and Gerard and Alex's might be better with imipenem. And the patient selection becomes, it's just going to be different. There are fine-tuned arts, but setting the expectations that this is what my success rate is. This is how I do typically. My success rate may be higher in PAE than Alex's because I've been doing it 10 years longer. Truthfully, it's not. But the point is you have that. And I think being able to discuss that openly with your patients really allows them to then follow down the track of maintaining seeing you for their knee pain, maybe for their GNA, maybe for their injections, maybe trusting your referral to a surgeon. And so I'd take that as well. So with that, I think, Gerard, are we done? All right, lunchtime. Everyone made it through the session. It was a great job. Thank you to all the speakers. Thank you to the organizing committee for arranging this. And thanks, Gerard, for setting this up as well so perfectly. Thank you, guys.
Thank you all. Thank you all the experts for sharing real-world experience and realistic solutions. Now we end this session and we will go ahead for the lunch with Just Meets Isvir. I'll hand over mic to.
Thank you so very much. Can you quickly come together for a group picture, please? That'd be wonderful. Ladies and gentlemen, give them a nice big round of applause. What a fabulous, fun session. We heard so many interesting perspectives. Thank you so very much. Yes. Thank you. We're going to open the partition and we're going to merge the two halls. Yeah. Just Meets ISVIR, and before that a quick industrial session as well. So we open the partitions and take it forward. Yes. Ladies and gentlemen, we have a wonderful industrial session that is all set to begin. May I please request you to take your seats and settle down. We have with us today Mr. Gaurav Agarwal, a senior healthcare and medical technology leader with nearly 3 decades of experience driving innovation in interventional and imaging solutions. As a managing director at Involution Healthcare, he has played a pivotal role in advancing indigenous next-generation technologies for cardiac and vascular care. At ISVIR 2026, he brings a valuable industry perspective on the future of interventional imaging and clinical innovation. I request the audience here to applaud as I welcome our wonderful speaker onto the dais. Ladies and gentlemen, a nice big round of applause. Come on. Thank you.
A very good afternoon to everyone, and many thanks for the warm welcome and the introduction. So over the next 15 to 20 minutes, I intend to introduce Involution, one of the most diversified imaging, cardiac and vascular solutions company. Moving to my first slide, we are among India's top 1% medical device manufacturers by revenue. Just to give you a perspective on the size of the Indian medtech industry, Indian medtech industry is about $14 billion, but still over 80% import dependent. We have over 13,000 medical device manufacturers, and the average size of a medical device manufacturing company in India is under 40 crores. So we've broken that glass ceiling alongside many other Indian companies, and we are among top 1% of India's medical device companies. We're also Asia's most awarded cath lab manufacturing company. We now have 530 plus installations in India and 20 installations outside India. Last year, as per AERB data, Atomic Energy Regulatory Board data, we became the #1 selling cath company in India in newly installed cath labs. We're also India's top angioplasty balloon selling company in collaboration with a company called Orbis Niche. And we started our stent manufacturing journey in February 23, and we now sell about 11,000 stents a month and are the third largest angioplasty stent selling company, coronary stent selling company. Very recently, in our aim to truly make in India for the world, and in a bid to expand our international footprint, we've announced a strategic global sales partnership with Fujifilm, a very respected 90-year-old, $20 billion medtech giant, where all of Involution's products and solutions will be sold through a joint venture outside India. This is our market reach. We have 530 cath labs installed and over 90 cath labs for which we have orders in hand, which are unshipped, but we have confirmed orders. We have 540 cath labs installed. I'm sorry, not 530. This number keeps changing every month. And we have a fairly wide reach, 275 cities and 25 states. At this point, I'm extremely proud to tell you that out of 800 districts in India, there are 25 districts where we are the only cath lab company truly saving lives and making a difference to heal heart one beat at a time. This is a snapshot of our manufacturing facilities. We are a Bangalore headquartered company. We have stent delivery system and PTCA balloon catheter manufacturing facility in Vizag. Our stent manufacturing facility is in Jaipur, and we have another export-oriented cath lab facility in Vizag and R&D center, dedicated R&D center in Pune. This is a list of forever growing awards that we won. Also proud to tell you that we are the only company globally, medical equipment company globally, to have won the holy trilogy of Good Design Award, Red Dot Award, and IF Design Award. These are all three considered the Grammys and Oscars of industrial design awards, and we won them all. We also won the Indian President Award for National Innovation, one of the most innovative companies, given only to 12 companies across sectors every year, and a few more awards. This is just a quick video of our first generation product. Oh, there's no audio. I'm sorry, this is not half as impactful without the audio, but please bear with me. So in the year 2019, alongside Google, Ferrari, McLaren, there was a young Indian company that went on to win the red dot design for its cath lab. So this is a current product portfolio. We're currently a 3-product company with market-leading presence in all 3: cath labs, stents, and balloon catheters. This is a video of our latest generation cath lab model, but I think in the interest of time, I'll skip it. This is a state-of-the-art cath lab model. I'm also going to be touching upon our latest launch, which is a dedicated DSA lab with rotational angiography and 3D reconstruction in detail. So these are some of our in-house R&D initiatives. The list is rather long, but our goal is to pivot from being an imaging and cardiovascular product company to one of the most diversified solutions provider in imaging, cardiac, and vascular industry. We've already launched the world's second commercially available OCT. We just got approved 3 weeks ago in India. Intravascular ultrasound has already been launched 3 months ago. We also are planning to develop and launch a hybrid Iverson OCT system, which is a single console having both sound and light capabilities with a single switching catheter. We've already launched the DSA with rotational angiography and 3D reconstruction machine. It's right outside this hall. We've installed a live cath lab. We invite you to come see it, give us feedback. We are also launching a 3D C-arm in June. All of this is done in-house. We are launching a OCT-guided CTO crossing device. It's an atherectomy device with CTO capabilities. Radiation protection shield, I'm going to be covering this in greater detail. We are launching one of the world's first balloon expandable polymeric TAVI later this year. Transcatheter edge-to-edge repair for tricuspid and mitral valve repair. Native tricuspid and mitral valve. Shockwave is being launched in March. PVAD, there's a company that we are working with last 3 years. This is a state-of-the-art PVAD with peak flow output of 5.5 liters per minute, less than 20 French delivery system. Also getting launched by Diwali, October this year. PTCA balloon dilatation catheters, proximal optimization technique balloon catheters, drug-eluting balloons, ultra-large stents, covered coronary stents. All of these products have already been launched and are on the market. Our flagship project is a vascular robot being developed in association with Imperial College of London. This aims to completely automate the entire PCI procedure. So sitting like all of us are on this couch, we could be performing a peripheral vascular or a coronary vascular angioplasty with zero radiation and zero fatigue. This will also hopefully get launched by December of next year. And we have 13 patents granted, and our goal over the next 2 years is to have a portfolio of over 100 patents, one of the largest by any Indian medical device company. Some products in focus, this is Premier Neurovascular 30. It's a large panel lab, 30 by 30 centimeter panel, a dedicated DSA system, which has first in the world indium gallium zinc oxide panel, which is known to have extremely efficient low light performance, which means for lower doses, you get much sharper image quality. Also, this is a rotational angiography system with 3D reconstruction. This lab is on display, as I mentioned, right outside this hall, a full lab, full feature lab. And these are some of the key features. We have CBCT technology, so it's a CT integrated cath lab in some sense. 240 degrees rotation, with the ability to park the gantry on the head-hand side, left-hand side, or the right-hand side. AI-MAG Vascular is a proprietary software which allows you to do a digital zoom of up to 6x without any radiation or contrast, and several other features, most of which are familiar to all of you. We've also launched our intravascular ultrasound imaging system with switching frequency of 40 and 60 megahertz, probably the only IVUS worldwide where you can do 150 millimeter of imaging in a single pullback. The fastest pullback speed prevents radiation, prevents contrast, and you're able to do an entire arterial shoot in less than 2 seconds. High resolution, one of the few 60 megahertz resolution systems on the market, and has some very cool AI-driven features where you can annotate, pinch, zoom, and this is one of the few IVUSs that has co-registration. It's a cath lab agnostic co-registration system. So you can have the image not only displayed on your main cath lab monitor, but co-registered. We're also launching a disruptive CT C-arm system in June of this year. This is going to be a 15 kilowatt stroke 25 kilowatt system with cone beam CT capabilities and at a very market appropriate pricing. So I already spoke about this. This will also have the first in the world indium gallium zinc oxide or IGZO panel. Typically panels are made of amorphous silicon which have a 1K by 1K resolution, but this has a standard 2K by 2K resolution. So a state-of-the-art system launching in June. This will also have full coronary DSA and roadmap capabilities, by the way, and it'll be priced under 1 crore. A breakthrough technology, quite honestly. So this is for the first time where we are making a product that cares for the caregivers. This is protecting the hands that heal all of you. We have an ambition to design one of the world's safest cath lab systems with our own radiation protection system which cuts scatter radiation by 98%. We are going to sell it as a standard with our cath labs. Also, this is one of the only systems where you can do a lead apron-free angioplasty, completely lead apron-free. No thyroid collars, no shields, no goggles, and still cut out radiation by 98%. So these are some of the key features. I'm not going to go over them in detail, but I just want to tell you that with this, we will be able to create a system that is able to allow interventional radiologists or interventional cardiologists to do a procedure without any lead on the body. So a truly path-breaking system. We're also launching, as I mentioned, our own intravascular lithotripsy solution in April. This is a truly differentiated system with true 360-degree shockwave emission. It has 3 emitters and 2 electrodes that generate true 360-degree emission of shockwave for pulverization of intravascular calcium. What is also extremely unique is that we have a broad range of diameters starting from 2.5, and every quarter size we have a balloon, which is also a limitation in the current systems. The balloon length is 12 mm, rest of it is pretty standard. The operating pressure is 4 atmospheres, and the rated burst pressure is 8 atmospheres, nominal pressure is 6 atmospheres. This is launching in April. And with that, I come to the end of my presentation. Thank you very much for your rapt attention. And
thank you so very much, sir, for that fabulous session. Thank you. Ladies and gentlemen, we're all set to begin the JES session. We're just opening out the partition so we can have more participants make the most of this much-awaited lunch symposium. I request you to please take a few minutes, just settle down. And if any of your colleagues have been wanting to be a part of it, you could call them and remind them and ask them to be part of it as well. The much-discussed, much-awaited JES session, ladies and gentlemen, just a few minutes. In just a few minutes, we have the jazz session, but we have our music therapist, Aditya Kamakshinada, with something very, very special exclusively for all our delegates at ISVIR 2026. And also a gentle reminder, the party tonight, the gala night, is going to be near the wharf. Apparently many of you found it difficult to find the place. It's the wharf. We are going to be partying tonight at that location. And also this evening at 5:30 p.m. we have the much awaited quiz as well. So make the most of it. Aditya, are you ready?
Yes.
Yes, all right. My wonderful delegates, give them a nice big round of applause. We have an artist with us to take you through a very, very special session. So nice big round of applause so we can feel the energy in the room. We're getting prepped for the jazz session in the most unique way possible. Over to you, Aditya.
Hello, Vanakkam, Namaskar, Vandanam. How are you guys feeling today? I just heard one response. How are you guys feeling today? Can you guys open up your voices? How's the Josh? Woo! Guys, you're a group, so I'm not going to point, oh, that guy didn't shout, this guy didn't shout, right? So we're so used to just being very silent during the workshop, not moving around, not talking much, just listening, right? Let's start using a body. Let's start moving around. Are you guys excited? How many of you here like cricket? How many of you like cricket? Yeah? How many of you like football? Like football?
Aditya, you know, in fact, one of the jazz team members is a huge Shah Rukh Khan fan.
Oh, wow.
Yeah. So, but we're going to give just 2 minutes because other speakers yet to complete their session.
Sure.
My apologies. The Shah Rukh Khan fan, warmest welcome to my country, India. Thank you. Just a few minutes, 2 more minutes.
Perfect.
While they're completing the session, yeah.
Great.
Over to you, Aditya.
Hi guys, how are you feeling? Folks, on this side of the hall, I already gave like an introduction here. Just gonna jump this side. How are you guys? Fine, thank you. So we've been kind of sitting all day, right? We've been listening to a lot of presentations. We've not been moving our body. We've not been using our hands much. So this session is going to be all about movement. I know a lot of people are here sports fans and like cricket, like football, but I want all of you to also become sports people. Meaning I don't want you to just sit and watch sports, but rather become athletes. Can you all please stand up? Can we all stand up, please? Yeah? Guys at the back, please stand up. You've been sitting all day. Please stand up. Yeah? Wow. I can see a lot of heads now. People there, please stand up. Yes. Perfect. So our bodies are very stiff, right? We are always working on the laptop, just taking calls. We are jumping from one device to another. But we are not jumping in real life. And when you jump, what happens? A lot of stress goes away from the body. Right? Just jumping. Right? You're not going to be jumping around too much, but you're going to be moving. Just swaying to beats. Okay? I want all of you to let go of your designations. Oh, I'm this doctor. I'm this profession. Just become kids. Just become small children. Remember how we used to just move around and feel so happy? Just moving around uninhibited without any restriction makes you feel so happy. I want all of you to start rotating your heads slowly. Rotate. Rotate. Yeah? Feel that stretch in your neck. Rotate your arms, your right arm. Yeah? Your left arm now. Yeah, that's nice. Both the arms. Wow. On the other direction. Let's do swimming, guys. Let's swim. We are in Mahabalipuram. Let's do some swimming. Now from side to side. Woo! Perfect. That's some nice movement. From top to bottom. Feel that stretch in your back. Feel that stretch all over your body. Now your shoulders and elbows. Yeah. You guys have a sense of rhythm now. Nice. Wow. Now we are all artists, right? We're all artists. So imagine that your body, or now your leg is a paintbrush and you're going to paint around. Just move your right leg. Rotate your right leg. Yeah. That's it. Write your name, probably your signature. That's my signature. Whoa. Using your other leg, your signature. That's a bit sloppy. Yeah. Now lift your leg as high as you can. Be careful with your pants though. Don't lift too. You'll fall down. Nice one. Now your hips. Rotate. Woo. Nicely. Got that big round. Yeah. The other way around. Yeah. dancers, yeah? Wow. Feeling better? Shake that stress out. Come on, shake it. Shake it fully. Up and down. Up and down. Perfect. Guys, go down, guys. You don't have to be always up. Life is all about ups and downs. The way you go down, you come up. Rotate. Turn around. Look around. Look at folks around. Who's there behind you? Who's there beside you? Who's on the right of you? Who's on the left of you? The world is spinning all around you. You are spinning with the world. Smile as you go around. Nice. Oh, there are so many people. Wow, suddenly you realize you are not alone in this world. You always have company in this world. Now I want you to jump, jog. Guys, you can do better. Come on, jump. You're all doctors. Come on. Push. Perfect. 1, 2, 3, 4. Jump. 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 Clap. Perfect. Everybody in sync. Whoa! Guy at the last, brilliant! Are you feeling out of breath? Breathe it out. Breathe. Shake that stress off. Feeling better? Feel like a kid again?
Ladies and gentlemen, give it up for Aditya Kamakshanada. And in the same energy, we have a wonderful team who's come to be part of this wonderful session, the Jess session. Please give them a nice big round of applause. Cheer for them.
Thank you so much.
Thank you so much for joining us. Wonderful to have you here with us. Please take center stage. It's over to you.
So thank you, everybody. Nice way for ISVIR to make us some exercise before the lunch. And actually, it's good because I did my gym today now, so that's great. Great work, Adi. Thank you so much. So with Mark, we'd like to thank ISVIR for the invitation to have a session. 2 sessions actually this morning. We had a master class and now we have an interactive case presentation. We would like to keep with this momentum of having people be loose. So we want people to start discussing with us on every case. So I would like to make sure we have mic going around and we would like to interact with everybody so that we are not the only one not eating. So, I would like to have Mark to give a small summary of guest experience, and we can start.
Thank you, Jafar. Thank you again for the invitation. So we're going this year in our 20th anniversary, started in Barcelona in 2007, and went around in Europe, in France, in Europe, in the US. Now we're doing one guest in LATAM, in Sao Paulo, early March. And next week in Paris, the guest MSK, which is a dedicated meeting on MSK embolization. So I won't be long. I think we want to discuss all these cases. So we have 7, 8 cases by different experts. So I think we should get started. You should have mics to interact and ask questions. So let's start by your case.
Where is
Your
Osman?
case?
Maybe you can solve your case. Huh?
Okay, so I'll start with one of my cases, okay? So if I can have the first slides on. So it was one of my recent nightmare on call 3 weeks ago. So the history is a 7-year-old woman who underwent endoscopic cholecystectomy in October. Not an emergency. She's an obese patient. She was considered excessively high risk for anesthesia, for acute surgery, so reason why she underwent this treatment. So she underwent this cholecystectomy in October 12th, and then she comes back around 2 months later with abdominal pain, vomiting, right upper quadrant pain, pallor, obviously hemodynamic shock due to bleeding. Heart rate is 100. Pain score is very painful. Hemoglobin dropped from 13 to 9. Abnormal liver function test. Then she, as we would all do now with no discussion, we would send her to the CT scan unit to do a CT angio to try to find if there is a bleeding, where is the bleeding, and what we can do with that bleeding. So this is what we get. We see a large hematoma in the postoperative bed, in the cholecystectomy bed. You can see here on axial views and sagittal views, and you can see already that there is an active bleeding here at the arterial phase. So we do some imaging workup and we try to understand which artery would be the feeder, considering that she might not have an easy access because she's an obese patient. And that's what the best image that we can get with CT angio, which is not bad. You can see the active bleeding. You can see this artery, which is going to the liver. And with careful attention, you can see that this is a right replaced branch of the SMA, which goes to the liver. So it's a right hepatic artery, which is supplying this bleeder. So this is a hemorrhagic shock due to a pseudoaneurysm or active bleeding. As you know, pseudoaneurysm and active bleeding should be considered the same. It's an emergency case, most likely originating from the right hepatic artery. So she was transferred, this CT was done outside, and then we bring her to the angio, and that's what we get. So I don't know if you can see my mouse, maybe not, but you can easily see that there is you don't see my pointer, maybe here I can get it. Laser. Yeah. Okay, so this is the SMA. This is the most part of the liver, right hepatic artery rising from the SMA, and you can see this active bleeding here. So now you're in a position where you say, okay, I have to go after this very, very small branch.
Mark, can we just
sure.
Interact and ask?
Yeah, I think it's a good time for interaction.
So you see that lesion. Who is, by show of hand, who is going for selective embolization, super selective embolization of that branch? By raise of hands. Okay. Who would go for sacrificing that right branch? No one? One person? That's a strong personality. I would tell why that is actually not a bad idea. So the question I would like to have, who would use liquid embolization in this case?
Most.
I promise you 10 years ago we would ask that, the majority wouldn't use liquid. So that's a very good change. Who would use coil embolization? Okay. So who would use a stent graft? All right, so just wanted to raise the
I think it's a good introduction to what we actually did. So we tried, obviously, and you see this branch is very, very, very small. So we decided to go with a 1.7 microcatheter with an O14 wire, and we failed. It was not easy to enter into this branch going through these tortuosities here. We couldn't achieve super selective catheterization. So what's next? As Jafar said, you can do sacrifice and coil embolization or liquid embolization of all this right hepatic artery, which personally I would try to avoid. I would prefer to maintain this artery patent. She had already altered liver function, and she also has portal vein, which is patent. So theoretically, you can sacrifice this artery. Would rather not. So,
comment? Sure. To the audience, if you can't select that vessel, what other options we have? One, we can coil the right hepatic artery. How many would do that?
Coil, hepatic artery, yeah.
And second option probably would be to put a stent graft in the right hepatic artery, excluding the branch. How many would do that?
Stent graft?
Not a single one?
We can discuss after the case each selection. Who would use a stent graft here? 1, 2, 3. Okay?
Who would do direct percutaneous stick to the aneurysm and glue it? Okay?
Wow, that's interesting. And then who would use gel foam? No. Gel foam? You're the only one. No, actually, all of these are valid choices. So that's the problem of IR. So, okay, go ahead, Mark.
Yeah, there is no right solution. I just want to share with you what we did. So we figured out that we wanted to keep this artery patent. So we chose to use a small stent graft, which actually is a coronary stent graft, which is called Papyrus, from a company called Biotronic. I don't know if you have this here. Your fellow colleagues, cardiologists, potentially have them. So it's based on O14 wire, and there are different sizes. The upper size limit is 4.5 millimeters, and obviously because it's designed for coronaries, you have smaller sizes. So we decided to pick one 4 millimeter by 15 millimeter and navigate it through a strong wire, which is the O14 Spartacor. And it was not easy because of this curve. So this is a control after stent graft, but you can see that this curve here is not easy to navigate with this stent graft, which is rigid. We were able to manage and to go there, and we did this occlusion of the bleeder with maintenance of the patent parent artery, and this is only a spasm. So it's a good result. So we are very happy. So I go back home. So, 5 hours later, they call me back.
Yeah, so I wanted to tell you, because that's an experience I already had, and I want to make sure that I would like to know the panel's opinion. When you select balloon expandable stent graft, there is one major problem, and especially in tortuous vessels, is here it was a straightforward shot, so I didn't expect to see anything after this, but your landing zone should be very large. If you say, well, the lesion is small, I can do half a centimeter each part, is not enough. Because there is a redevelopment of the anatomy around the vessel, the stent that you place, and there is almost always a rebleeding if you don't use a long stent graft. I don't know what was your experience in this case, but I have exact similar case before.
So I will show you what was rebleeding actually, what was bleeding in the second session. So to your point, Jafar, I think you're very right when we do pseudoaneurysm in the setting of acute pancreatitis, because then there is all this leakage of pancreatic acids which are all around and will re-rupture the artery at another place. But the thing is that it was not what happened here. The rebleeding was from another source because of a lot of local inflammation, potentially infection. So we bring back her to the CT unit. So this is the CT angio control of the stent graft, which is very nice. You can see here that there is no more spasm. there's no bleeding here, so the rebleeding is not here. The rebleeding comes from very patchy areas around the gastroduodenal artery, and you can see here this arrow. So you really don't really know where it's coming from. You assume it's coming from the GDA here at a later phase. So we go after the GDA. So I remind you that this anatomy is specific because we have most of the right liver, which is taken care of by the right replaced hepatic artery. So you have only one artery to the segment 4 and the left liver, which is not the problem here, and you have the GDA here. So the thing is that we don't really see where the bleeding is. So this is a detailed anatomy. So middle hepatic artery is supplying only segment 4, and that's where we are. So we don't really see what is the target branch here. So the thing is that the patient is bleeding like crazy. It's in the middle of the night, so what can we do here? This is open for discussion. I will show you what we did. We didn't find a single feeder, which we would love to go after. So what are the options here?
So Sanjeeva and then Osman.
I think gel foam is a reasonable option, or you can also use glue or liquid embolic materials, anything you want.
Yeah, I mean, I think you can sacrifice the GDA with coils or gel foam or some combination. I mean, the other thing is, I hate to say it, but there's a huge hematoma also in the abdomen, and it needs to probably be evacuated as well. So surgical exploration is not.
Would any surgeon do that?
I think so. I think if you've done endovascular now twice, I think that's a very reasonable thing to.
And you are not afraid for a recurrence of bleeding because now that compression will go away?
I don't think so. I mean, I think the risk of the hematoma staying there is probably more harmful because of compartment syndrome and.
Any comment from the audience? Anybody would do something else? Do we have a microphone that we can ask other people's opinion? Don't be shy because if you don't do anything, I will name you. So anybody who wants to comment on that, raise your hand. Come here. You would use gel foam from the GDA. Okay.
I would use a liquid embolic agent, which would percolate distally also. Dilute liquid embolic agent.
Well, who was talking?
This guy.
Yeah, go ahead.
Dilute liquid embolic agent like glue into the GDA.
In the GDA?
Which could percolate distally also.
So aren't you afraid of some...
bowel ischemia.
Yeah, bowel ischemia with glue.
Small pinch of salt we have to go.
So question mark, is there any possibility that is bleeding from some other branch?
Well, I think there are possibilities, but I think if you see this image now, which is the next image, you can see a very small dot here, which we thought was the bleeder. But you need also to understand that the time you're doing the CT angio, the time you're doing the patient to the angio, the bleeding anatomy can be different because of pressure regimen, because of the hemodynamic status. So this patient is in very poor clinical condition, and we cannot afford a rebleed because of coagulation status. Reason why we said coil will not work, because we're afraid that we can just do a proximal embolization of the GDA with coils, and we would not go after that because we know that the risk of rebleeding is maybe higher. We didn't select to use gel foam for the same reason, because we were afraid of rebleeding. So what we did, wrong or right, it was in the middle of the night to save the life of this lady, was liquid embolization. That's what we did. And we took off every artery, including, unfortunately, the artery going to the small part of the liver, which is not a big deal. So you can see, I think you can see here the liquid embolic all over the place. It was not glue, it was squid 12. And we were happy because the blood pressure went up, but we were concerned about the secondary condition that could happen, like necrosis, etc., etc. Fortunately, nothing like that happened, and the patient recovered after this embolization. And that's the follow-up scan with no evidence of, and you can see the liquid embolic all over the place here around the GDA. So I think using glue here would be also an option. Personally, I wouldn't use coil, I wouldn't use gel foam. I think we need the right thing, in that case, but by chance. Thank you very much.
So a comment here, please.
The long-term patency of stent grafts of small diameter is not great. I mean, I don't have experience with Papyrus, but I've used GraftMaster.
So the question is about the long-term patency of this stent graft. I don't know, and I don't care.
So that's the thing. It's not necessarily a very long-term patency because it's smaller vessel. The ones, if I had like handful of them, they stayed open. But the thing is that you want to sacrifice it anyway with coil, right?
Exactly,
So,
yeah.
so instead of that, give it a chance for the vessel to be patent. Even though we know that the occlusion of hepatic artery in general, especially if it's coiled proximally, is not a big deal. But I am actually the partisan of saving vessel as much as we can.
Sure. And plus be on dual antiplatelet, just like you're treating.
Yeah, if you can. There is a comment there.
Hi, sir. Thanks for sharing the case. What do you think would be the cause of the second bleeder? Because we never went close to that area with our hardware. So could it be that the antiplatelets that we used during the procedure after stent deployment could have led to that?
I don't know about antiplatelets. The question was, what is the cause of the second bleeding? I think sometimes, at least this is something I always say to fellows, is that post-surgery or post-trauma bleeding, you have to look at more than one vessel bleeding. It's very rare that there is one vessel. It's possible, but so maybe that there were two bleeding. The fact that this vessel, hepatic artery, was replaced. I don't know if you tried to do a celiac trunk check also at the time of the first embolization, but very often you go directly to the artery that bleeds, you close it and you go away. But I would always recommend to do multiple vessel diagnostic angiogram. And then especially in trauma, the fact to have more than one vessel bleeding is not rare. But in my experience, if I put a stent graft, I don't put anticoagulation for the first 48 hours anyways. Especially in this situation, if it goes down, it goes down.
So you don't use tirofiban loading or anything? No. Okay.
So here we discussed with the intensive care doctors about putting, we would recommend double antiplatelet therapy in this small stent graft. Obviously, because of this situation, we wait for 10 days and then we start with this therapy. I'm not saying it will stay patent, maybe it won't. Maybe we go to the next case. So maybe this one or the ruptured, this one?
So I think we will not be able to present all the cases, so you can do one more case and then Osman will take the next one.
Well, come over because if we don't have time, then we can rotate.
We have time, but yeah, go ahead, start your first case and we can change. Thank you. So any last question or comment about the Dr. Sapoval case? Okay.
This one? Jafar? Okay. All right, so this is a 72-year-old man with a 2.2 centimeter left renal artery aneurysm. This is coronal image. You can see here a partially calcified pedunculated aneurysm. On the axial, you can see that as well. Jafar, tell me if you want me to stop or keep going.
So just one question, maybe Sanjeeva. When would you embolize a renal aneurysm?
I think the standard recommendation is when they cross more than 2 centimeters. Some people say 2.5, but somewhere between those two numbers, we choose to embolize it.
We use the same threshold, except if you have a young woman who wants to become pregnant, then we become more aggressive.
So one thing is, for all the aneurysm, visceral aneurysm, 2 centimeter is the cutoff. But the problem with renal, and I think Dr. Morgan can talk about that, but the renal aneurysm, what we are afraid of is not the rupture, because the natural history actually shows 0% rupture. So more than the size and rupture, we want to make sure that we prevent from distal thrombosis of the renal artery. So some key opinion leaders talk about actually treating them independent of the size. So I wanted to see if, Rob, you have a comment on that. Can we give a microphone to Dr. Morgan? The mic is here. Sorry to put you on a spot, but I couldn't do different. Gerard, you are next, by the way.
No, that's quite. I was enjoying the show, but it's a great pleasure for me to actually ask the question that you've posed. We use several things. Clearly, anybody who wants to have children, we'll embolize any aneurysm. In fact, I've embolized a 5 millimeter one in somebody with bilateral small renal artery aneurysms. Otherwise, size, we use 20 millimeters. Obviously, growing or symptoms is another thing. But something that's like this is calcified. The evidence for it to rupture is very low. So, do you leave this? Do you watch it? Do you ignore the threshold on the basis that it's calcified? I don't know. Be interested to know what you have to say.
So that's a good point. And by the way, there is some debate about calcification and rupture. But in the renal, I think that's the most important thing.
Yeah, I think there is another point to take into consideration is the psychological aspect of the patient, because some are crazy about this threat of rupture, even if it's very small, because everybody will tell them, we will do a CT scan in 1 year, in 2 years, in 3 years, and then they get mad about that. So sometimes they push for the treatment, even if you would not like to do it.
And what Rob said also is very important. In portal hypertension patients, especially with the spleen, I don't care about the size. We treat all of them very, very similar. You have a comment?
Yeah, so I may have missed a detail, but why are we assuming that this is a pseudoaneurysm to begin with? Couldn't it be a true aneurysm with a calcified stable wall?
Yeah, no, I'm sorry. It's not a pseudoaneurysm. I'm just using that chart under the word pseudoaneurysm to sort of classify this aneurysm like a...
Yeah, it is an aneurysm.
It's an aneurysm. It's a true aneurysm.
So all true aneurysms need not be treated. All pseudoaneurysms should be treated, right?
Absolutely, yeah. So we were talking about true aneurysm, the discussion. You are right. Pseudoaneurysm, in general, the recommendation is to treat them. Now, there are some studies showing, for example, even pseudoaneurysm post-pancreatitis can shrink with time. I am very scared of leaving those not treated. So pseudoaneurysm should be treated in general.
Definitely. So in this case, if we are assuming this is a true aneurysm, and now we are deciding whether to treat or not.
Yes.
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 Right.
Thank you.
Yeah, so I think all very good points. I think there's some thought that calcium can be protective of aneurysms, but I think Mark also brought up a very good point that the psychology of the patient and the threshold for treatment may change depending on that. So, so here, as I mentioned, we have a pedunculated type aneurysm with a slightly wide neck. And so our strategy here was to try to preserve the renal artery by coiling the sac itself. So just, again, just showing a cartoon graphic here. It's a pretty straightforward case, I would say, but you can see here we've put in a 5 French catheter into the renal artery and then advanced the microcatheter into the sac of the aneurysm itself. And then we proceed with coiling that aneurysm sac with detachable microcoils. Jafar, you want to ask some questions?
Yeah, so can you go back and show the first angiogram? Okay. No, go back. All right. Next. So where is the angiogram before embolization? Yeah,
this
one.
is before.
Okay.
Before and after.
So who would do what Osman did in this situation? Just raise your hand. Okay. Who would do stent assisted coiling in this? Rob, Kratik, Sham. All right. Who would put a stent graft? So the stent graft in this situation is going to cover the inferior branch, right? Okay. So one other question, and Osman, did you show me the endpoint on this case?
Here on the right.
Would you did you put this patient on anticoagulation after that?
This patient, no.
No. Because you think the packing was good enough that there is no risk of thromboemboli?
That was our thought, yeah.
Anybody would put anticoagulation on this patient? No one? Huh?
Anybody would do glue? Would anyone use glue here?
Who would use glue?
I saw some hands. I see one over there.
Who? Anybody wants to talk about glue on this case? No. I think there is not right or wrong. You can. It's just a question of how can you keep the glue in this. So, if you want to do that, you use to balloon protect. Onyx. Yeah.
You can
Onyx
put a
has
coil
another-
first. You can put a coil first, a framing coil, and then inject onyx or glue inside. It stays inside.
What do you think about that? As I said this morning, the use of coil in addition with onyx is much more common, especially in endoleaks. Would you do that, like put 1 or 2 framing coils and then fill that with onyx?
No, Sanjeev is much more brave than I am, for sure. But no, I mean, I definitely understand that that's a viable way to do this, but I feel much more comfortable placing detachable coils just because I think you can pack it and control it.
So one question to the panel and then to the audience. We have all heard about coil density. Who cares? Do you care?
I don't. I used to when I first started doing them, but yeah, not as much anymore.
How about you guys?
I do care.
Do you calculate that?
I don't calculate that, but I make sure it packs well.
Yeah, so that formula online that you calculate how much coil, you don't use that. How about you, Mark?
Sorry. I would not calculate because I'm too lazy. But I would try to pack as much as I can, which is always a trick because then the last coils is the worst thing that can happen.
If it was a bit proximal to where it is, this aneurysm, maybe, just near the bifurcation of the renal artery, what would have your strategy been in that case?
If the aneurysm was closer to the bifurcation, you're saying?
A bit proximal, say 5-6 millimeters proximal to where it is.
Oh, proximal. So proximal to the bifurcation completely.
Or no, just at the bifurcation where you see that bulge.
Just at the time, just at the origin of the bifurcation.
Oh, I see.
Which means that you can probably have a coil coming and block both sides.
I mean, I think it really depends on the neck. With this neck, I feel comfortable putting just a microcatheter in and being able to coil it. But if I had any concern, I would probably then do stent assisted.
What would you do?
In
Balloon
a
assisted?
Same aneurysm proximally, we have used a flow diverter and put a few coils because that's a.
So you brought the flow diverter
Coil,
discussion.
coil.
That's a very interesting discussion. You want to make a comment on flow diverter?
Well, no, not on flow diverter. I would like to ask the audience, how many of you would send this case to their surgeon?
How many you sent to surgeon? Do
How
we
many-
have a surgeon in the
How many?
audience? Any
How
surgeon?
many?
No. Okay.
How many of you would find a surgeon to do that kind of case? Because for us, in some case, we would prefer to refer it for surgery because the anatomy is too complex. But when we try to find a vascular surgeon who would be confident to do this, it's not easy because there are very, very few guys skilled enough to do this kind of surgery, which is intrarenal surgery, like autotransplantation type of thing. So I just wanted to raise that point, and apparently here you wouldn't get that as well, right?
And it would become even more complicated if it was a single kidney. If you have this problem in a solitary kidney, I am just now looking after a patient who has a large AVM and a solitary kidney. So similarly, of course, if you have this problem in a solitary kidney, then at any cost we have to try and preserve the artery, with of course a risk that we may not be able to preserve. We may lose the kidney during the procedure or immediately after the procedure. That counseling is very, very important.
So if this aneurysm were to be present at the bifurcation of the main renal artery, flow diverter may not be the best option. So what would you consider at that time?
We may think of doing a stent-assisted coiling or a balloon-assisted like the neuro guys. But it is easier said than done, and all these things have to be kept in mind.
Considering the aspect ratio of this aneurysm, or maybe if the neck was a little narrower, couldn't we just get away with the pushable coils? Why use detachable coils here?
Question to audience. How many would use pushable coils in this case? Raise your hands.
Pushable coils.
Okay, there are only 3 people. How many would use detachable coils? Okay, now you got the answer.
So I would like to just have a follow-up case on a renal embolization because it's very interesting and it's totally by accident that I selected that. So this patient was referred to me for splenic embolization. The patient had a splenic aneurysm and the dictation didn't talk about what we saw, which was a renal aneurysm. And so you can see here the renal artery aneurysm. So we discussed with the patient and we did the angiogram, showed the splenic aneurysms and this renal. And we discussed and patient preferred to treat the renal first, then the splenic. And I think it's a fair decision. So this is a little bit like the case you were talking about, more proximal. The neck is larger than what Osman was showing. So what would you use? Maybe Mark, then Sanjiva, then Osman. How would you treat that?
I would really look carefully at the 3D imaging, whether it's CT or cone beam, before to make any decision. It seems to be that there is only one entry and one exit.
Yeah.
But the entry seems to be very large as compared to the exit. And the neck, I mean, the part of this artery feeding in seems to be short. So I would consider a stent graft, but not easy.
Stent graft, yeah. So I will show you. So go ahead, Sanjiva.
So I think I agree with what Mark said. The proximal segment of the artery is too short for a proper seal with a stent graft. I would probably consider using just a bare stent and a stent-assisted coiling of the aneurysm.
How about you, Osman?
Yeah, that's what I was going to say. I probably would back it up with what Mark said. I'd get some really good 3Ds to understand the best angle that opens that up.
So you see, from that aneurysm, I could catheterize the aneurysm and went to the outflow. And so you can see very well where is the outflow of that aneurysm and where is the inflow. So we decided to go for bare stent-assisted embolization. Anybody would do it differently? Like any other idea we didn't discuss? Balloon occlusion and percutaneous puncture with liquid? Yeah, who would do that, by the way? It's actually a smart way of doing it. Anybody would do that? Because you have to turn the patient posteriorly and do it a little bit more difficult.
Raise your hands, how many would do that? Okay, not a single person.
Okay, so
Jafar, question for you.
Yeah.
How much kidney would you sacrifice if you did a stent graft here?
That's what you see that we would sacrifice, which is probably 1/4 of the kidney. I don't know exactly, but as I always say, I am the partisan of saving as much as we can.
Yeah.
Now, one thing Mark said that is very important. I think is very important when you have a risk of sacrificing the renal artery, talk to a surgeon. Because contrary to what we think, if they are a skilled surgeon, doing a patch repair is not that difficult. And some transplant surgeon actually, they take this kidney out, they treat it and put it back. So again, if it was my kidney, I would prefer to save it instead of sacrificing it with colembolization. So it's important to think that there are options. Of course, when we have a hammer, everything looks like a nail, but we don't want to be like that. So be careful on that. So what I did actually was very easy, place a stent. You see the stent there, went with a large 2.8 prograde into the aneurysm, put the coils, and you see the stent is in the other vessel, not the aneurysmal vessel. And we ended up with this image. I think I was satisfied with that, and so you can see the view of the packing and the stent. So the patient went home with this image and came back a month later for a splenic artery aneurysm. Patient was doing good. We did the splenic artery aneurysm, and as a result, the patient went home and started to have pain. It's very normal for splenic artery aneurysm patient to have pain, but this pain was a little bit different. The pain was posterior and in the back, in the left side, and I'm usually not used to see that. Usually the pain in the spleen is higher and is diaphragmatic pain. So we brought the patient back and realized that actually there is an infarction of the spleen, the kidney, a month after. And so what has happened here, I have no explanation why this has happened, but the explanation is that the stent, you can see, actually has migrated, and you can see the stent actually here in that image. You see that here? So the stent migrated, which is extremely unusual. But the lesson I learned from this is that, well, what was my mistake there? Anybody has a comment there? What was the type of the stent? It's a self-expandable stent. The length was, I think, is 3.8 something. I am not sure though. I have to check that.
Which stent?
Let's see. Get a mic, please. You go ahead.
Yeah. One other thing. This has happened 1 month after splenic embolization.
Yes.
So after splenic embolization, you may suddenly have a rise in platelet count. That may be one of the things which we should consider in this.
Yeah, that could be an explanation. But I probably did something wrong to get to this point anyways. Any other comment?
Stent could have been slightly oversized. Oversizing of the stent.
What?
Sizing,
That's
diameter,
exactly.
diameter.
So I always went with the idea of that study published by Blue many years ago that renal artery stenting should be 6 millimeter or above to reduce the occlusion. In this case I decided to put a 6 millimeter stent, and that's my mistake. In those cases you have, especially in a normal vessel, because the rest of the vessels are normal. Young patient, normal vessel, you have to oversize your stent. That's in my opinion. Anybody comments on that?
You have to oversize, definitely.
Yeah. Anybody would think, Rob or Gerard, what size would you use?
Jafar, did you use anticoagulation or double antiplatelet therapy after that?
The first month, yeah.
Yeah, only first months.
Yeah.
So okay, so maybe
for
longer.
the spleen, I didn't care after that.
No, of course, but
Yeah.
for the renal stent.
Rob?
I may be wrong. Sorry. Go ahead.
Well, it's easy for me to say in retrospect, but a bigger one than you used. But 6 millimeters seems big enough for that kidney.
6 millimeters seems to be large.
Yeah, I would have thought so.
But still was not large enough to go distally.
No, I'm
right?
surprised if you would have had to use a 7 millimeter, because it's not actually the main renal artery, is it? It's sort of.
Yeah, you are afraid of stenosis at
Yeah.
the tip of it. So it's something to keep in mind, but I would say there is a risk in a normal person, young patient. So an atherosclerotic patient, you don't care, because you know that there is enough resistant sclerosis in the vessel, but in normal vessel, you have to be careful. Any comment?
The normal renal stents that we put for atherosclerotic disease they just go into the renal artery a little bit. As we go distal, closer to the bifurcation, towards the hilum, we have to keep in mind that these stents are going to act as embolic agents over the period of time. This is what has exactly happened. I know I have an experience with one or two flow diverters. There is invariably loss of renal parenchyma, and we definitely get some infarcts here and there.
Yeah. Kumar, do you have a comment on that? I see you are looking at it, but no? Wouldn't you use larger stent? So you would have probably done the same? All right. So
Jafar, one point. Did you do control angio to make sure that the stent actually migrated? Because on the CT, I think it's not so easy to see.
That's a good point. Actually, I have a follow-up CT on this patient, but let me show that.
Jafar, what would you have done in retrospect then, if you did this case over? Would you do balloon-assisted coiling?
No, I would have done the same.
Same thing.
Yeah. So this is the follow-up, I think. Yeah. And this is 3 months follow-up. So the majority of the kidney was, the area that was thrombosed came back, but that's one thing. So Sanjeeva, you go for your first case. Any other question or comment? Yes.
Just a comment. You treated the aneurysm successfully, good result. You infarcted a little bit of kidney, not great, but certainly not a disaster. So it's a good result.
Yeah, no, I don't feel guilty. I just want to know what you're right.
Don't be too nice to this guy.
Yeah, I think you were just unlucky, Jafar, because the 6 millimeter stent, particularly for that distal in the renal artery, would be the right size. I think the only other comment that didn't happen in your case is that we should be careful because the renal arteries can undergo spasm. And so if you see spasm, you need to think, I actually need to give some GTN or perhaps size my stent a little bit bigger because the artery looks smaller.
Sorry. So actually as one discussion for FMD patient, I used to use always 6 millimeter. Then I talked to some key opinion leader like Alan Matsumoto and Fritz Angel, and they say they usually go to all 7 millimeters in some of those lesions. So this discussion between 6 and 7 millimeter for even younger women is very interesting, but I was so scared of going above 6 millimeter, and there are some people actually think that 6 millimeter is the base for the origin of the renal artery. But I totally agree with you. The risk of a spasm, especially in young women, is very high. So what do you use, by the way? 6 or 7? 6.
Sorry, I just have a quick question. What about the distal end of the wire? Did it go too deep in and it caused some spasm or perforation?
The question is, did the wire go and perforate the renal parenchyma, the wire you used to place the stent graft or stent?
So that's a possibility, but when I placed the stent, there was no problem at that time. The problem started a month after the second embolization. So if it was like the next day, I would say, yeah, probably there was some technical problem. But what was really puzzling to me was the 1 month delayed complication. Because at the time I did the embolization of the spleen, the patient was doing great, labs were good, everything was good. So it happened right post the splenic artery embolization. So very puzzling.
So when you did the splenic aneurysm embolization, did you take a check run of the renal?
No. After the second embolization, I didn't check on the renal, no.
Okay, this is a very simple case. I think most of you would have done this case already. The 75-year-old woman with diabetes and a cavitary pneumonia presented with massive hemoptysis, and a CT was performed, and CT scan shows, as you could see very clearly, a pseudoaneurysm of the superior lingular artery. And what would you consider? Probably most of us do angiogram and embolize it, right? So this is the angiogram, which did show the aneurysm, and selective injection does show the aneurysm. You can see the aneurysm, very irregular aneurysm. It was not easy to select it, but at the end we got it selected. So this is what ultimately the aneurysm is here, which is already ruptured. You can see a small projection into the bronchus there, but there is active bleed going on. You can see the contrast into the trachea going up here. So she was actively bleeding at the time of the angiogram. So this is not another pulmonary artery. This is actually the contrast going into the bronchus. So what embolic materials most of you would use? Coils? Anybody would use glue? There's one guy, 2, 3, 4. Okay. Anything else people would use? Any flow diverters, people? No? Stent-assisted coiling, covered stents?
So let's discuss the flow diverter, because I think it's something we missed to discuss from last case. How many of you actually, I know that Rob, you have talked about that. How many of you actually believe on flow diverter for peripheral? Because you know the neuro is usually 4.5 and above. What is your, who would use flow diverter in aneurysmal treatment? Mark Sapoval?
Yeah. I have used one hepatic artery, and Murthy and I used one for splenic artery before.
So I will use it when they are smaller, but when the larger one, I wouldn't. Shams, you have something to say?
See, flow diverter we use in selected cases. One could be depending on the morphology. If the course of the artery is very acute, tortuous, then we can consider. Second thing is, if there is no active extravasation, then only we'll consider flow diverter. So many of us, we also do neurointervention. The experience we got from neurointervention, that's what we'll be applying here.
Yeah, I think for a smaller vessel is good. But the other thing is that when you use flow diverter, you use anticoagulotherapy with 2 different medications. And especially for aneurysm, I have realized that we don't close those aneurysms. So I am actually going only on some smaller hepatic arteries, or sometimes in the situation where you have to sacrifice a major vessel. But if their size is around 5 centimeters, I would use it. Otherwise, I won't. Anybody, I see that table, there are a lot of key opinion leaders. Any comment on that? Rob or Philip or? Yeah, that's for rupture aneurysm. You are totally right. We don't use it for rupture aneurysm.
I mean, I've tried them a few times in aneurysms, and the aneurysms still are perfused. We have to bear also in mind the cost. You know, they're much more expensive than a few detachable coils.
That's a good point too.
Yeah, given that this is ruptured, would that make a big difference in selection of the embolic material? Would you still use glue? People who said glue. Okay, good. Anyway, I wasn't strong enough to use glue here, so I said, okay, use coils.
I think one you could use, you really could use EVOH-based agent here. This is what we would go for. Okay. We would go for squid or onyx because it's very easy, straightforward. You don't really care about sacrificing 1 or 2 additional branches, and it's fast. The only thing is that you need to prep for that ahead of time because you need to shake it. So, I mean, when you bring the case from the CT, you have time to prep everything, and that's what we would do. I think the one thing which is very difficult in that case is finding the appropriate parent artery. And usually we use 3D angio, but it's sometimes very tricky. I saw that you did this brilliantly, but you can comment on that as well, maybe, right?
Yeah. So I went ahead and coiled it. As you could see that coiled the aneurysm, coiled distally, coiled proximally. So that my intention is it won't recanalize. It's a ruptured vessel. I want to have enough protection both distal proximal. It won't refill backwards or frontwards. So this is a post-injection, and I thought I did a good job. How many of you agree that I did a good job here? I'm sure all of you agree.
I think you did an excellent job.
Thank you.
It's
so
beautiful.
How many of you follow this patient after this? Okay. So like you guys follow, I followed this patient. And 3 days later, this is how it looks.
Go back to the previous image. And go to the next compact one. Go to the next one.
It's a very good compact coiling here. It's a very nice compact. The next image you can see is no longer compact.
What coil did you use?
You want to tell?
Yeah.
It's a non-fibered penumbra.
Bare platinum. Yeah.
Penumbra pod packing. Initially helical, then pod packing to pack the aneurysm sac, and proximally again, regular helical coils are used. So, what
let's
would
just-
you do now? So how many would you go back and check it? She's not symptomatic. She has no problem. She's very happy. The bleeding stopped. She's doing well.
Are you worried that she might cough up the coil?
How many of you are worried about it? Okay. So if you're worried, what would you do? You will do repeat angio. And if you do repeat angio, would you go back and coil that? Okay. How many of you would you do that? Okay, so 1 or 2 people.
I think.
So this patient, remember, is asymptomatic, has no problem at all.
But what's the reason for the aneurysm?
How about you by Rob and Gerard? You had a comment?
I would first ask what is the etiology of this pseudoaneurysm? Is it an abscess? Is it tuberculosis? Is it you have an idea of the reason for this aneurysm?
So this patient has pneumonia, so infected aneurysm here. She was not positive for tuberculosis, probably. It's mostly pyogenic.
So Rob, then Sham, and then Aaron.
So the coils moved, but the patient's not bleeding anymore. So, I mean, we're doctors, we treat patients, not x-rays.
Great comment, great comment. Sham.
Yeah, considering that this is likely to be a mycotic aneurysm, we have to be more serious because even if the patient is not bleeding, we have to proactively block it. Perhaps I would do a contrast enhanced CT at this point of time to understand the morphology.
Okay, Aaron?
Aaron?
So the basic concept of embolization has completely been considered: distal embolization, proximal embolization, and neck. So looking at just at the middle part, I'll not be worried, and possibly I will not evaluate.
Yeah. I'd be a little bit concerned about this because ruptured pulmonary aneurysms have a mortality of 50%. So they're a very serious disease. And theoretically, you might not have completed your treatment, particularly if it's mycotic. So I would be keen to retreat.
So you would intervene or you would not?
I would intervene.
You would intervene, okay. So the problem with intervention is that the vessel that is supplying the aneurysm is completely embolized. You can see this picture up to the level of the main pulmonary artery. We already coiled it. There's no purchase for you to go back into that one and distally coiled. So either we can do a stent graft or call a surgeon, go and resect the lobe. That's another considerations. But as a good thought, if there is a space, for example, go do angio, try to probe it with a microcatheter, microwire. If you are able to get in, you could pack it well, yeah.
As Rob said, this patient is asymptomatic. I understand what Gerard is saying, but certainly I will not go back with a catheter where my chances of going alongside is quite small. An asymptomatic patient, I'll do a dual energy CT to reduce my artifact and assess if there is any risk. I feel that the aneurysm is still in place and is enlarging, then I would do what Gerard has said.
That's exactly what we did. We thought getting back into the aneurysm sac is going to be tricky. We got a CT scan. We did not see any contrast in that area. I don't have pictures. The vessel is still completely blocked proximal and distally, and we thought, okay, we'll stop it, do nothing here. After a week later, we got another chest X-ray, and this is how it looks now. So now what would you do?
Shams, you have a comment, I think.
Huh?
What? You know the case, yeah. Okay.
If you know, don't tell. Tell me what other people talk. Go ahead, Shams, you have a answer.
So JV, I think the patient needs bronchoscopy.
Yeah. So she's not bleeding, but the coil is in the tracheobronchial tree.
Sham?
No, you already told, I think.
What is
No, it is showing the anatomy of the bronchus.
Yeah, very nicely, right?
Yeah. It's like a coil.
So the question is, would you retrieve the coil, go put a catheter into the bronchus and retrieve the coil, or would you ask a bronchoscopist, go and retrieve the coil, or what else would you do here?
My question here is, that what do you think has happened?
You're saying on one side that it is totally thrombosed. There is no leak. Now, why is it moving?
So I think what has happened is, if you see this picture, there is active contrast extravasation from the pulmonary artery to the bronchial tree. So that rent, the fistula, pulmonary bronchial fistula is present. Even though I packed it, the fistula gave away and the coils just migrated into the bronchus from there. They're not filled with blood because you coil proximally and distally, so the blood is not coming, but each time you breathe in, breathe out, the fistula is fed and the coils are migrated back into the tract. That's what my, at least hypothesis is. So what I thought was, okay, she's asymptomatic. I called proximally distally, and I called our pulmonologist and told him, okay, listen, don't pull the coil, go into this bronchus, cut the coil here and take it out. Let us not unravel all the coils in the pulmonary artery, and I stayed standby to see if she bleeds, I can go back and do embolize again. We talked to cardiothoracic surgeon, okay, if she bleeds, you need to do pneumonectomy here now, there's not much I could do there. So those are the considerations, and luckily all he did was just cut this one, take the coil out, this coil remained as it is, she never bled after that.
So, Sanjeeva, one question. Have you thought about something like this? You know, the first thing I told you when you talked about this, have you put a stent graft, or would you put a stent graft in a, not an infectious mycotic, but in general, a rupture in a bronchial artery?
So I think in this case, because it is mycotic, I would not use a covered stent. But I have used papyrus stents in the pulmonary circulation to treat untreatable pulmonary AVM. It's a very short neck and AVM. Instead of losing entire artery, I have put like 6 cases where I have put the stent graft, and they remained patent even after a couple of years of follow-up there. So we have done that.
Anybody? Yeah, go ahead. Can you give a mic?
Hi, so this actually happened to me before, but my cause was cancer, and the patient coughed out the coils a few years later. We tried to stent the pulmonary artery after that. It was a horrible idea, and it's really because the configuration of pulmonary artery is conical. The stent migrated as well, so I don't think stenting of the pulmonary artery is the best idea also.
So one consideration could have been, I could have asked a bronchoscopist to put a stent graft in the bronchus to keep the coils away, not to come back again. Anyway.
I had a similar experience. It was, we published this case, not for this, it was a Bessett's variant with thromboembolism. It was an aneurysm of the pulmonary artery. We put a big coil, and the aneurysm was taken care of. He presented on the follow-up that aneurysm and that segment was reduced to one small cyst. But we had a coil sticking into the, migrating into the trachea. The mistake that we did after that, like Sanjeev was telling, is that I asked my bronchoscopist to try and pull it. It just kept elongating, and finally, we just had to leave it. Patient was asymptomatic, he's doing well, but exactly a replica of this.
I had a similar case, but not in the chest, actually in the GI bleed, and I think if you scope post-GI bleed, most patients you can see the coil. If you happen by accident to pack the aneurysm, pseudoaneurysm, because there is a pseudoaneurysm in most of this bleeding. So I had a case like this at the University of Iowa when I coiled, patient was doing well. The next day they did a scope and they called me and showed me the picture of the coil into the stomach and say, can I remove it? I said, please don't touch it. So those type of lesion will be covered with normal gastric wall, and so we had that follow-up in that patient and everything was good. So this can happen if you do early scope on those patients. You have a comment?
Yeah, I'm saying forgotten wires also can be a problem in the vascular tree. So we actually have cases where the coronary wire was broken probably a few years back, and it has worked its way through the aorta into the neck, and she presented with not a pseudoaneurysm but a swelling. And when the neck surgeon tried to take it out, we had to tell him, no, just be careful. Nothing happened to the patient. So these things do happen. And similar case, we actually ask our bronchoscopists to deal with it through bronchoscopy. If I'm correct, they have actually put a stent there. That's why I said he's going to cough out.
Great point. Satish?
maybe not in this case, but in TB, we see that a lot of time it is the bronchial artery is also supplying, if it's a fistula. So when you see these Rasmussen's aneurysms, many times it's also the bronchial artery that's supplying. So we, most of the time, will end the case when we embolize to also do a bronchial artery study to make sure that there is no communication. Could have been in this case that that's what pushed the coils, one. That's number one. Number two is, what does your pulmonologist feel about leaving a bit of foreign body in the airway, because they are very touchy about even having small objects, they go and retrieves because of the infection risk. So what about antibiotic prophylaxis and all that stuff?
I think in this case, they went and removed the coil or in the bronchial tree.
Mark?
So just a final comment on that case, great case. I would use directly onyx or squid here, because I think it would avoid all these problems with migration. It would occlude things in 1 second, and would be also cost saving, because then in that case, I don't know how many coils you had to put in and the time, room time to achieve these results, which was really great. So I would put squid 12 or squid 18 here.
Mark, this patient has a fistula between the pulmonary artery to the bronchus. Would you be worried about onyx going into the bronchus?
No, I think if you have a small leak into the bronchus, I don't think it would be a big deal.
The patient will cough it out.
Yeah, maybe, but I think it's a life-saving thing, and I wouldn't be concerned about that. Maybe I'm wrong. We've done a lot of these cases, but not in my memory, not with a fistula, as you say.
The only problem,
if there is no fistula, I would directly go for this approach. If there is, I would still do that, but maybe with more concern.
the only problem with fistula and onyx is that the patient will smell garlic for the rest of the...
They do
you
smell
know,
garlic anyway.
that would be a problem. All right, Shams?
Yeah. So, Mark, you mentioned about onyx. I can give you an example of similar onyx which we placed in the liver, not in this location. However, it's pretty similar because the movement which Sanjeeva was mentioning, with every movement, things move. And you are alluding to the fact that possibly the movement made the coil unravel and went up. And onyx will not. But we had a very complex biliary leak in a patient. We tried everything. We tried like coils came out. We tried ablation, didn't work. So we tried onyx also. And onyx made the same fate. So onyx also, after hardening, it behaved much like coils. So I think onyx would have faced the same fate, just like these coils. And yeah, the only advantage would be like we would not see in the X-ray, it would have been coughed out. And this X-ray, we had to go in and deal with the coil, I guess.
After that discussion, I want to know how many people now would use glue in this case? Yeah, because I think that's a very good thing. Because I think sometimes we did that, I guess we do a survey of people before the case and then a survey after. And I think that's one case where glue may come victorious.
Glue would be a good option. I think so. Okay, so another case. So it's an 80-year-old man, history of prostate cancer. You need to read this carefully because it's very important for the story. So prostate cancer treated by radiation therapy and surgery, very severe surgery, total pelvic exenteration, Bricker ileal conduit, left nephrostomy, left double G urethral stent, and left colostomy. Come to the emergency department with a brutal rectal bleeding through the stoma, because he had stoma anastomosis, massive hematuria in the Bricker conduit, which is well tolerated. So the patient, so we do abdominal CT scan with and without contrast, and there is no active bleeding. But we find a urodigestive fistula. So the patient is referred for urology clinic for surgical revision or specialized advice. This is where we are. Unfortunately, the next night, hemorrhagic shock with severe bleeding, 6 ml of hemoglobin as compared to 9 before. So they call us and we do an emergent CT again, and that's what we find. So this is the left kidney where you can see that there is this double G stent, which is the white line here. Oops. Here. And this is contrast And these are blood clots all over the pelvis of the kidney pelvic cavities. So we see there is severe hematuria. We go for analysis of the CT angio. We don't see active bleeding. We see this image, and we go further. We try to understand what's happening, and we see here that there is potentially a pseudoaneurysm here around this place. So we look for a pseudoaneurysm, and we find a pseudoaneurysm of the left common iliac artery in contact with the ureter, which does explain the urinary bleeding. So suspicion of left arterioureteral fistula. So these are other projection of the CT with the clot in the kidney, and here it's always the same place where the double G catheter crosses the artery. So we take this patient to the IR suite. We do local anesthesia, left groin puncture, retrograde puncture of the left common artery, and long 8 Frenchies, and this is what we see. This pseudoaneurysm, which is actually the place where the bleeding started. And you can see exactly at the junction between the artery and the left ureteral double G stent. So we put a stent graft. So what can we do? Surgery, coil embolization, covered stent, maybe we can open this for discussion. Surgery, I think, is maybe not an option because of the very complex anatomical situation. So who would try to coil this? Who would try to do something else?
So, go ahead. Yeah. So stent graft. Who would do a stent graft here? Majority. Who would do a stent, bare a stent-assisted coiling? Why not? It's cheaper. Why did you say no? One, yeah. Okay. So, how many people would use glue? Mark, why didn't you use Onyx on this one? So, any comments? Any other technique you would recommend that we didn't think of?
I had exact similar case. No, so not about the treatment, because I think the most sane people will choose stent graft unless you really want to try something different. I had a similar case which the patient was bleeding, hemoglobin kept dropping, she was completely pale. One of my colleagues did an angiogram, nothing. CTA, nothing. Angiogram, nothing. It still kept bleeding. 12 hours later, we were again called. We did another CTA. Maybe something showed up, nothing. Another angiogram, nothing. Then I said, you know what, we need to do something. I did the angiogram and set everything up and called the urologist to say, pull the stent out. And the moment we pulled the stent out, then we saw this. Otherwise, till that time, nothing could be seen. And then the whole ureter was full. And we did a stent graft. And this is about like 6 years out. And she's still doing really well. And she still keeps getting her nephrostomy exchange every 3 months. So we meet her and have a very good, strong follow-up.
Yeah, I think that's a good point. Sometimes the double J stent would make the sealing for some hours, and then it would reopen. So my next question to you guys, everybody would use a stent graft, and this is what we did. The question is which size, which diameter?
Mark, I think somebody has another idea.
Yeah, go ahead.
Yeah, I think some similar scenario, especially in a setting of a cancer, it's communicating with the ureter. So there is a septic focus all the time. So stent graft always has that risk of getting infected. So because we have been caught before, we'll try to exclude surgically. If it's not possible, then you might do some coil embolization, proximal and distal, and at least try to completely exclude the diseased part. The surgery is probably a better option if you can, but in inaccessible areas, covered stent can be tried, but we always need to have a very low threshold to be prepared for reoccurrence of this situation, especially if there is a communication with gut or urinary tract.
So you would say you sacrifice the artery?
Yeah, sacrifice and try to do
so the iliac artery,
extra anatomical bypass with a vein graft or something like that.
So that brings me actually to one question, and I have my opinion. I want to see how people think about that. The fact that don't put a stent graft or a covered stent in a potentially infected situation is something comes very often. But
this is crazy. This is crazy.
Yeah, who actually believes that?
I think we don't care. I've never seen, I mean, in the audience, has someone seen a complication with a stent graft placed in an infection territory?
I think the
clearly related to that, because I don't think it really matters.
I think it can happen, but it can happen also if you put a coil in that area, if you put anything else. You had a comment on that?
We have seen when we have done a similar case like this, it was a small communication of the bowel. And promptly patient developed infection, developed another pseudoaneurysm from the edge of the stent graft. Again, I lined up with another stent graft, covered with antibiotics, had a third pseudoaneurysm. Then we occluded the artery and did an extraanatomical bypass. So whenever there is a communication of hollow viscous, now I'm very skeptical, we'll go for an occlusion with some sort of a bypass.
Yeah, so one thing, and again, Rob, I don't want to put you always on the stage, but, one thing we see, let's say that you have a aortoduodenal fistula, that happens. What is the standard of care right now? It's not surgery anymore. They put a stent graft very often. Now,
here we have changed the strategy of late.
Yeah.
In case we have to put a stent graft, then we think of doing a laparotomy and try to cover the stent graft with momentum. Whenever we treat any pseudoaneurysm in the aorta, this is our strategy when we have a communication with any hollow viscous. So it doesn't end with the stent graft. Follow it up if it is a thoracic, then go for a limited thoracotomy or one of those video thoracoscopic surgeries with laparoscopy. Try to harvest the momentum and cover the stent grafts.
Okay. Rob, and then there is a comment.
So in my hospital, we wouldn't worry that this is a potentially infected field. I mean, this is like any artery in a potentially infected field. We would use a stent graft and maybe cover that for sort of an indefinite period of antibiotics or not. So in this case, I'd use a self-expanding stent graft, oversized by 2 millimeters, and hope for the best. I'm sure this is a complicated case, so you're going to tell us that you put a stent graft in and there was repeat hemorrhage.
One last comment, because we have to finish by 2:30. Go ahead.
What we've seen is that the organisms responsible for mycotic aneurysms is different in the Western versus in India. Mainly we have tuberculosis, we have fungal, and salmonella. These are the three main causes for a mycotic aneurysm. And these are certain circumstances where you need long-term antibiotics. As far as the West is concerned, it's staph and streptococcus. Yes. So there you can give antibiotics and then decide to put a stent graft.
That's a great point, by the way. Yeah.
Okay, so I was asking about the size, so I will, because we don't have so long time just to discuss, but we decided to put a 10 millimeter. As you can see, the common iliac is relatively large, so maybe 10, maybe 9, maybe 11. So we put a 10, and we get no result, because 10 is potentially too small. So what you do with a 10 millimeter balloon into a 10 millimeter stent graft, you can oversize. So you put more pressure, or you change for a larger balloon, and this is what we did. And it happens often, especially if the artery is calcified, because then you cannot have a very good wall apposition. So we did oversize, and we were successful by excluding the pseudoaneurysm. And to remain a friend with Rob, patient did well, and then he comes back for bleeding again.
So Mark.
But that's a very interesting story, because
Yeah.
the bleeding didn't come from there. Yeah, go ahead.
So I think the size is extremely important, and the length again is very important. So even though
you need to use a long one.
Long one. You need to use a long stent graft, and you have to oversize it, especially in normal arteries. I think I have repeated myself multiple times, but it's very important for a stent graft for any stent, in younger patient and normal vessel, you need to oversize. You have a comment?
One question. Here, a balloon expandable covered stent was used. Question is, how many would use balloon expandable versus self-expanding in this case? No preference? How many would do balloon expandable? Okay, how many would do self-expanding?
The problem of self-suspending is that for the size you want to go, you need to go to very large sheets. I would prefer self-expandable, but in general, I prefer to finish the case with the 7 French maximum sheets than the 9 or 11 French. So that's the only difference. But I think you are right. In general, in those situations, self-expandable is better because it's kind of marry better the anatomy, the curvature.
I would disagree. I think that if you put a self-expandable stent, you cannot make any mistake on the size. As compared to a balloon expandable stent graft where you can oversize, and it's very difficult to do the appropriate sizing up to a precision of 1 millimeter or 2 millimeters. So I think balloon expandable stents is what we would favor in that case, in addition to what Jafar said about the puncture site and the availability. Yeah, there's one point here. IVUS at 2 in the morning is, you know, and cost as well. And I would not rely on IVUS to do sizing. I mean, okay, that's another story, but...
no, I think that's the standard of care. But at the same time, I agree with him. With age at 2 a.m., I would just go. But you know in general what is the size of those vessels. Just go 2 millimeter higher.
So...
No, you are totally right. I think that's the right practice. I don't think we can argue. That's the right practice.
So we're called back one day later, and reason why I wanted you to remember what we had in terms of anatomy of the surgery that has been done, and there was a fistula with the rectum. So the guy is having recurrent rectal bleeding, but there is no drop in hemoglobin. Okay, so there's no additional bleeding. So we try to understand what's happening. Should we re-embolize? So the intensive care people are on our back saying, you should go back, and then we reanalyze the images, and they just want you to show what happened. What happened is that the clot from the renal cavities went out through the rectum secondarily, one day after, and it was not rebleeding, it was just evacuation of the clot. And you can see before, here, and after. So we didn't do any re-embolization. Sorry, Rob, we didn't went back for re-embolization. And that's it. So you know that these cases are very, very severe. They are always, I mean, most of the time related to previous surgery or previous radiation therapy. So something to keep in mind. And last thing, I don't have any drawing on that, but it's very important to consider the anatomy because if you can see here on this reconstruction...
2 minutes.
You can see... Thank you.
You see I'm standing up for that.
you can see that the pseudoaneurysm is here and the internal iliac artery is far away. But sometimes the internal iliac artery is very close because of the anatomy, because the ureter crosses the iliac bifurcation at this very specific point. And then you need to preventively embolize the internal iliac artery, which was not the case here. Thank you.
Thank you so much, Mark. Thank you, the panelists. Thank you, ISVIR, for giving us the opportunity to do this case. I think the interactive discussion was very good, and thank you for all the participants who actually were not shy. I think that exercise before the meeting helped a lot. So, so thank you, everybody, and thank you, really, both of you. You have been great, and Mark. Have a great day. Thank you so much. Oh, by the way, they asked us to have a past guest at faculty to come up here to get some pictures. So I see there are already 3 of them. Come up here, please. Where is Shams? Where is Shams and Kumar? Kumar, come up.
All right, let me, sorry, Dr. Jafar, may I take this opportunity to invite the organizing chairperson of ISVIR 2026, Dr. Deepashri, to please join us on the dais. We're all set to felicitate our fabulous team. And what a fabulous session. Did you guys enjoy it? Yes? Oh, yes. They did. Thank you, thank you. Please move to the center of the stage for a better group picture, if you could. Better lighting, yes. And also someone has missed their room key. It's with me. Just check if you have your room key. Yeah? Yeah. I now request the president of ISVIR to say a few words.
On behalf of ISVR, we really thank the JUST team, and we really see it as a wonderful session, and we enjoyed your session several times before in various other conferences. It's indeed a big pleasure to have you here with part of ISVR. I hope this grows like a trend, and we wish to see you in future. Thank you.
The JEST team, we'd like to felicitate you. We have a special memento. It's a miniature version of the UNESCO heritage site, the Show Temple, what you see behind you. We are giving you the miniature version of that to take home. Can you please stay back? Yeah. Yes. Can we begin the felicitation? Let's honor Dr. Jaffer. Thank you so much, Dr. Jaffer. Dr. Jaffer Gulzarain. May we now honor Dr. Mark Zapoval. Ladies and gentlemen, show the appreciation. I know you had a great time enjoying the session, and they've been fabulous as delegates. Thank you so very much. We will now felicitate Dr. Osman Ahmed. And now we would felicitate Dr. Sanjeeva Kalva. Thank you, Dr. Sanjeeva. Thank you so very much. Thank you so very much. Meanwhile, we've had a fifth step challenge, a step count challenge actually. On day 0, we had Dr. Ajay Kumar who clocked in 14,343 steps. And day 1, we had Dr. Tabish Khan clocking in 26,434 steps. On day 2, can we have the image please? Dr. Shaleen Rana from Chandigarh. Wow, that's fabulous. Guys, we can clap for this. This is huge. Yes. And finally, we have a very, very special video. You know, we need people like this to inspire us. Can we please have the video, please? Yes, Dr. Pushpinder, please join us on the stage. We have a voucher for you. A nice big round of applause because, you know, absolutely inspiring. In your busy schedule, you've made fitness as part of your regime. Dr. Deepashri, can you please do the honors of giving the voucher, please? Ladies and gentlemen, the one and only Dr. Pushpinder Khera for you. It is a body massage, full body massage voucher that he's getting from this very hotel. So we can, you know, make the most of it. Are you going to be running tomorrow as well? I know you served today. You will? All right. Thank you so very much. Next up, we have the paper presentation for which we're going to be moving the partition in. But thank you so very much. It's been fabulous. May I please request the team from GRT to help us set the partition because they're ready with their sessions. Our speakers are ready. So please, konja seekirama partition poda udavunga. Is it done? Right, we have podium presentations. It's all about the venous interventions. That's going to be what we're going to see on this big stage in a few minutes. Remember guys, tonight the big gala is going to be at the wharf. For those of you wondering where the party is tonight, it's at the wharf. So see you this evening at 7 o'clock. Make sure that you make the most of it. And some of you have not collected your saris and your veshtis. It is there at the kit counter where you collected your kits. It's right there. Please collect it without fail. Yes. Tonight's theme is ethnic wear. So remember that as well.
Good evening, not good evening, this is an afternoon, after a big lunch. And I say we are going forward for the venous intervention presentations. So I request to the jury members as well as the podium presenters to come to the Oceanic Hall in the front rows. So I would request Dr. Tushar sir to come front as a jury member, and the other is Dr. Abhik Bhattacharya sir. And Dr. Sabari Sundarwale sir. So, and they are coming. So in meantime, I will say the podium presenter to come forward. I think we'll start the venous intervention podium presentation. The first presenter will be Dr. Abhinandan Kumar. Is he available? Okay. So we'll go for the next one, that is OP50, Dr. Shreya.
Good afternoon, everybody. Am I audible? I'm Dr. Shreya from NH Group of Hospitals in Kolkata, and I'll be talking about intravascular ultrasound for complex central venous obstruction in hemodialysis access, its morphological insights and therapeutic applications. So a little bit about why this is important. So central vein obstruction causes a significant morbidity in hemodialysis patients. It is a leading cause of access dysfunction and failure, and it leads to high reintervention burdens and complex management. And we've already established with the landmark video trial that IVUS helps in iliac vein lesions. So we set out to find whether this applies to the central veins as well, pertaining to brachiocephalic vein and SVC. So the objective of our study was to compare diagnostic efficacy and therapeutic impact of IVUS versus DSA for lesion detection, severity assessment, and treatment planning in complex CVO cases. It was a prospective study in a single center-based environment, and The study duration was about 12 months, and we had a follow-up of 3 months after that. So after excluding 4 cases, we had 25 patients with us. And all of the cases underwent DSA along with IVUS, and then there was no dropout. So moving on to patient demographics, all the patients with hemodialysis who presented with significant clinical central vein obstructions, which was characterized by upper limb swelling or presence of collaterals and visible veins in the neck or facial swelling, were taken for the study. The symptom duration was of an average of 3.5 months, and mean number of previous dialysis access in the neck was 8. Moving on to morphological assessment, by IVUS we could detect 31 lesions in those 25 patients, and we could detect 27 lesions with DSA alone. So IVUS definitely had an upper hand. And the lesions which were missed on DSA were more on the left BCV-SVC junction or the retro-sternal SVC. IVUS consistently had a significant upper hand in vessel measurements. So it measured more diameters by plus 3.5 mm, and even the lesion length was more by plus 10.9 mm by an average. So as we can see in this image, the central venogram shows a lesion diameter of the length diameter of about 12 mm, and while the same on IVUS is about 16 mm. And similarly, the lesion length is more on IVUS. Why? Because it straightens the vessel. IVUS also added some morphological features which were not clearly seen on DSA. For example, in this case, when we can see in the first image, the left central venogram shows some flow-related artifacts or rarefactions, but we actually do not know what is happening inside. So when we did IVUS, we found out that at the BCV level, there was extrinsic stenosis. In the proximal SVC, there was extrinsic wall thickening, and in the distal SVC, there was fibrin sheath. Similarly, in another case, here we can see that the left central venogram shows brachiocephalic vein occlusion, but actually it was lumen occluding thrombus, which was inside the vein, that was causing the occlusion. So this also has therapeutic implications, because in first case, we had to do fibrin sheath stripping, and in the second case, we had to put the patient on anticoagulation. Another very important thing is the extrinsic compression, which is detected by IVUS better. So extrinsic compression is particularly at 2 sites. One is at the costoclavicular level between the first rib and the clavicle, and second is at the retrosternal level between the sternum and the aorta. And why this is important is because standard balloonplasty doesn't help in these cases. There will be recoil. So we'll either have to do surgical decompression, and then it needs to be followed by stenting. So these are certain examples for extrinsic compression. So like in first case, we can see that DSA doesn't show any significant extrinsic compression. But in the same case, when we see the IVUS image, there is indentation of the first rib. And this was also demonstrated by CBCT. So we inflated a balloon at that level, and then we did a CBCT, and we can see there is an extrinsic indentation on that balloon. So this had to be treated by surgical decompression and stenting. And similarly, the other case, here the IVUS shows that there is luminal collapse. This was dynamic at when the sternum and aorta are very close to the vein. And similarly, when CBCT was performed at this level, we can see that there is only a 2 mm distance between the aortic arch and the sternum. So again, this had to be treated by central vein stenting. So the residual stenosis detection rates were also much higher on IVUS. So IVUS detected 61.3% residual stenosis as compared to 16.1% residual stenosis on DSA, and this directly had impact on treatment modification. So treatment modification was carried out in 54.8% of cases in the form of balloon upsizing or additional stent placement or stent length modification. For example, if we see in this case, the left central venogram does not show any significant stenosis, but actually there is persistent recoil, which is seen on IVUS, and post-stenting, there is significant lumen gain. So IVUS did not add any significant complications to the procedure, and the average time that was added to the procedure was only 7.8 minutes. And the patients had no recurrence of symptoms for the next 3 months, although we have to follow these up for more time, and we are waiting on our 1-year data to see the recurrence rates and compare it with our standard DSA. In conclusion, I would like to say that IVUS is an essential adjunctive tool for optimizing outcomes in complex central vein obstruction.
Last 2 minutes.
Thank you. This is my team from NH Kolkata. Okay, it's not seen.
Any question from the audience?
Would you use an IVUS for in the veins in every case?
I would like to say, if the time is also not an issue.
The time is not an issue. So what she says is that if time and money is not an issue, she would like to use IVUS in every case.
Because in lower limb venous interventions now, IVUS is a standard of imaging. So similarly in central vein also, IVUS should be a good investigation tool for finding some important data like vessel diameter, extrinsic compression. Also, if you combine that with the DSA, we can make a dynamic imaging of the venous systems. Good.
Thank you, sir. Thank you, everyone.
The next speaker will be Dr. Mohit Gambhir. That is OP51.
So good afternoon everyone. Today I'll be talking about the efficacy and safety of small diameter tips in advanced liver disease to reduce the portosystemic gradient, deciding the stent diameter and how. So the common complications of portal hypertension are refractory ascites and variceal bleeding, which can be managed with by tips. And the recent review report variable but high incidence of post-tips hepatic encephalopathy with no definite decline in the incidence despite medical advances. Small diameter tips reduce the incidence of post-tips HE and post-tips liver failure. However, they provide a lower portosystemic gradient reduction, which makes it more prone to tips dysfunction. And several meta-analyses report improved HE control with 8 mm tips without any significant difference in recurrence, stent patency, reintervention rate, and overall survival. But the data regarding 6 mm stent graft is limited. So we did this study to compare the efficacy and outcomes of small diameter tips, 6 mm versus 8 mm versus 10 mm. So we compared a total of 20 patients who underwent 6 mm tips and compared that with 40 propensity score matched 8 mm and 10 mm tips patients. The technical success was defined by successful creation of the tip shunt. The clinical success was achieved when there was complete resolution of ascites or hydrothorax or variceal bleeding with no further requirement of large volume paracentesis or any additional clinically significant variceal bleeding. Recurrence was defined as need for at least one large volume paracentesis after tips or any episode of clinically significant variceal bleeding. Overall survival was calculated from the date of tips creation to death or liver transplantation. Patients who were lost to follow-up were censored at last contact. And the overt HE was defined as new onset neurological symptoms, graded West Haven more than or equal to 2. So our study population included a total of 100 patients, 20 of 6 mm and 40 each of 8 and 10 mm tips. And the mean age was around 61 years. And there was high incidence of sarcopenia and pre-tips HE in our study group. And the major indication was ascites. The major etiology was NASH-related CLD with a mean MELD score of 17 and predicted survival probability at 6 months 60% and 1 year as 50%. There was no significant difference between the baseline lab parameters. So coming to the portosystemic gradient, the best reduction in the portosystemic gradient was with 10 mm tips as compared to 8 and 6 mm tips, which was significantly different. We achieved a 60% reduction in 10 mm tips as compared to 45% reduction in the 6 mm tips. So coming to the outcomes, so as we can see in this Kaplan-Meier graph of 1 year recurrence rate, you can see that over a short period of time until 6 months, the recurrence rates is almost nearby. But as we go beyond 6 months, the lines diverge. So there's a higher chances of recurrence after 1 year. And this is the overall recurrence rate. And the similar trend is seen in the reintervention rate. Up till 6 months, there is similar reintervention rates. But after 6 months, over a long period of time, the reintervention rates are higher in 6 mm tips. We did not observe any difference between the overt HE rates among the 3 groups or the difference in mortality rates in the 3 groups. So we did the Cox regression analysis and found out that stent patency and child-pugh score were predictors of recurrence, which is pretty obvious because dysfunctional stent will lead to recurrence, and higher child-pugh score means that underlying hepatic reserve is less. And child-pugh score was also a predictor of mortality as it predicts the underlying liver status, and pre-tips post-portosystemic gradient was another predictor of mortality, which suggests the extent of portal hypertension and hepatic fibrosis. So our major subgroup was ascites group. We had a total of 80 patients who had ascites or hydrothorax or mixed indication of ascites plus variceal bleeding. We did the receiver operating characteristic curve analysis and found out that a post-tips PSG of more than 9 mm led to a higher recurrence rate, a post-tips PSG of more than 11 mm led to higher overall mortality, and a post-tips PSG of less than 7 mm HG led to a poorer HG control. So we divided our subgroup, the ascites subgroup into 2 parts, one who achieved the target PSG of 7 to 11 mm HG and those who did not. And we compared 18 score matched patients in the 2 groups. So the best post-tips portosystemic gradient control was achieved with 10 mm tips as compared to 6 mm tips. And as we compared the patients in the target and the non-target group, we saw that in the non-target group there was higher recurrence and reintervention rates, but paradoxically we observed that there was higher mortality rate in the target PSG group. So this could be explained by the higher incidence of post-tips liver failure in 10 mm tips patients, which was precipitated due to the higher flow rates into the systemic circulation with large diameter tips in already high-risk patients in our study group. So the principal finding in our study was 6 mm tips provides a comparable short-term clinical success, stent patency, HE incidence and survival, but are associated with higher long-term recurrence and cumulative reintervention rates. The more advanced disease was observed in our study as compared to prior studies, which predicts the higher absolute rates of recurrence and HE and mortality. And higher cumulative recurrence and reintervention rates were observed in 6 and 8 mm tips, as they will have a smaller diameter, which leads to a turbulent flow within the tip shunt. And achieving the target post-tips PSG of 7 to 11 mm HG leads to a lower recurrence and reintervention rate, but paradoxically higher mortality due to increased cardiac complication. So a 6 mm tips provides a comparable short-term disease control in selected high-risk patients, but higher long-term recurrence and reintervention rate limits its utility. And the decision between 8 and 10 mm tip stent should be considered based on individual patient characteristics according to the baseline hepatic function, pre-tips gradient, and the cardiopulmonary reserve. So the limitations of our study was it was a retrospective study with a single center setting and a small sample size, and we did not observe the added advantage of adjunctive procedures such as proximal splenic artery embolization, which might be used along with 6 mm tips, which will provide a better result. So to conclude, 6, 8 and 10 mm tips provide similar short-term clinical success, reintervention and overt HE and survival rates, but higher long-term recurrence and reintervention rate, and achieving a target post-tips PSG of 7 to 11 mm HG may reduce recurrence in patients treated with ascites, and patient selection should consider hepatic reserve and cardiac risk. So these are my references. Thank you.
So what is the balloon size you used after putting 10 mm of stent? Like
So
you used to plaster with 10 mm or 8 mm balloon?
we decided based on the gradient that we achieved after 8 mm. So we start with the smaller balloon. If we do not achieve the target gradient, we'll overdilate it with 10 then
So
eventually.
for a 10 mm stent, you used to start with an 8 mm balloon.
Yes, sir.
So for 8 mm stent, you do balloon with
6, 7 and 8.
6, 7 and 8. So eventually at least like for 10 mm stent, it is like a 8 mm diameter mostly, no?
Yes, sir. But in many studies, they have reported that after 1 month, the stent achieves its original diameter. That's why. So
Currently, what is your what you are following currently, like after this study?
So
You are
after this
putting-
study, we have almost stopped 6 mm tips. We are doing 8 or 10 only. 6 mm in only very high risk patient
Very
who
high.
does not have very good cardiac reserve.
Okay.
So it is a retrospective study.
Yes, sir.
You told you have selected the stent size according to the photosystemic gradient and hepatic function.
Yes, sir.
So what is the cutoff point using an 8 mm and 6 mm stent?
Sir, we have, after this study, we have started targeting the PSG accordingly. Like we want to target the post-tips PSG to be between 7 and 11. But before that, we were following the previous guidelines. For variceal bleeding, it was less than 12, and for ascites, it was 50% reduction.
Now to decide whether you will use the 8 mm or 6 mm, it was retrospective. But
Yes,
now
sir.
onwards, you will be planning that only.
Yes, sir.
Right.
Thank you.
So for the next presentation, that is OP52, Dr. Saurabh.
Good afternoon, everybody. So, I will discuss the feasibility of tips in patient with segmental or lobar bleed dilatation at our center. As we all know, biliary obstruction is traditionally regarded as contraindication for TIPS procedure due to potential risk of biliary injury and related complication. This is a single center retrospective clinical study to evaluate the feasibility and clinical outcomes tip placement in patient with biliary dilatation without peri-procedural biliary decompression. So it was conducted from Jan 21 to 25. We estimate over 100 patients, 5 patients are included in which have localized biliary dilatation, either lobar or segmental. And the etiology was post-transplant biliary stricture into post-radiation fibrosis into and one post-hepatectomy biliary stricture. And the indication of TIP for refractory ascites in all and resistant melanina in 2. So I will be showing 2 cases. So the first case is a history of CAJB with developed a surgical bed recurrence. Basically, CAJB developed a recurrence. The PET was positive. The patient underwent multiple sessions of immunotherapy, chemotherapy, and this is the follow-up scan in 23. So patient presented mycelia ascites, left lobe is atrophic with biliary dilatation, right posterior segment is atrophic with biliary dilatation. So the presenting complaint was massive ascites. However, the disease was controlled. There was high seg ascites. It was negative for malignant cells. The fish ascitic cell block was negative. We did the biopsy. It was suggestive of drug-induced liver injury secondary to long-term chemotherapy effect with F3 fibrosis. Upper GI show early gastropathy. Even we did FAPI PET to rule out malignancy, so it was negative. So we have a atrophic lobes, segmental dilatation, but patient was asymptomatic for this, only no bilirubin within the normal limit, only mild L-phos was raised. So we did TIPS in this patient. So this was the normal middle hepatic vein tributary, and this is the portal vein tributary. So we target this under ultrasound guidance, and there was this was the acute bend of the TIPS. So this was the TIPS. We can see the tip track traversing through the normal liver parenchyma, and the rest of the biliary it's not compressing or pushing towards the rest of the dilated bile duct. So we have to carefully plan the tracts within the normal liver parenchyma, and care is to be taken that the normal dilatation should not be hit during the procedure. This is the pre-TIPS and post-bilirubin. Even the patient was asymptomatic and remained asymptomatic for this liver function. LFT was within normal limits. We have more than around 8-9 months follow-up this patient, and only the L-phos was raised, but
pre-tips and post-tips are comparable. So the second patient is a patient has a history of hepatitis C related cirrhosis and right lobe split liver graft was done in 2014. The patient has an anastomotic biliary stricture for which multiple sessions of dilatation and stent exchanges were done in the immediate post-transplant period. So last stent was 215 was done in the 2015. The patient was asymptomatic for around 5 years, now present with malignant refractory ascites, and the liver biopsy was done. It shows only chronic active hepatitis with fibrosis. So this is the scan. So we can see large varices, ascites, and this is a transplant liver. We can see that biliary dilatation involving the posterior segment. There is atrophy, hypoplasia of the posterior segment, and even the portal vein is also hypoplastic. So this is the lower image. You can see the anterior segment portal vein is rotated and it's hypertrophied, while this is the hypertrophied, and the right posterior segmental vein is hypoplastic, and as well as there is biliary dilatation and atrophy in the posterior segment. So the patient has an ascites and melena, so we plan to do tips and targeting the anterior segment of the portal vein. So we did tips. This is the entry into the right hepatic vein. We have to mold the guiding cannula so much like we are doing a tips in the normal level left portal vein. So we are able to puncture the anterior segmental vein and do the tips. This is the final picture. So this is a 1 year post-op. The flow was good. This patient has the largest follow-up of around 5 years with us. The patient developed SCC in 2024. We did tips in 2022, and this is the follow-up. Sorry. You can see this is the MRI. The varices are depressed. Is gone. The ascites is gone, and you can see the traversing of the tips tract. The tips tract is seen along the normal liver parenchyma, not traversing or hitting compressing the dilated bile duct segment. So this is the second image. Is arrow is pointing towards the tips patent tip stand, and the dilatation is posterior. So this is the bilirubin. The reports are from 2021 to 2024. No change in the LFT. So LFT are dead normal in this case also. So we planned tips procedure without prior biliary decompression, as the obstructed segments were already atrophic, and placing an external drainage catheter would have imposed an additional burden to the patient. And in few cases, endoscopic biliary decompression was also challenging because they are tight and chronic strictures. So results were mean pre-procedure bilirubin and post are almost normal. Technical success was seen in around 100% of cases. No significant change was seen between the pre-tips and post-tip LFT. Clinical outcomes: a complete resolution of ascites was seen in the patient, in 75% patient, and one patient had partial improvement at 3-month follow-up. The bleeding was controlled in both the patient. The mean hospital stay is around 2 to 3 days. And the follow-up
Last 2 minutes.
Follow-up with the Doppler is showing demonstrated 100% tip stent patency. You review the literature, you won't find any single case report or single study of tips in the biliary dilatation. So we conclude that tips placement in the presence of localized segmental biliary dilatation is both technically feasible and clinically safe. And detailed pre-procedural imaging, strategic tract selection, and use of cover stent minimize the risk of biliary injury. Tips can be successfully performed without biliary decompression, achieving durable stent patency and symptomatic improvement. We recommend to modify guidelines of tips contraindication. However, large multi-center studies are required to further substantiate our findings. Thank you.
Sir, what are the risk of bacteremia or sepsis?
Sir, all the antibiotic prophylaxis was started 1 day before IV antibiotics. We have decided the protocol for this. IV antibiotics was started 1 day before the procedures. And we did the puncture in the ultrasound guided. We know where the dilated duct is, where we have to puncture the vein. It was all, both CT and ultrasound were pre-planned to determine the which tract we have to take. Yes, sir.
So in your first case, where patient, I think after surgery, he received immunotherapy.
He received radiotherapy, multiple chemotherapy, and immunotherapy.
So for that also you need a reduction of bilirubin. For that also you need a biliary decompression before that. Isn't it?
In this
Have
patient,
you tried that?
in this patient, bilirubin doesn't rise because he developed post-radiation structure at the hilum, but then the atrophy started, the dissociation of the biliary radicle started, the central liver becomes hypertrophic and surrounding right and left, the central liver take up the action function of the whole of the liver. So in this case, not even a biliary stenting was performed, not even, his bilirubin remains constant. It's less than 3 post immunotherapy also, but at the time he came to us, it's around 1.2. He remained asymptomatic and now also is asymptomatic. It's just a study designed to that we always say biliary dilatation is a contraindication, but in certain scenarios, we have done 5 cases. In biliary dilatation, presence of biliary dilatation, asymptomatic, you can still do a TIPS after planning, proper planning is required.
Thank you.
This is the first kind of study in India. Nothing. Thank you.
So, after 2 presentation on hepatic interventions, we will go into again the venous intervention. I am calling Dr. Abhijit to come up for the next presentation.
Good afternoon. I am Dr. Abhijit. I will be presenting a single institutional study on prediction and validation of a scoring system for IVC filter retrieval. So IVC filters are placed mainly to prevent pulmonary embolism in high-risk DVT patients. However, if it is delayed retrieval, then it can lead to migration, fracture, penetration, and thrombosis. And the retrieval rates are low, with ranging from 12 to 45%. And difficult retrievals can increase the procedure time, increase radiation, need for advanced tools. So our study objective was to identify the clinical and imaging predictors of difficult retrieval, and based on that to build a simple pre-procedure risk score and to validate in an independent cohort to support planning and scheduling. So our study design was divided into 2 phases. Phase 1 was the derivation cohort and phase 2 was the validation cohort. In the derivation cohort, it was a retrospective study on 60 patients who underwent the IVC filter placement. Phase 2 was the validation cohort with the independent time period cohort of 13 patients. So the outcome we had defined was a pragmatic definition of difficult retrieval, where a standard jugular retrieval was attempted for all the cases first, and if it was unsuccessful after 50 minutes, then we labeled these cases as difficult retrieval. And those cases usually required an advanced technique, either balloon assisted or hangman techniques. So most of the filters were either Denali or Cook Select, and we placed mostly infrarenal. Few cases we have placed suprarenal, in those cases with mid-IVC thrombus or in pregnant women. We actively surveillance was done for all the cases every 3 months with Doppler of bilateral lower limb and IVC assessment. One day prior to the retrieval, we did pre-retrieval CT imaging with a non-contact CT abdomen. We focused on a 5 centimeter coverage cranial and caudal to the filter to minimize the radiation dose. And the CT imaging, we evaluated parameters such as the filter tilt, tip embedment, filter penetration, and IVC diameter at the filter tip level. So we have standardized the workflow. The routine workflow is that we started with a standard retrieval with giving a trial of 50 minutes. If it failed, then we escalated and we obtained additional access which was required. Then additional techniques like balloon assisted disengagement or hangman loop was done, and finally we inspected the filter post removal to look for any residual or the fracture. So this was our IVC filter retrieval outcomes. We have placed 60 filters and attempted in 55 cases with successful retrieval in 54 cases. Of the 54 cases, 15 cases had difficult retrieval and standard retrieval in 39 cases. So what were the factors associated with difficulty were? One, the route of placement, like femoral placement had a difficult retrieval in 60% of the cases, when compared to jugular placement had only around 12.8%. And regarding the type of filter, Cook Select had difficult retrievals in 53%. And regarding dwell time, difficult retrievals had a median dwell time of around 233 days when compared with the standard retrievals where the median was 103 days. Now coming to the imaging factors that predicted the difficulty were, mainly we found 4 factors that were significant. One was the IVC diameter. Larger the diameter, it was easier to remove the IVC filter, and median tilt of 11 was considered to be more difficult in retrieval, and 93% of the cases with tip embedment had difficult retrieval, and 33% had thrombus around the filter. So when we found the univariate analysis, we had multiple factors. However, when we did the multivariate analysis, only 2 factors came out to be significant and as independent predictors. Those were the IVC diameter and filter tilt. IVC diameter with odds ratio 0.03, suggesting a larger diameter as protective, and filter tilt found out to be, more the filter tilt, higher the risk of difficult in retrieval. So based on those 2 parameters, we developed a simple 4-point CT scoring system, and each parameters were given 2 points each, and we predicted difficulty whenever the score was gone above 0. Anything more than 0 is considered to be difficult, and we also classified the groups into low, intermediate and high groups based upon the scoring system. Now the next phase was a validation phase that was done on 13 patients, and the independent cohort actually confirmed a good discrimination with a simple CT score, even though sensitivity has gone from 100 to 75%, possibly because of the reduced number of sample size. However, the specificity was good, around 88.9%. So when we compared the derivation and the validation cohorts, there was an overall good generalization with a small and simple model. So the limitations of our study was that it was a single center experience with a small validation cohort, and we actually more focused on the mechanical CT predictors. Not all the clinical conducts has been involved. So next step will be doing a multi-center prospective validation. Then the final outcome is that with a simple 2-parameter CT-based score, we can actually plan for the complex retrieval risk, and that is simple enough for routine use and useful enough to change the workflow of the cath lab. Thank you.
So what is the median time for the duration for the removal? Like after how many days you remove most of the filters?
That's a we check for the anticoagulation, whether we can if the patient is on adequately anticoagulated.
No, what is the median time for the removal?
That's like for a difficult case it was around 200 range, but for in a standard case
200 days.
200 days. For standard case it was around 103 days.
So that is not did you not find anything relevant to that?
No, when we are multivariate analysis, it was not showing any significance.
Okay, and you have said that tilt 5 degrees also. We used to know that more than 15-degree tilt is significant. Otherwise, it is not that significant.
Sorry, sir, I couldn't.
More than 15-degree tilt is significant.
Yeah, so that was previously in all literature it was around 15 degrees, 15 degree. But in our study we found that a median of at least 5 was showing a significance.
Or is there any correlation between tilt and the embedment later on? More the tilt in the initial phase or during the deployment, it will more correlate with the tip embedment with the wall, IVC wall.
That's how when we did most of these tip embedment was seen with femoral when we had femoral placement, and those cases had tip embedment when compared to jugular.
Not with the IJV,
less with the IJV, more with the femoral.
When you told in difficulty in retrieval of the IVC filter, you told about the axis, femoral versus jugular axis. Yeah, femoral axis can cause tilting of the filter, we can appreciate. And the days till we are retrieving it. If it is longer, then the retrieval is become more difficult. But what is your experience about those different vendors like Cook and Bird has got a significant difference in retrieval?
Yes.
What is your take on it?
We were easier to retrieve with select filters when compared to Denali filters when compared to Cook and Select. Mostly because basically Denali itself inherently it was trying to maintain a central position when compared to Cook Select. The design itself was mainly that these Denalis are having they align with the central
after
IVC.
Deployment,
It
becomes central, and Cook filter tilted. What?
Because it has, we found that it has more penetration when compared to Denali.
Thank you.
Any operator factor which will influence the retrieval time?
operator, that's with we couldn't find any significance like that, but maybe with experience and it will be much less time consuming.
Good. Good study. Thank you.
So again switch into the hepatic venous intervention, that is OP56. I am requesting sir to come now.
So good afternoon everyone. So I'm presenting this data of Dr. Ranjan. Actually he is to left, so I'm Dr. Prayas. I'm presenting his data. So the topic is the role of baseline liver and spleen stiffness in predicting liver function following PARTO or BARTO for gastric varices in patients with liver cirrhosis. So here's the background. So as we know, BRTO and PARTO is known to improve the liver function in addition to variceal obliteration. So, but not all patients experience improved liver functions. So, higher liver stiffness is less likely capable to accommodate increased portal flow after BRT PARTO, then in turn would result in complications such as aggravation of acial varices and hepatic function. So, the function, if the function is liver function is good, stiffness is less, so there is more chances of improvement in liver function. Also, spleen stiffness is also, it also varies according to degree of portal hypertension. So, LSM and SSM could be an important biomarker in predicting liver function following shunt occlusion. So, this is study design, it's a single arm prospective study and the study period is 3 years. Objective is to determine the role of baseline liver stiffness and spleen stiffness in predicting liver functions following the procedure. And the second objective is to evaluate the association of baseline LSM and SSM with progression of esophageal varices following shunt occlusion. So these are inclusion and exclusion criteria. In inclusion, age between 18 to 70 years, patient with liver cirrhosis, presence of dominant shunt more than 8 mm, and shunt occlusion for secondary prophylaxis. These are the exclusion criteria. CTP score is more than 10, intractable ascites, HCC, Budd-Chiari, PVT, and if there is any history of prior history of TIPS or surgical protostomic shunt. So here's the flow diagram of the study design. So we have taken history, clinical examination, endoscopy was done at the baseline, TPCT, LFT, CBC, INR, RFT, and CTP scores and MELD score. Then according to inclusion exclusion criteria, the patients were taken baseline LSM and SSM was measured with a transient elastography machine. Then the procedure was done and the patient were followed at 1 month, 3 months and 6 months. Then again, here the outcomes we measured is the improvement in liver function and the status of esophageal varices at 6 months. So we use graph pad prism 8 to analyze with the help of pair t-test, ROC analysis, and area under curve of more than 7.8 was considered clinically useful. These are the baseline characteristics of the patients. The mainly patients were CTP score A and B, and MELD score of mean was 12. Coming to the results, the technical success was 100% in all patients. We did 2 BRT and 33 PARTO. Clinical success was 100%, unable to obtain LSM in only one patient, but the patient was not, we were not able to measure, the patient was uncooperative. 2 patients died within 1 month of BRTOs, these are excluded from the study. And there was no major complication of the procedure. One case had a minor shunt rupture, but that was finally there was but finally the PARTO was done. So if you see the ROC curve in splenic and stiffness and liver stiffness, we can see that liver stiffness ROC area under curve is 0.7, so it's significant with a cutoff value of 22 kilopascal. And sensitivity of 65%, specificity is 83%. So these are the improvement in the albumin. So the cutoff improvement in albumin was significant in patients with LSM. So if the liver stiffness is 22, less than 22, so we have a sensitivity of 63%, specificity 83% specificity. So this is the albumin at baseline versus at 3 months. So you can see there is significant improvement on albumin at 3 months in patients with LSM less than 22. So because the liver was better, the stiffness was less, so these patients have improvement in albumin at 3 months. But there was no improvement or no significant change in values of serum bilirubin. Similarly, INR was also there was no significant because p-value was more than 0.97. The next is the predicting whether we can predict if we need any treatment of esophageal varices with the help of LSM. So in this we can see that LSM has liver stiffness has a negative predictive value of 90%. So that means 90% of patients with LSM of less than 22, but that was our cutoff through the ROC curve, did not require esophageal treatment. So patients not requiring treatment was 90% if the LSM is less than 22. So there are many studies which have evaluated these values. One study was from ILBS also. They showed that there is significant improvement of liver volume and serum albumin following shunt occlusion. And one study they also measured this and found that significant improvement in serum albumin at 3 months following BRTO with cutoff value of LSM 22. So the limitation of the study was because it was only patients of 35 patients were taken, small sample size, single center study, no long-term follow was taken. Follow was at 1, 3 and 6 months. So in conclusion, LSM was useful to predicting which patient would experience improvement in serum albumin following shunt occlusion, and esophageal progression was slow in patient with LSM of less than 22, as reflected by a lower negative, lower rate of varicose needing treatment at 6 months of procedure. Thank you. Thank you, sir.
So coming to our last session, I think that is OP 58. So you sorry. So next will be on the again the venous intervention, that is OP 57. Dr. Kamran Hasmi.
This is not much.
And we will go to the next session.
Okay.
Sorry for the inconvenience. We will go to the next, then we'll upload further. So I will call upon Dr. Saurav again for his last patient, that is OP 58.
Good afternoon, everybody. So I will be discussing iatrogenic portal vein fluid aneurysm following pancreatic surgeries and liver transplant surgery, highlighting that the GI bleeding is not always arterial. Portal vein fluid aneurysm are a rare vascular anomaly with isolated case reports and comprising all 3% of all venous aneurysm, and they are typically occur in post-traumatic or post-surgical settings. So despite the low pressure venous system, rupture can cause massive GI bleed and associated with high mortality and morbidity. So in a single studies in multiple pancreatic liver bleed, we identify 3 cases. 2 are post-pancreatic surgery and 1 is post-HJ in a liver transplant recipient, which are all 3 are managed by endovascular stent grafting. So the mean age of the patient was 44 years. 2 patients, one after pancreatic surgery, 1 was after lateral pancreatic jejunostomy, and 1 after Pepper's procedure. And the liver transplant as a post-liver transplant HJ for biliary stricture. All the patients present with after 2 to 3 weeks post-op with hematemesis and melena and cholangitis in the liver transplant patient. So I will be showing 2 cases. It's a 32-year-old case with chronic ulcerative pancreatitis with recurrent pain, abdomen, and lateral pancreatic jejunostomy. 2 weeks later, he has abdominal pain following a severe bout of hematemesis, and initially was taken to a local hospital. We did presumptive GDA coiling because there was so much hematoma at the pancreatic jejunostomy site, so they weren't able to identify an arterial source. So because most of the pancreatic LPJ surgeries bleed or Whipple surgery bleed are from the GDA territory, so they presumptively block the coil the GDA territory. However, the patient again have a fresh bleed. So we did repeat CT angiography at a hospital, and we found a secular portal vein pseudoaneurysm. This is the pseudoaneurysm at the just projecting into the HJ side pseudoaneurysm. The third image is also showing the projecting pseudoaneurysm. So this is so you can see a thrombus and projecting pseudoaneurysm within the. You can see there is a thrombus and projecting pseudoaneurysm. Just this is the projection into the HJ side. This. So we did a transhepatic portal vein puncture and gone into the SMV and did this is a coiled GDA. This is the active second image is showing the active extravasation from the pseudoaneurysm and place a covered stent. The thrombus was aspirated partially because the patient was already bleeding, so we don't want to touch the fragile portal vein wall. So this is the pre-stent image and showing active extravasation, and this is the followed up the post-stent. So we have completely knocked off the pseudoaneurysm. Why did it happen? We retrospectively see this is the pancreatic. This is the basically we see there is a duplication of the pancreatic duct. We can see there is bifurcation of pancreatic duct. At this point, there are two. It's dividing into 2 points. So when they do LPJ, they lift up the superior pancreatic body and try to find out the ducts and remove calcium from it. So most likely due to this bifurcation that they didn't know, so they hit the portal vein. So the patient was discharged 2 days later and was on tab aliquis, and he is doing well. The stent is patent. We have around 1 year follow-up this patient. Case 2 is a NASH-related cirrhosis, underwent a split liver transplant graft, and after 5 months developed a biliary stricture where multiple endoscopic balloon dilatation and placement was done, which was the symptoms got partially relieved. So the surgeons decided to do a hepatogenostomy. However, within 2 weeks of surgery, the patient presented with history of fever, chills, and episode of melena. So MRCP was done. We see the biliary dilatation. The second image is showing that this is the biloma cavity, posterior segmental IHBRD biloma cavity. We did a PTBD. So when we did enter the duct system, initially the bile came, then the hemorrhagic bile appears to hemorrhagic bile appears to be coming, and this is the biloma cavity. The fourth image, we did the angiography. We see the portal vein is filling. During the cholangiogram, the portal vein was filling, so suggestive of portobiliary fistula. So every time we tried to cross it across the HJ, the wire was going into the main portal vein. So we put the patient on IV antibiotic and external drain for 5 days. The cholangitis and melena subsided. Then again we did cholangiogram. There was persistent fistula. The portal vein was filling. So we decided to do a portal vein. Despite the infection at the bedside, we decided to do a stent graft the infected system. So when we do transhepatic portal venography, we see this is a pseudoaneurysm, probably mycotic pseudoaneurysm just at the origin of the posterior portal vein, and there is non-opacification of the posterior segmental portal vein. So this is probably the fistula site, because our wire from the cholangio bile duct side was always going into the main portal vein. So we decided to covered fluency stent graft was placed transhepatically. This is the post-op done. Now when we are taking the cholangiogram, there is no filling up of the main portal vein. The pseudoaneurysm is completely sealed off. So this is the follow-up CT. Like the biloma cavity, IHBRD, this is almost suppressed. The liver looks good. So on follow-up after 2 weeks, we are able to internalize we are able to remove the biloma cavity pectoral drainage and able to internalize it, because initially we can't able to internalize because the wire was going into through the fistula into the pseudoaneurysm and then into the portal vein. So we are able to internalize, and the patient is on external catheter. Now we have a 6-month follow-up of this patient. So all 3 patients underwent percutaneous covered stent grafting with a 100% technical success rate, and liver transplant recipient with pseudoaneurysm requires additional PTBD and drainage. So literature review, it's a very portal pseudoaneurysm are very rare. Aneurysm are around 3%, but portal pseudoaneurysm are very rare. Only 8 cases have been reported till now. So we have 3 cases more to the literature. Open surgical repair
Last 2 minutes.
Open surgical repair carries a high morbidity mortality, around 30 to 40%, and this stent grafting is a minimal invasive approach in these patients. This is the latest literature. One case have been reported in which they do a stent-assisted coiling. This is a gastric ulcer eroding into the pancreas portal vein, so they put an uncovered stent and did a stent-assisted coiling in this case, as opposed to our stent graft patient. So we can conclude that iatrogenic portal vein pseudoaneurysm should be suspected in case of unexplained GI bleeding following pancreatic or liver transplant surgeries, because the bleeding is not always arterial, and endovascular stent graft exclusion is life-saving in these cases. However, there is a limitation, include the need of lifelong anticoagulation, limited long-term follow-up, and unknown long-term effects of proteolytic enzymes on the structural integrity of the stent graft fabric in pancreatic cases. Thank you.
I think we are going for the last presentation, that is OP 57 by Dr. Kamran Hasmi.
Good afternoon, everyone. So, we have done a study, endovascular occlusion of surgical created portosystemic shunt post live donor liver transplant using Emplar's vascular plug to prevent portal still syndrome, a study on the improvement of clinical and lab parameters. Introduction. Following liver transplant, liver dysfunction can occur in the post-operative period, which usually present at cholestasis, coagulopathy, ascites, or encephalopathy. It is seen in both deceased donor and live donor liver transplant. In deceased donor, liver dysfunction is attributed to the poor quality of the graft, either inherited in the donor or sustained during the process of brain death, retrieval, or storage. In live donor liver transplant, the quality of graft is usually excellent, and liver dysfunction occurs due to the insufficient hepatocyte mass. During living donor liver transplant, portosystemic shunts are created intraoperatively to prevent the ill effect of portal vein overperfusion in recipient of a small four-size graft. And the persistence of these portosystemic shunt can lead to the portal still syndrome, leading to hepatic encephalopathy, graft failure, and rejection. This is a retrospective done at our center in the live donor liver transplant patient in between 2016 and 2021, where clinical and laboratory parameter evaluation was done after endovascular occlusion of the surgically created portosystemic shunt using Amplar's vascular plug. So in the interval of 9 years, we have 4 patients who developed the symptom of hepatic incuft and graft rejection due to the persistence of surgically created portosystemic shunt. So these are the basic characteristics of the patient. So this is coming to the first patient. We have 49-year-old male who presents with NASH cirrhosis, and the live donor liver transplant was done on 2023 using right lobe. Portal flow modulation was done. Hemiportocaval shunt was created. After the interval of 1 year, 4 months, the patient presents with a grade 2 hepatic encephalopathy. So endovascular hemiportocaval shunt occlusion was done. So this is the pre-procedure CT scan and Doppler lever, which shows the low flow in portal vein, and the CT contrast CT shows the location and the size of the shunt. So the endovascular occlusion of the shunt was done taking the right common femoral vein axis. 7 French sheath was secured using 5 French cobra catheter and a thermowire. This hemiportocaval shunt was cannulated, and wire and catheter was navigated into the splenic vein. Venogram was taken, the different projection, the shunt was identified, and the size is measured. After exchanging the thermowire for stiff Amplar's wire, 10 French long sheath was secured into IVC close to the level of the shunt. Prograde microcatheter was secured into the splenic vein. Then 12 into 9 mm Amplar's vascular plug was deployed. After the deployment, the venogram was taken, which confirms the good flow into the portal vein, and no flow was noted into IVC across the shunt. The post-procedure follow-up was done with X-ray abdomen, Doppler liver, and a liver function test and serum ammonia. Coming to the second case, this is a 50-year-old male who presented with alcoholic cirrhosis. The transplant was done in 2022. After the interval of 8 months, patient presented with grade 3 hepatic encephalopathy. So the pre-procedure CT scan was done, which shows the presence of shunt, and we measured the size of the shunt. And Doppler lever shows the low flow in the portal vein. So similarly, we have taken the common femoral vein axis, and 10 French long sheath was secured and advanced into the shunt. Using thermowire and 5 French vertebral glide catheter, the superior mesenteric vein was selectively cannulated and cannulated the shunt, and the portal venogram was obtained, which very well demonstrated the portocaval shunt. The maximum diameter of the shunt measure was 14 mm. 18 into 14 mm Amplar's vascular plug was deployed, and post-deployment of the shunt, the venogram shows the good flow in the portal vein and no flow across the shunt into the IVC. So the post-procedure X-ray abdomen was taken to just see the location of the shunt, and there is improvement in the portal flow, and the post-procedure contrast CT was taken, which shows the presence of the shunt. So this is a third case, 59-year-old female who has NASH cirrhosis. The transplants were done in 2025, and the hemiportocaval shunt was created at the time of transplant. And after the interval of 4 months, the patient presented with a grade 3 hepatic encephalopathy. So the pre-procedure Doppler shows a low flow in the portal vein. So we have, so this is a table showing the pre-procedure Doppler evaluation of the portal vein. So we see there is significant improvement in the portal vein after closure of the shunt. This table shows the liver function test and post-procedure follow-up at 6 months. The serum blood ammonia level also showed the significant change. So the take-home message is surgically created portocaval shunt in the liver transplant patient is managed by the endovascular occlusion of the shunt by vascular plug of the IVC stent. Amplar's vascular plug is a mesh device that expand to fit the vessel lumen after the delivery and are safe, effective, and minimally invasive to close this shunt. As these shunts are side-to-side shunt, no length is available, so careful selection of the size of the plug is needed, as there is always a risk of proximal to distal migration causing occlusion of the main portal vein or distal migration into the pulmonary artery.
By this, we are concluding this session. I am thankful to the jury members for giving the time for the venous intervention podium presentation. Thank you. We'll quickly switch up onto the next session.
Good afternoon, ladies and gentlemen. Very shortly, the much awaited session, Men versus Women in IR. We're going to be witnessing it on the stage, and it's going to be a very, very interesting one. I urge you not to miss it. I invite everyone who's outside and who can hear me to please join me in the hall. If any of your friends and colleagues are outside, I request them to please join us here. This is going to be an absolutely amazing session, I assure you. It's going to be done very differently. Good evening, ladies and gentlemen. Men versus women. Shall the battle begin? Only men are saying yes, all right. Survey of challenges faced by women IR, an Indian perspective. This session will be led by Dr. Neelu Dhoot. Ladies and gentlemen, with a nice big round of applause, may we invite the first speaker of this session. Here is a woman IR professional. How should you cheer for her? Like that. So, hello everybody. Thank you for coming to this session. Before I start with this results of women in IR in Indian perspective, I would like to share what actually initiated it. So last year actually I went to see pre-assess a lady for fibroid embolization, and she had had previous 2 myomectomies, and she was admitted this time with heavy menorrhagia. So I went to see her and she smiled at me and she said, "Oh, are you the intervention radiologist who's going to do the procedure?" To be honest, I was surprised because usually I'm having to do the talking and I have to say, "Oh, I am the intervention radiologist, I do pinhole surgeries and it's a day care procedure, blah, blah, blah." And they're just staring at me. But this time, this lady knew actually what an intervention radiologist was, and she knew what IR was. So I thought, one job less for me. But the next thing she said, "You know what? I had never imagined an intervention radiologist to be a lady." That moment actually got me thinking. And I was like, if all of us in this room were to close our eyes, including myself, and imagine an intervention radiologist, probably chances are all of us are going to see a man, tired eyes, fiddling with wires and catheters, and maybe looking at the screen. But you know, the problem is not the less number of women in IR, it's about the perception. Because even in our imagination, the women are missing from the picture. So that actually led me to do the survey, and I had 4 questions which I needed to answer. Where do we stand? What are the challenges? Why it is important to close this gender gap, and how are we going to do this? So when I did the survey, we had 163 women members, making only 10% of ISVIR registered members. We excluded the females who were not doing IR, but were members, who were doing simple biopsies and drainages, and exclusively practicing breast and MSK interventions. So of the 95 eligible members, we had an overwhelming response of 91%, with 86 women responding, giving us a robust baseline data. So where do we stand? Majority are in training and early career stages, which is up to 5 years of their training. 35% in government, 34 in hybrid, 31 in private, with majority working in large institutions. Less than 15% exclusively practice IR, making diagnostic radiology their maximum workload. And obviously, geographic representation is mainly in southern and western India, where northeast and eastern India is very scarce. Nearly 50% of the women reported gender-facing barriers. However, what was encouraging was 90% remain encouraged, and 9 in 10 women said that they will still choose IR again. And what was also encouraging, that there was increasing female representation in IR, steady from 2005 to 2025. Let's come to what are the challenges which is holding us back. First is lack of female mentors. We do not see female role models which look like us. But the good thing was most of us rated our mentors more than 3 on a scale of 0 to 5. The other challenge is 76% of the women had no leadership roles, and of the 23% women who had leadership roles, 40% faced barriers. While 53% had no structured mentorship program. However, I think this is not exclusive to women, this is also by men, so it is basically a problem for IR as a whole. What was alarming was 40% of the women experienced sexual harassment, and of which 28% reported explicit physical harassment, which is a shame for the society. 72% of us felt obviously missing out on family time, but this may be for men as well. And 43% got equal access to cases, whereas 57% reported that men were favored more when it came to complex cases. What was actually disheartening was more than 50% of the women, patients actually doubted the females first. And we had this open response, which was very witty, I would say, because she was asked, you know what, where is the main doctor? And she probably had been asked this question before, and she said, you know, today, I am the main doctor and I come with earrings and empathy. But, so I would say that this stereotype feeling is there embedded in us, like in the society. We have come a long way, but we still have a long way to go. We also did some comparative analysis between early career and senior career groups, and we found that early career considered leaving IR, and they were also involved in gender equity advocacy, whereas senior career group faced more gender discrimination. Let's come to why it is important to close this gender gap. Why? Because it's not about charity, it's about chemistry. So, data says that gender diversity improves team performance and innovation. More women in the clinical teams have benefited patient outcomes. Of the, in medical school, there are 50% medical students who are females, whereas IR has only 10%. So there is 40% risk of losing the untapped talent. Women in the team builds a sustainable, empathetic, and balanced clinical team. Greater gender representation boosts academic output. I'm not saying that, it's there in the literature. Inclusive environments lead to higher satisfaction and lower burnout. Lastly, the most important, how should we close this gender gap? And I threw an open-ended question where we said, what are the changes do you believe are necessary to make IR inclusive and supportive for women? And we got these representative answers. So I think I'll let you read through this. So we suggest that let's create structured programs where young women can see role models who look like them. Fair policies where we also on the survey had 62% of the women who actually felt that they got less paid when compared to men doing equal amount of work. So we should have fair policies, equal pay, transparent promotions, equitable case assignments. Leadership development where women are in the decision-making rooms. Obviously, maternity support would be good, flexible schedules, changing rooms, and childcare. Address radiation concerns and zero tolerance workplaces for bias and harassment. Visibility is important. Let's celebrate women in IR. SIR has got a Women's Champions Award. Maybe we could have something like that. We should have talks, storytelling, and panels, something like this maybe.
Last 2 minutes.
So another open-ended question, what advice would you give to the young you? And we had some very, very encouraging responses. This study will be published in CVIR shortly, and the editor has suggested that we do a comparative analysis with low-income societies versus the SIR and CERSE, so maybe we'll take that on. And lastly, we don't need just more women in IR. Basically, we need IR to evolve so that more women would want to stay. Thank you. Thank you so very much, Dr. Nilu. I hope this would make you happy. We are seeing an increased participation of women. in these conferences, and this year is the highest. Let me quickly ask the audience the question, what is common to Kevlar, Wi-Fi GPS precursors, and the improved medical syringe? What is common to these three? Kevlar, Wi-Fi GPS precursor, and the improved medical syringe. What is common to these three? There were women who invented them, ladies and gentlemen. Women have played an important role when it comes to science and research. But what does it look like, men versus women in IR? I invite Dr. Swati to lead this session. May I also invite Dr. M.C. Uttapa, Dr. Lijesh Kumar, Dr. Pujita, Dr. Saumya Chitra, Dr. Mandeep, Dr. Farah, Dr. Meenal. Please join us on the dais. Can we quickly applaud all the wonderful people who are on the dais?
Thank you. Yeah, it will be nice. No, but this is fine. Actually, I will invite some more men because many of the men who were impaneled have run away. So now it's my prerogative whom to call. I can see Sanjeev smiling there. Sanjeev, please. Please join us. Dr. Jairaj, come. It's all fun. We are not going to ask you to talk or anything like that. It's just a fun rapid fire. And let's see how men and women do. There are 4 and 2 more there they can join. Geetika, you would like to join here? So there will be 6 and 6. Am I right? Yeah. You have to go now? Oh, sorry, I forgot about it. Yeah. Virendra, doctor, please, Jairaj has some other commitment. Thank you. So by the time everybody is seated there, let me just take you to this session. First of all, I'm very happy to have this session in the main hall, thanks to Deepa, because first we are having this session, let me say that, because there were conferences where me alone or me and Mandeep will be the 2 women sitting in that entire hall. And I remember one of the conferences when foreign speaker started speaking, and then he just looked at me and he said, lady and gentleman, like that, because I was the only one there. From that, we have reached this level, and I'm very happy about it. So this is the way we have to progress with our talent, with our intelligence, and not using the card that we are women. We are same as you as far as the work is concerned. Let's see, but actually we are not same. God has created us differently. Men are not same as women and women are not same as men. We have some things which we can do better than you. There are some things which we do less likely or less better than you. You are better in them. So we are complementary to each other, and let's see how it works in interventional radiology. Now coming here, see, this is what they represent, men and women brain. Are we like that? No. I'm very sure people who are sitting in this hall, our brains are full of our cases and patients and strategies and all that, and we don't have time for all those things. So before we go to questions directly, I have, with the help of Deepa, we have divided the questions into some headings, and one question will come, and I will invite Aditya now to tell us how quickly we can answer, how men should, if the answer you think is men, you beat the drums in particular way. Aditya, please come.
Hello everybody. I urge you all to come a little bit front. If you can, I'll give you 20 seconds. Come fast. We just have very less time. So we have a lot of instruments here, so if you want to grab, you can just grab and sit in the white sofas here, and we'll start immediately.
There are more drums on the stage also,
yes.
People can take from stage also.
Please grab a drum, each one of you. Yes, you have to.
I urge people on stage also to take one drum, because your answer is not going to be vocal. It is going to be with instrument.
All right, I'll just...
Okay. Guys who want drums, there are enough drums here.
Call everyone.
Yeah, please come forward, guys.
Kumar.
Okay. You can explain now. The questions are going to come where either the answer is going to be men or the answer is going to be women. And how do you answer that? He will tell you. Aditya, please.
Yes. So there are only 2 beat patterns, and for women it's going to be, okay, so it's 2 beats. Yeah, 1, 2. And for men it's going to be on the rim. Right? 3 beats. Women, and then yeah.
So even in these drums, men will be making more noise. You can understand that. Okay. This is just to explain to you that, you know, it is not that your answer. If the answer to the question, suppose even if you people feel the answer to the question, men feel that it is woman, you should beat, or you should have only 2 beats. Okay?
Yes.
So answer, if the answer is woman, 2 beats. If answer is men, it is 3 beats. Okay?
Yes.
Clear?
So the beat actually goes like when someone, so when we have a question on the slide, you have to see there.
Oh, no, no, no. Okay. Then do you want to sit down?
Yes.
Or
Yeah,
you can sit down
sure.
or turn around. Turn around.
You can see here?
Turn around.
Yeah, sure.
No,
Can you
but
just
then
come
they have
forward?
to have this, to see the screen.
They can see it here.
These people
Yeah,
can see.
here. This screen is there.
Yeah, yeah, yeah. Okay, all ready?
Or you want
2.
to face the men and then.
Okay, so 2 beats for women, 3 beats if the answer is men, as well as there will be an opinion poll also which will be coming. Is it coming?
Yes. So when one question appears, you have to beat at the same time. So it will be sounding like, right? So women will be playing and men will be playing. We'll see which is louder. If is louder, men win. If is louder, you guys win. So bring out that energy and you guys got it.
So we are
Yeah.
all ready?
No, 2 beats.
2 beats, 2 beats.
2 beats, 3 beats.
It's very simple. Come,
Yeah.
let's go on. We have divided the questions according to some topics. The first we will start with work life. Okay? Here is the first question. Who reaches the cath lab earlier? No, Ash, you should not be beating the drums continuously. Then we can't make out who is who.
You have to beat at the same time. So on the count of 1, 2, 3, 4.
And now, here we are going to make a difference. People who are sitting there can scan and give your opinion. Opinion poll also.
Then men will easily overpower. You can't hear.
Oh, this is biased. Okay. Oh.
Come on, women. Keep playing.
Okay. We go to the next question. Oh, what is the final answer? Please, don't beat continuously, then we cannot make out who is who.
You have to stop at a point.
Stop at one point. Okay, so we'll go to the next question. May I have the PPT again?
Who leaves the hospital later?
Who leaves the hospital later? No.
That is
Yeah.
towards
Yeah.
the men.
I think, wait, I will have to say that first women to respond, then men, because everybody is
Correct.
hitting drums, so we can't make out. Okay, now let's start. Who leaves the hospital later? Who? And let's see what is opinion poll. Done? There are more men in audience? Okay, let's go to the next question. Who multitasks better during the long procedures? Okay.
No.
Is less. Yeah, that's what. So this opinion poll is, what do you say, tricked. Fine. Let's go to the next question.
The question to men
Who
is...
responds more patiently to post-procedure patient calls? Women. This is not working.
This is one by one.
But then it will go, we will see. Who? Any of the women, if you want to say that why you think that you are more patient? Do men think at least that women are more patient? No? No. Anyone wants to answer?
Actually, being female and I think genetically, we are more developed, more patient as compared to men, being at home or at work.
Only for 5 minutes.
So let me add a word of caution here. I think this is a stupid question. All doctors, irrespective of their gender, will have adequate patience and concern for the patient.
Perfect.
So this doesn't make sense at all. I don't think there is any difference between man and woman in terms of response to the patient.
Perfect. Perfect.
So that's a 50-50. Both of them win.
Perfect. Okay, let's go to the next one.
But I may add, this gender bias is largely self-created by Swati, I think. None of these questions.
No, yesterday in GBM I have proved that I have no gender bias. I refuse that we do not want any extra.
In the minds of the doctor, there is no gender bias. In the minds of the mentor, there is no gender bias.
Yeah, 200%.
Oh, no, I think this one question has got missed here. Anyway, but people have answered. Who plans cases more meticulously? Why do you think so? Dr. Farah?
I think women plan cases more meticulously because we're always worried about the complications. So you always have your step A, step B, plan D, plan E, whatever. Men always go in, and when there's a complication, says, "Oh, abhi kya kare?" So I think women plan better.
Women always overthink. So we are good at overthinking. So we plan cases more meticulously, I feel. We have it figured out before even we start the case.
And I think we have been ingrained to multitask and look at a situation like a 360-degree holistically. So we've been doing it since very beginning of our life. So I think it is just ingrained that we plan cases meticulously.
Any response from that?
There is no gender bias in them. Both the males and the females can plan it meticulously if they are properly trained.
I can see my mentor
Can you pass
shaking
the
his
mic,
head
sir?
I think
and saying that's complete.
I think the men can probably do it more meticulously for the cases because they don't do much at home.
But you see, this again.
No.
So Swati, this again depends on the training. All trained personnel will do adequate justice to treatment planning, and it's not something to trifle with. So I don't think any physician would take any liberty in planning the procedure.
Great, perfect. Next question, please. Who adapts faster when anatomy throws surprise?
On the count of 4. 1, 2, 3, 4. Now. Men, you have to listen.
Obviously, I think we will respond better.
Again, more men in the audience, so audience poll is always for men.
Yes.
Okay, next.
It's more real world and closer to reality.
Who double checks dosimetry more often? 1, 2, 3, 4.
What?
We don't check dosimetry, right?
Oh, so here women are more and men are less for once. No. They are picking up. They are picking up. Next, please. Yeah. Who relies more on gut instinct during difficult calls or difficult times? No, wait a minute. Now, time for women to answer.
Two beats.
Two.
Yeah, she's doing voting.
So she is giving voting to you.
We agree.
That's very sportive. Supporting them. Nice.
Okay. Next, please. Who explains procedures better to patients?
Both.
What? Oh, third option also should have been there, okay?
50-50.
Oh, super. 50-50.
Wow.
Best.
So I think again
it is no gender bias.
role of training, that's
Yeah.
only the gender doesn't make a difference.
Yes.
Then you have to. On the screen only men are shown. The videographers, please wake up. There are women sitting on this side. They are not shown on the screen at all.
I have to agree that is gender bias.
Okay, next
so
one.
For once, we
Next
are in
one.
agreement with you.
Who manages anxious relatives better or more calmly? Okay. So, what do you think? Women do better?
Yeah.
Very good. Nice. It comes inherently. Next, please. Who negotiates better with surgeons and colleagues?
Women.
We are much more diplomatic.
Your turn. You think you also do it very well? Okay. Oh, better. I see.
Better.
Who sends longer WhatsApp messages?
Okay.
Next, please.
Easily women.
There is no
Oh,
competition.
100%.
There is no
So
competition.
here, women will hands
Clear
down.
winner. 4%.
Okay. Now coming to cath lab realities. Next, please. Who complains more about weight of the lead apron? Yes. Now your turn. Oh.
Men, it's
women.
3 beats.
Always women. Okay.
I don't agree, Swati. I don't think anybody in IR would be really, we've been wearing it all our lives. I mean, I don't think we've ever thought of complaining about the weight of it.
It's not about doctors. Even the nurses are there, and I hear every day from the nursing staff, it's too heavy, those who are rotated. So it's common.
Yeah.
That's okay.
That's okay.
Should not be taken as...
Every day I can record and send on WhatsApp.
No opinion poll here.
So
Then
I
you
will,
must buy them
I
lead
will
which
tell you
fits
the
them in
difference.
their size.
So what happens is,
That's why lead free came.
men continue to wear the apron but complain about the backache. Ladies wear the apron and complain about the weight. That's the difference.
Okay. No opinion poll here. Nobody has logged in, looks like. Not working maybe. Okay, next please. Who actually wears lead protection properly? So everybody wears because this is not related to gender at all, actually. That's true.
Should be the lab.
Nobody takes radiation casually. Who survives longer without tea or coffee during long cases?
We survive.
Huh? No. No. What do you mean by no?
Means same. No difference.
No difference. Okay. 67. Okay. Who asks for a break first during the extended procedure?
Depends on the man's prostate size.
Yes.
Anatomical reasons, is it?
things we have to agree.
Now next please, coming to training, power and perception module. Who teaches fellows more patiently?
Definitely men. Yeah.
I think this question should be asked to the residents in fellowship programs or in DM programs.
Is there any fellows
Any
here?
fellow or
Any fellows
student?
here?
Any resident here?
No, they can just give the vote there. No?
More importantly, do you think the fellows are going to be in the hall?
No, here a little margin has come to the
Women's
women
side.
audience poll. Next, please. Who is stricter during the procedures?
Women.
I think
Women.
Women.
Yeah.
I think women are stricter.
Thank you. Who faces greater scrutiny in the workplace? Women.
Women.
Absolutely.
100%.
Many women say, in fact, that they have to work almost double in quantity and quality to prove themselves to be in the same shoe as their man colleague.
Correct.
Yeah. Next, please. Who silently keeps the system running?
which system?
The entire system in the department.
Yeah, we agree.
Women.
Thank you. You are honest. Okay, can we switch over to my PPT now because the polls are over? Thank you so much. Everybody really, what do you say, like nicely participated, enjoyed, and you had sportsman spirit. But just to prove that here we are not men versus women, we are men and women. Only women are less in number. You know, we are getting at a better number, better quality, better spirit. And you know, it is because both women and men work together, bring complementary strengths to patient care, training as well as innovation. As you know, that women's cricket team's T20 match final had equal number of viewership as men's T20 match this year. So previously we never even knew who was in our women's cricket team. So slowly they have progressed. We are also progressing because we have different styles, but our skills are same. We are practicing the same branch. One specialty, that is interventional radiology. We are all IRs. So on this note, may I request Aditya to teach us the note of ISVIR, which all of us will beat now.
Yes. So there are different beat patterns, right? There are so many different beat patterns, but there is just one rhythm. Similarly, there's just one IR. We are all one family. So let's try to emulate that using rhythm. So I want you guys to play 1, 2, 1, 2. So IS. And the men folks should play.
Stop. No, you can.
3, right? So on the count of 1, 2, 3, 4. Louder, guys, come on. Maintain speed. Guys, don't go fast. Ding, ding. Come on, men, join. Keep going. Can we increase speed? Men, what happened? still going. Done, done. Mute. Four, three, two, one.
Thank you, Aditya.
Thank you so much.
Everybody. Everybody participated so sportly. Thank you.
Thank you so much. Please place the drums carefully here. Thank you. Yeah. Thank you. And people who have instruments there, please place it on the table in front. I know they are tiny and nice, so you would want to take it home, but please return them. Thank you so much. Thank you. Any more?
That's good. Hello, hello.
My dear delegates, I request you to please settle down and take your seats. Dr. Virender is ready.
Yeah.
May I please invite all those who are standing there to please settle down, take your seats. Please sit back.
So good evening, everyone. I'll be presenting Storm P results, which were recently came out during TCT and VIVA meeting in United States. So basically, it's a landmark trial, I would say, first of its kind. It's a randomized controlled trial in which they compared mechanical thrombectomy using Flash 16 2.0, Penumbra CVAT, what we call computer-assisted vacuum thrombectomy, versus the standard treatment, which is anticoagulation. And the results were really, really encouraging, and I think from here, there is no looking backward. So we know that endovascular therapy for the treatment of acute P emerged almost 12 years ago, and we have seen the transition over this last 12, 13 years in which CDT, ECOS, pigtail maceration, thrombolysis, aspiration, angiojet. So we have seen, and none of the studies came out with really positive result, and we were hesitant to remove the pulmonary clots. So the mainstay still remained anticoagulation, followed by, if patient is unstable, go for systemic thrombolysis with inherent risk, which systemic thrombolysis creates. So Storm P, the results came in 2025, and I would just go over. So this is a simple slide which tells us on the one arm it is a system mechanical thrombectomy, on the other hand it is anticoagulation, and the results, how they planned the study was, so the total number of patients were close to 50-50. Most of the centers were in United States, and the inclusion criteria were intermediate high-risk patients. So clinical signs and symptoms of acute PE, which were less than or equal to 14 days or 2 weeks. CTPA showing filling defect in one or more main or proximal lobar pulmonary artery. Then RV-LV ratio, which was raised more than 1 on CTPA with elevated cardiac biomarkers. So what does that mean was, it is intermediate high-risk cases were taken for the study. There were exclusion criteria, CTEP, hemodynamic instability, which makes it basically a high-risk PE, primary brain metastatic cancer, life expectancy less than 3 months, and any WS2 score more than 9. So this was the flow chart: baseline, randomization, then after 48 hours looking at the primary endpoints, then at the discharge, which was 7 days or less than 7 days, 30-day follow-up and a 90-day follow-up. They did a functional assessment using multiple different kinds of questionnaires, which will be discussed. So this is a flow chart which I was talking about. So after 48 hours, they compared the ratio of the ventricular dilatation before discharge, the safety endpoints, and at 30 and 90 days, functional and quality of life assessments, which were questionnaires. So the primary endpoint which they were looking at was change in RV-LV ratio. So those group in which they had a thrombectomy and those group which had only anticoagulation, that was the primary endpoint, what was the difference between the two. And then they looked at the major adverse events when you're doing a thrombectomy with such a large bore device, whether it is risky or not. That was basically their secondary endpoint, which they call major adverse event, followed by the functional gain. So coming to the device, I think we have seen transition so fast that after CAT 8, when basically 12 and 16 came with a different algorithm, and suddenly after 1.0, 2.0, Flash 16 came, which was a game changer. So in this study, all the cases were from Flash 2.0 system. So this is for those who haven't seen. So the system is really, really good. The aspiration system is intelligent, and you can see the amount of clot. So when it is acute, it's just like I would say a minute job. Even if it is subacute, I would show the images when it pulls. It's unbelievable. And the blood loss is really, really minimal, I would say, but it's not zero. You can lose up to 200 to 300 ml as well. So this is something which opens the eye. It can pull really the stuff which looks like we have scraped it out with a tubing of 16 French, but that's how it comes out. And it's amazing. So before I begin, RV-LV ratio, an elevated RV-LV ratio is associated with greater than 2-fold increase in the risk of early death, 3-fold increase in the risk of P. And there is no rocket science. I mean, RV is trained because there is an obstruction there. We all know that. And this has to be the best prognostic marker once you remove the thrombus. So this is the flow chart. So they assessed close to 800 patients, out of which 100 were randomized. And on each arm, there were close to 50 patients. And then 7-day major adverse event rate assessed in this intent to treat population. So coming to the results which came out, the baselines on both the groups were almost matched. So both groups were well matched across key baseline measures. So that is one thing which is important. And if you look at the thrombectomy time, procedure time, estimated blood loss, as I told you, so it was somewhere between 150 to 300 mils. Technical success was 100%, and device-related complication was 0. Okay. So primary efficacy endpoint, RV-LV ratio, so they compared, so CTPA was done after 48 hours of the thrombectomy, and you can see between group difference, so there was real significant change in the values from baseline on the side where they had done a mechanical thrombectomy compared to anticoagulation. So this was statistically significant with p-value of 0.001. Coming to secondary safety endpoints through 90 days. So again, comparable 90-day safety rates, no device-related mortality, no PE-related mortality till the patient got discharged within or equal to 7 days. They also did a pre and post CT comparison. So they had that criteria in which they measured change in thrombus burden, significantly large reduction of the main, so they had that all the criterias are given in detail how they measured. So we know, I mean, when it comes out, there has to be a great reduction post thrombectomy. Then they compared other parameters like heart rate, tachycardia at 48 hours, again, significantly lower heart rate and significantly less tachycardia in CAVT arm at 40 hours. And we have seen immediately as you remove the PE thrombus, on table, we have seen the blood pressure rising. It doesn't even take more than 5 minutes. Your anesthetist will tell the blood pressure has returned back, the tachycardia is getting settled. So that starts on table. Oxygen requirement came down significantly, lower supplemental oxygen requirement in CAVT arm at 48 hours. Coming to this national early warning score, where the components are respiratory rate, oxygen requirement, blood pressure. So again, the CAVT arm had a significantly lower new S2 risk score at 48 hours. Coming to functional endpoints, so they evaluated multiple parameters by asking questionnaire. So post-venous thromboembolism functional status, and they found out that CAVT patients were almost more than 2 times more likely to move towards their pre-functional status, whether it be a 6-minute walk test or other parameters. So this is 6-minute walk test, which is considered kind of very important parameter. So CAVT patients walked significantly further at 3 months and had close to 2 times improvement in walking distance from 30 to 90 days compared to the other arm, which is only anticoagulation. So functional endpoint percentage of predicted 6-minute walk test at 90 days. So CAVT patients were able to complete significantly more of their predicted walk distance, because, I mean, the perfusion is better now. So the conclusions were very, very promising. STORM-P is the first RCT to report the results of mechanical thrombectomy with anticoagulation versus the standard of care, which is anticoagulation. The CAVT arm demonstrated superior reduction in RV dilatation and similar safety profile to the anticoagulation arm. Treatment with CAVT resulted in early physiological recovery and greater reduction in pulmonary obstruction compared to anticoagulation arm alone. Patients treated with CAVT demonstrated greater improvement in functional outcomes. These promising results reinforce the role of mechanical thrombectomy, specifically CAVT, as an effective treatment strategy in patients with acute intermediate high risk. So it is for intermediate high risk patients as of now. And I still remember when this device came and when we started doing it, we were really skeptical how would be the results. And the main concern was whether we will do any harm to the patient, because it's a bulky device. But honestly, in our hand also, as of now, no complication has happened. So STORM-P, this was in Viva, where the results confirm that improvement in heart strain has long-term clinical benefits. So 2.7 times greater thrombus reduction at 48 hours, faster physiologic recovery, 2.2 times higher likely to return to pre-function status, and longer 90-day walk distance. So these were the results of STORM-P. After this, I'll just go over the importance of a PERT team, and then if we have any questions, please feel free to ask about the study. So I'll just go how important a PERT team is nowadays in a hospital setup, because we still remember before we had a proper PERT team, it was very hard to convince where these patients should go. There was always a tussle So venous thromboembolism, we all know it's a deadly disease. We are studying from our MBBS days, very high mortality, and we didn't had much to offer to these patients. So why multidisciplinary approach? Because nobody knows when a patient comes to a triage, where it should be sent. Cardiology takes over. Sometimes it goes directly to a critical care. It can go to a respi guy. So unless and until you have a proper team, it's not going to work. So rapidly, I'll just go over the PERT. So which specialty gets to treat it? So I think the answer is PERT. So pulmonary embolism rescue team or response team is the answer, because it's almost like a stroke. When you have a proper protocol, the results are coming great. Same happened with what they call PAMI or acute MI. Now they have a set protocol. That is how it should be. So rapid assessment, risk stratification, multidisciplinary consensus, which patient should go for anticoagulation, which patient should go for systemic thrombolysis, and which patient should go for aspiration thrombectomy. So common goal of improving patient care. We started when it came almost 2 years ago, and then we started creating awareness. We call our ear docs, we call our respi, the cardiology colleagues who were doing echos, and then we started creating awareness. And from day one, we knew that it's going to improve. So I'll just share the statistics from Jan 22 to 23, pre-PERT and post-PERT. So we made a team where we made our cardiac surgeon, the head of our hospital, as the chief of the PERT team, and then all the specialties were included. And then the referral patients started increasing. We even started getting patients from airlifted from other cities as well, as the awareness started increasing, as the outcome was better. Now all our critical care guys, ER, whenever a patient comes, we get a direct call, so-and-so has been done. The cardiology guys come there for doing an echo. The radiologist knows whenever the patient goes for CTPA. So we have a team, and that has completely changed the outcomes. So baseline characteristics, pre-PERT, we did 150 cases, and the cases increased to 240 next year, just because of we had a good team. And I'll just go over the changes. So and mostly these patients were again intermediate high risk. Now we have started doing intermediate low risk as well, those patients who are on borderline, and we think that they have basically changing parameters. So here you can see most of the patients were intermediate high risk, and the number of patients increased after the PERT team for follow-up. So from 75 to 180 cases, so there was almost 250% increase after the PERT. Direct referrals, and there were different patterns. The ICU guys started calling directly, cardiac unit, and then referrals from outside and smaller hospitals as well. So just to share a few cases, on table we can see there are changes. Time to triage decreased, time from diagnosis to anticoagulation, and time from admission to access or the puncture time. Treatment strategies, I would say mechanical thrombectomy was, you can see how drastically it increased from 7 to 54. So that was a major change. So everyone starts and call, and then us, and then they say like, if a mechanical thrombectomy is possible, so go over and see it. And the length of ICU stay, total length of stay, inpatient mortality has decreased significantly. And as you see, the complication rates are really low. So limitations, yes, it's a non-randomized data which we have taken it out, but I thought I'll definitely share for those who want to start PERT team. It doesn't disappoint. It will definitely increase your numbers as well as your expertise, and finally the outcomes of the hospital. Thank you. So, there are two important, over time I have learned. So it's a costly catheter, we know. It's almost like 12 lakhs MRP. So initially even we were worried for pulmonary embolism, how will go? So we requested the hospital if they can do a split billing. But with insurance, it's not easy because they need everything. So what we have, and when we realized that if the anatomy, we used to go over the city and we burned our finger. So we tried a reuse catheter in few cases. It's not easy. Patient is already intermediate high risk on a borderline. So now we have made a protocol that whenever a PE comes, unless the anatomy is really good that the catheter may track, so we tell our patient. So it's almost like a MI, or I would say a stroke or a ruptured aneurysm. Most of the patients agree, sir. So that is how we have projected that this is a life-saving procedure, and the conversion rates, I mean, we do lose patients also who cannot afford, but the conversion rate has increased. Once you tell that it's a life-saving procedure, somehow they manage. So that's how I think we have to project.
I think the biggest success for it is headed by a doctor and
Yes,
who is
sir.
a cardiothoracic surgeon.
Yes, sir.
Your hospital head is a cardiothoracic surgeon
Yes.
who understands PE.
Yes, sir. Yes, sir.
But it is going to be difficult in many corporate hospitals to do the split billing.
Yeah.
Where you have guys from the accounts who are going to tell, I cannot do it, I cannot do this, I cannot do this. So that's why I wanted to ask you,
Yeah, but
how
sir,
you managed it. Yeah.
Sir, P will work. Like out of 10, I think at least 6 patients will agree. When they understand the severity, they'll come up, and somehow, I mean, nowadays the economy is not that bad. Patients may, that's what I think. Yeah. Yeah, Farah.
Thanks for the presentation.
Thank
Two
you.
quick questions.
Yeah.
I saw on your slide that yours do high-risk PE. So do you have an ECMO team on standby? Because
What?
do you have an ECMO team on standby?
ECMO team?
ECMO.
Yeah, we do have.
Yeah.
We do have.
So in your hospital, you have an ECMO team which
Yeah.
stands by,
Yeah,
right?
we do
For
have.
every patient that you do. How many patients have actually desatted when you've put the big catheter through? Because everybody says that they are okay. It's even intermediate high risk. If they're very stable, once you put your catheters through your tricuspid valve with that 16 French going through, they can suddenly decompensate. So have you had patients who've
Yeah.
decompensated? Because not every hospital will have access to ECMO. And that is when you have to decide what you're going to do, because you will lose patients
Yeah,
doing these.
very
Because
nice.
they're high-risk patients and they
Yeah.
will die on your table. Yeah.
Agreed. Very nice question. I think ECMO, there should be a backup ECMO. I should have mentioned that. I would say, I remember 2 of the patients who really got sick, but then they were on the other side. They were really, really sick when we started. And initially when we started this, we had CAT 12. You used to put a big sheath across the valve. As soon as the bigger sheath used to go, the cook sheath, the patient starts right at that time that something is happening. So now we go sheathless. 16 device is great, but still I would say this can happen, and there has to be an ECMO team available. That is for sure, because and there will be a day we'll derange a patient. It can happen, definitely it can happen. But we have to choose our patients very, I would say, selectively, in the sense those patients who really don't need, we should not intervene. And that is very important. And go over your CT scan, plan how the angle is, take a pigtail, don't cross it with just a plain Terumo wire, because you can go through the wrong side of the valve, and people have reported it, the rupture of the cordy right on the table, and patient have died. So that is also important. Thank you.
Thank you so very much, Dr. Virinder. Can we give him a nice big round of applause for taking us through this incredible session? Thank you. Next up, we're going to look at the next generation of devices, and I invite Dr. Rohit P.V. Nair to take this session forward. Ladies and gentlemen, while Dr. Rohit sets things up, let me quickly tell you that tonight we are going to have a very long and extended party. At 7 o'clock, we are going to be partying first near the wharf. And then we come here to this very hall. In this hall, there will be dinner and dance. It continues. So be there at 7. We have starters, we have fun things for you to do. There's a band that's going to perform. And then all of us are going to come to Oceanic, and the party is going to continue through the night. So make sure that you make the most of it. And also today, traditional outfits. We have given you dhotis, we have given you saris, so please come in that wonderful attire. Thank you so very much. Over to you, Dr. Rohit.
Thank you.
I just want to speak to Dr. Murli when you're talking about convincing power. And if you look at it, when the TAVI came, I was just referring to your previous question. When TAVI came, it was about 22 lakhs. And we used to wonder how the cardiologist is going to get people to do TAVI. We thought it's going to fail. Now, how many TAVIs are being done every year? So the convincing power of interventional radiologists are a bit lesser compared to the cardiologists.
No. See, we convince patients who are all aneurysm coilings and flow diverted. That is fairly easy.
Yeah.
But when here the patient comes with a PE, when they go to they are initially seen with the emergency guys, and they go to the ICU guys, they tell that I'll make you all right with heparin infusion.
Yeah.
Or I'll start you a streptokinase infusion. So that's where the problem starts. So you go and tell them, you want to convince them, they tell that thrombolysis gives excellent results.
Yeah.
That's where the real problem comes. Then they tell it's very expensive, I'll get the same result.
Yeah. Okay. We've got a very, very thin audience, which is quite understandable. Last couple of hours of the conference. See, I'm going to talk about, just a disclaimer, I'm a proctor for Terumo. But again, at the same time, I do not speak on things which I do not believe in. So this is an industrial talk by Terumo Aortic, as requested by Dr. Deepa. I'm going to talk about the Relay Pro device, which very quickly, most of you know, there's nothing too different, but there are a couple of things which are very important about the Relay Pro, which I want to speak to you about. The design technology, the performance zones, which is something unique in the Relay Pro. But all of you know, just as an introduction, it's a polyester woven fabric with nitinol skeletons. And there are a few radio markers that you will see on the extreme right. You've got the proximal tube markers, you've got the two-body dumbbell markers, and you've got the marker which is in the outer ring at the 100 mm graft. Okay? And you've got 3 distal dumbbell markers. Those who have used fenestration, it's a dual sheet system. Those who can fenestrate the dual sheet system, you can use one of these markers to mark your inner sheath fenestration. Again, what is the biggest advantage of the Relay Pro is the access size. You know, the arteries can be, you can do it up to 5.5 to 6 mm of non-calcific artery. It's actually really low profile, and I think that is one of the biggest advantages of Relay Pro. So if you have patients, especially the Indian patients, obviously the arteries are smaller, especially the access arteries, and they've got diseases. So this is one device which glides in quite easily. And it's one of my go-to devices for really small access vessels. This is the only thing in this particular slide you have to look on is the performance zones and the S-bar technology and the dual sheet technology. See, these are the very important aspect of the Relay Pro which you have to, the rest all is fine, but the most important are the performance. I'll be speaking about those things specifically so that we don't spend too much time on the whole description. You have got the stent diameter from 22 to 46, okay, and that's, you've obviously got the bare stent and the non-bare stent configuration. And the stent graft diameter for the distal length bar stent is about 22 to 38 diameter, it's 25. Again, these are something which just for you to know, okay, but you remember it's 22 to 46. It's a wide range. And I'll show you how what the exercises are in a few minutes. Okay. Obviously, it can be used anywhere. The ascending aorta, I personally use the NBS. We had a live case for IGT where we use a Relopre for a supraannular deployment. Again, you have to be very careful with it. We do it under pacing. Different zones of the aorta, again, you can, I always, we prefer to do beyond zone 1, and only if pushed, we go to zone 0. And if it's a zone 0, then obviously for me it's a Relay Pro. Okay, I'll just go to, this is the one which I want to speak to you about, the zones. Okay, now on the top you have got the alignment zone, which is the non-NBS, with the bare metal aspect. Alignment zone it's not a fixation thing. It's just so it has got different lengths for the Relay Pro, and you have to select for each patient. Obviously, the company measures it. I think the Terumo company uses 3 Mensio for measurement. I use Radiant. You have to select even the NBS lengths depending upon what length your landing zone is in, because it's only for alignment and not for fixation. Remember that. And there's a proximal seal zone. Again, the radial force is quite high, so you get a seal. This bit is a flex zone which I requested the company. Now the flex zone is about 20 mm below. It doesn't have any radial force. And the reason is so that you can just conform it quite nicely. It can go against steep arches. But what I have requested the company a couple of times is that I think this flex zone should be a bit more, we should be able to sort of tell them where we would like, not always in the top bit. You might have a really steep aortic arch, which is across the mid bit. So if the flex zone can be a bit more distal, it'll be even better. So flex zone, very important for this. And then there's a secondary seal zone behind it, okay. Main body zone, as that's no different from any other company, and you've got a distal seal zone. Again, you just look at the radial forces, the highest in the proximal seal zone. This is for the NBS. They do not have an alignment because obviously they don't have the bare metal aspect. It starts with the proximal seal zone. The rest is no different, it's all the same. Yeah, so I was spoken to you about that. So you can see the variable bare strength line from 13 to 21 mm. So these are the bare metal strength that you have, and you have to select different for each patient. And they have got various combinations. Okay, let me just, for want of time, let me go through this. This flex zone, this is the one which I said, 3 to 4 mm of free space to provide independent articulation. And this is one which I've, again, repeatedly telling, I don't know if the Tiruma guys are here, that this have to be moved a bit further down so that we can go across steeper arches. And below that, you have the secondary seal and fixation zone. So I'll skip all that. That's not important. Now, if you look at the performance zones, decide to each one. You can see how they have used for each different diameters from 20 to 26. It's about 5 proximal stem axes. So it's all it changes according. So it's a very flexible, and you can actually fit to the anatomy quite well. That's the only thing you have to see. You will not remember all these measurements. This is in the slide, I'm telling it to you, but just remember it can be quite conformed to what your patient is. Okay, and then there was an ulcer cohort and a thoracic study for which they said the type 1A into leak was 1.8% with this thing. Now, this is the other thing which is quite unique. There's a nitinol wire which goes sort of obliquely, which starts about, I think, 25, yeah, sorry, started from 25 mm from the proximal end. The idea is to give a good columnar strength, at the same time not make it too stiff. And this is also quite unique for relay. So remember, it's the access size, the S-bar technology, and the performance zones. These are 3 things that I want you to take from this study. And yeah, multiple size options. Okay. They have got a tapered, straight and a tapered. The tapered is only up to 4 mm. Most of them are up to 4 mm. There's one company which provides up to 8 mm tapering, but this is about 4 mm. Okay. Okay, and then as with Cook, they also got a wonderful. I've not been lucky enough to use it. They've got a custom-made program for scallops and for fenestrations. So this is again, remember the outer diameter. This is not the inner diameter, it's the outer diameter. Minimum of 19, maximum of 23. So even the 46 comes up to 23 French. So that's how low profile it is. And you can usually if you can use it in quite calcific aortic bifurcations as well. Okay, now in comparison to Terumo, somewhere quite close by is obviously Cook. But as you go to a higher diameter, you can see 32 to 33 comes in a 20 French as opposed to Cook's, which is a 21 or 22 French. And higher, 41 to 42, comes in a 22 French compared to 23 of Cook. So this is by far one of the best low-profile devices you have. If you remember, Cordis had the Incraft, I know it must be in Singapore, and it was there in the UK as well. The problem with that was, while making low profile, the actual nitinol system was very weak, and it used to collapse at the aortic bifurcation. So this particular system doesn't have that. Okay. Okay, again, this is a dual sheet technology. There are a couple of other companies who've got similar. The advantage of the dual sheet technology is just accurate placement. The windsock effect is less. You can be a bit more relaxed. You don't have to clench your buttocks. If you're going to zone 0, you can take your time a wee bit. Yeah, so I'll just go to a few tips. Now, if you look at these support wires down in the screen, I don't have a pointer. it's a very clever thing. So basically, it's an atraumatic tip. It sort of is designed to be in the inner curve. Why it is there is, as you open, it forces the graft to align the inner curve. And then the bird beaking, it's not that it never happens, it does happen to a certain extent, but the chance of bird beaking is quite less. This also is quite a good, quite a good design feature of the Relay Pro. And yeah, so let me just skip all, because this is no different from the other thing. I'll be showing you the Trio in a couple of minutes. There the clasp is a bit different, but this is not much different from the other devices, okay? And then I'm just going through because I want to show you just want to show you the deployment video. Okay, I think most of you must have used anyway by now the Relay, or even the older device of the Relay. You've got the 4 positions. One is the advancement positioning. Position 2 is deployment. The initial bit is it's quite stiff. You have to have a bit of strength, but then afterwards it's just quite smooth. And then position 3 is release of the proximal stent. It's quite an easy thing. I mean, you may have to have a technical proctor for your first maybe 4 to 5 cases, but after that you should be able to do on your own. Okay, now let me just skip all, that's all not important, but I'll just get you to see the actual deployment video because that'll be more interesting. Okay, so just make it if it can be bigger. So it's got an outer and inner sheath, you know. It's a control hub. That knob you have to actually loosen it, and then yeah, so you're advancing the indicator. You have to go past indicator. So the outer sheath is parked about 20 to 30 mm below where you want the distal sealing zone, remember. Okay, the usual flushing of system. Over in Lindicus Y, you've done anatomy. See, remember it's parked below the thing. You can see the tip. You can see the nose cone which is below the sealing zone. And you're in position 1. So clockwise, and you're unsheathing the outer device. And you can see the inner sheath going all the way to where you want it to land. And you can adjust, the zigzag markers, you can come up, go front and back a bit according to what you want. And then you're changing your position. So here's where it is actually quite controlled. It's very controlled, and you don't have to be worried to do it very quickly. It's actually quite controlled. So it has got a lot of, it doesn't actually come back that easily like the other normal graphs, especially the dual sheet systems. They have got the Mentis, I think there's a workshop again tomorrow, I think, and you can try that. There was a session yesterday. Yeah, and it looks good. And then and there are a few steps to grasp the thing back, okay? So, just a quick clinical case, a patient who's had a previous endologics in 2006, endovascular aortic aneurysm, and the patient had a type 1 endoleak which was fixed. The patient had a limited thoracic dissection which then became aneurysmal. So that's the CT. Okay, so we have seen enough of that. You can see the previous repair, which looks pretty okay. That's the reconstructed. So that's the angio, the pre-op angio. It's pretty straightforward. So it was sized to be a 42-38, 4 mm tapering, 150 mm length. I think the length is up to 220 for the Relay Pro. So this is a bare metal one, which is very straightforward. And then there's a follow-up CT. There's another case which was done, which I was not very convinced with, so I was not going to show you that. But this is just to show how this is quite an easy, straightforward case, but good for a starter. Okay, so now the clinical evidence, we don't have much studies. I have multiple studies and registries given. And obviously it shows less than 2% type 1 endo leak even in a 10-year follow-up. That is pretty good. I should say, to be fair to other companies like Cook and Go, they have got a similar sort of result. But 1.4% is the lowest for Terumo, which is very good. Okay, I'm just going to skip the rest of the slides because I think that's probably not important at this point of time. Sorry. This is a very short presentation. So how many of you used the Trio? I think most of you have. You have used it, of course. So they are coming up with the Trio Fit. I don't know soon. So Trio Fit is something is that it's like everything in one. So if you're doing a fenestration, it's a right question, Raj. You're going to bring over the Trio Fit soon. That's got everything for you. You don't need any. You don't have to separate sheets. Graph cord tree wires. Nothing of that. Everything comes with the covered stents in one package. But Terumo being Terumo, I'm pretty sure it'll be about 12 to 15 lakhs for the whole thing. It's very costly. Okay, now this one again. It's obviously Terumo came with Anaconda initially. It is a beautiful graft in the sense that. It can be used in the angulated but long necks. I think initially, when it came initially, a lot of people were using it. It's a new graft, it's a new toy. They're using it for short angulated necks, which is causing problems. And then obviously when you don't use it for the right patient, everybody blames the graft. Anaconda is a graft which has been used for long curve necks. But now they have come with the Trio. That's a history. It was initially Bolton's and then taken over by Terumo in the early or mid-20s. Okay, all that is not much different. This is something which is, they've got multiple combinations. And if you see the main body, which I'll show you in a different slide, they've got, I think, up to 100 mm. They don't see, there was a study when initially grafts, I think the Cook is the only one which has got longer main bodies. Because usually it's about 50 mm, but I think Cook has got over 100 to 120, and similar with the Terumo. The idea is to keep the bifurcation of the graft as close to the natural bifurcation as possible, which is why they have come up with this combination. And it's a very straightforward thing. Obviously, it starts from a 28. So you can see, this also has got from 80 to 120 mm. So the main body is about 90 with a minimum of 50. So that allows you to bring the bifurcation a bit lower. Okay, and this is a study wherein you say the L1, L2 is basically L1 is the main body, so the higher the ratio, so that's towards this end of the graft, your force is much lower on the graft. So the chance of type 3 late is much lower, is what the studies have shown. So this is a very clear picture. You can see that 80, 100, 120. They have got flared. Again, this is no different from the other graphs, so I'll skip this. I'll tell you what is a really important, really interesting or good design feature for this one. Is now in this particular thing, they have got this inner air traumatic clasps, which actually clasps the limb that goes in. So chance of migration is very low, and that will show you in a second. Yeah, so angulation up to 75 infrarenal neck angulation. Obviously, you had the other graphs like the AOFix, which can go up to 90 degrees. We don't have it here in India. This slide is a comparison with aortic and Medtronic Endurant. The maximum infrarenal angulation is less than 75. It's similar. Minimum aortic neck length is 10 mm, which is similar. Again, this is maybe something which I don't completely agree with. I think it's better to go as away from the disease bit as possible. So I would stick to 15 mm. And then obviously you've got both the suprarenal and infrarenal fixation with the Trio. Medtronic only has got a suprarenal fixation. Okay. Now this is one thing I want to tell you about. You see the small pin, the suprarenal fixation, everything is got, everybody has got it, but I don't know if an arrow, but yeah, you can see it here. So they have got this laser cut barbs, which is part of the infrarenal bit, and that also gives a pretty good fixation, and the chance of caudal migration is quite less. Okay. And I'll just, that's engage steady. Again, all of you know the engage steady, so I will not, it just says the type 1A and the type 3 are the higher, the most they have seen in the engage steady. Type 3 is what they're going to show now. This is what I told you about. In the main body, inside the ipsilateral and the contralateral limb, you have got these rounded barbs, which holds the limb. And I mean, it's a very, very simple, clever idea. And you know, the chance of migration is quite less. Although we have to wait for a few years to see. And the other feature which I would like to show you is, I'm going to skip through all this. I just want to show you this. Okay, so again, the main body, 30 to 36, 20 to 28, you can see the French sizes. Minimum is 19 French, minimum is 18 French and maximum to 19 French. So again, the low profile is amazing for Trio. I think there are many, obviously there are newer companies which are coming with lower profiles, but at the moment, this is one of the best around. And it's an easy pin and feel unsheathing. You can reuse the sheath. You don't have to change the sheath. The sheath exchanges less. That's one of the good advantage of Trio, just like Cook. Okay, I'll just skip all that because there's no, you'll not understand all this all of a sudden. This is one important feature. I'll just show you. Just one second. Yeah. See, this is quite nice. If you look at the proximal, the cusps, you know, we have been always taught to go up or go down, get to the main graft, and then, then retrieve the nose cone. The problem, the Endurant obviously is they have got that open nose cone here, just here, and it's quite dangerous. At times, obviously, I also had a case, obviously, when I was working abroad, wherein the barbs got just very careless of me, but we just I couldn't do anything for it. Ballooning everything, I couldn't do anything, so it had to go for an open procedure. Whereas this one is quite clever. It's quite blunt, so there's no chance you'll get caught. So you can easily retrieve without any problem. Obviously, be careful, but you can. It doesn't get. So this is something which is slightly different from Endurant, and I think this is a pretty clever design of Trio. Okay, thank you. I think that's more than enough for you guys.
Thank you, Rohit. That was a good this thing, though it's a company presentation.
It's a company presentation, not mine.
I know that.
Yeah.
See, there are only two things. They talk about a 46 millimeter device.
Yeah.
I think one of the biggest risks for a retrograde type A dissection is a larger ascending aorta.
Yeah.
I think that's the reason all the other companies stop at 40 or 42.
Correct, yeah.
Do they really have any data to tell that with the 46 they are more safer?
No, so the 46 mm has been, I think, anything, so if the ascending out is more than 40 mm, it's abnormal anyway. So we wouldn't do anything more than 38 into zone 0. Yeah. 46 is more towards zone 3, zone 4 if you've got a large aorta.
Even there, is it so safe? That's the issue.
Sorry?
Even there, is it very safe, this 46 or something like that?
I mean, so if it's zone 4, zone 5, if it's a large aorta, I think it's okay. It shouldn't be a problem. But in the ascending aorta, obviously, anything above 30 is something which we don't use. And again, I rarely use it. You know that.
Very impressive results with AAA, the long-term follow-up and this thing. Usually, Cook used to have the good results. Now, Trio seems to have fantastic results in the AAA.
Yeah. They are developing a registry which is quite good. Terumo is planning to develop a registry, obviously try and work with us. I think they had a few chat with Viren.
Only thing is the cost seems to be a little more. And,
so that's a problem with Terumo.
And we are the highest users of the Terumo FET graft in the country. And in the country. But still they are expensive for us in the endovascular segment also.
It is quite expensive, yes. So the cost is going to be a challenge, but we have been told by the company that they might think of something which could fit for the Indian public. Farah?
Thanks, Rohit, for that. Yeah. One quick question. Your graft has those little hooks which come at the bottom. So what is the proximal landing zone for this graft? Is it 2 centimeters?
For the trio, for the abdomen.
For the trio, yes.
So they are saying with an angulation of less than 75, it should be minimum of 10 mm. And I told you in that disclaimer, I have a bit of a different thought process because it's not about the landing zone. You know it's an evolving disease, so you may have to stay away from the abdominal. So for me, it is still minimum of 15 mm. So that hasn't changed for me.
No, because there's a whole load of publications out there with the aphthous, because you can use the aphthous screws to fix for a short angulated neck. So I was just wondering whether if you have your hooks which are downward facing, whether that gives you a better fixation in a short angulated neck, or is there some sort of, what is the IFU for that?
For their IFU says 10 and that short, the infrarenal barbs you're talking about, that's more to mitigate the migration, long-term migration. Caudal migration is less, but the actual ceiling, which they say 10 I think should be at least 15 But the caudal barbs are mainly for the caudal migration not to happen. The infrarenal. That's also a pretty clever design. It just hooks onto the aorta. On top, yeah. No, that's true. Yeah, is it ovation? Yeah. Nelix, yeah. Okay. Okay, thank you, thanks. It's time for party.
That was the last session of the day. A big round of applause for Dr. Rohit. Thank you. No, we are not ready to party yet. We have the grand quiz that's going to unfold next. Yes, no worries at all. It's okay. I know you want to party and we're all getting ready for it. Just a gentle reminder, we'll be partying at the wharf and then we will come back to this very hall to have our dinner and more music and DJ over here. We're going to gear up and get the stage ready for the quiz that's going to happen. It's a grand quiz that we're going to see. Prizes up to rupees 60,000 up for grabs. The finalists are going to be battling it out on the stage.
Vincent.
Good evening, ladies and gentlemen. We are all set to begin the quiz, and we invite our participants to join us here.
I want to make sure the presentation is here.
Yeah. The participants of the quiz, we invite you to please join us on the stage. There's already one team on the stage. We want you here so we can check the buzzers. We can do our preliminary hygiene checks before we begin the grand quiz. This will be led by Dr. Sanjeeva and Dr. Murthy. Dr. Sanjeeva, the participants who are there, wonderful. That'll be really great if you can show your support. Come forward and fill the chairs, please. Come forward. It's going to be very interesting. I'm told this quiz is much sought after and really some amazing prizes. And also a quick reminder that the party begins near the wharf at 7 p.m. So please be there. And then it continues at the Oceanic after 10:30. We'll have our dinner here. So remember that. And please come in your beautiful traditional outfits. If you have still not collected your dhotis and saris, it is near the kit counter. So please collect them. Contestants, once you have settled down, we urge you to check the buzzers and mics. I will tell you, I'll give you the cue. May I please invite Dr. Kunal to join us on the stage because the presentation is in your laptop, so we urge you to come to the stage.
Is it on now? Okay. Hey, Kunal is here. The presentation loaded. Yes. And we'll ask them to introduce themselves first. Yeah. Okay, as we wait for the presentation to load, we're going to start the quiz soon. And welcome to the ISVIR 2026 quiz. First of all, congratulate these teams first, making it to finals. We'll start with introductions. I'm Sanjeeva Kalva. I'm a faculty here and I work at Mass General before and now at UT Southwestern. Okay, let us go ahead and introduce yourselves.
Hi everyone, my name is Dikshit Verma. I am a final year IR resident from Grand Government Medical College, Mumbai.
Hello everyone,
I'm Dr. Snehal, and I am final year DMIR resident in Grant Medical College, Government Medical College, Mumbai.
So give a big applause to Dikshit and Snehal. Good.
Good evening, everybody. I'm Dr. Abrar, IR resident from KMCH Coimbatore.
Hi, I'm Dr. Venkatesh. I'm final year resident at KMCH Coimbatore.
Myself, Dr. Anshul. I am from NH Bangalore, second year resident.
I'm Dr. Aditya, final year resident from NH Bangalore.
Talk to the audience.
Myself, Dr. Shubham Yadav from GMC Nagpur.
I'm Dr. Aman Yusuf Khan. I'm final year resident from GMC Nagpur.
You want to lift it up? So we will check whether they can see the TV and the images well. Okay? Going to put that one?
I am Dr.
Disconnect
Sivachandar. I'm coming from, I am doing DM intervention radiology in PJ Chandigarh.
Up.
I am Dr. John V. Alexander. I am also doing DM in PJ Chandigarh.
Introductions over. I want to make sure the first slide shows up. They can
I
see it.
am Dr. Vineet from Gangaram Hospital, Delhi.
I'm Dr. Ravij, DRNB resident, Sir Gangaram Hospital, Delhi.
I think we need to bring more audience here. Very few people. That's the most interesting part of the ISVR conference, but I'm very disappointed with the number of people on this audience. Please call your friends to come. And all of you, call your supporters. Who's going to cheer for you? Nobody comes from your institution. Huh? Good. Can you see this is not working? Where is Murthy? They need to set up his mic too. Yeah, we can go and start our introduction. Okay. I want to make sure this plays before you start.
Hello. Thank you.
This is not connected, I think. Can you check whether the buzzers are working for you? Buzzers are not working. Oh, so when something else already working, already pressed, nothing will work. That's a good thing. It's exclusivity. So nobody will take your chance. Murthy, you got the one?
Yeah.
Okay. Huh? Whatever, yeah. I'll stand on this side. Whatever, you can just move back and forth. Okay, looks like you're able to see the screen now, okay? Visible for you, all of you? All 6 teams, comfortable? And am I audible to you all clearly? No resounding? Kunal, you want to start the presentation? Okay. Can you all see the screen showing first slide? Can you confirm? You can all see the screen well? No glare? You don't need to tilt the screen, nothing? It's all good? Okay. Go ahead. You want to take this? We can take one of these mics here. Yes. Okay, guys. Audio visual guys, this screen is somewhat blurry here. I think it's everywhere the same. I think the way that slide is made. Okay. And there also same thing on the screen. So it won't. Not yet.
Yeah.
And now we can.
Yeah. Hi. Good evening, everyone. Good evening, everyone. Welcome to ISVR Grand Quiz. And this is done in the name of Dr. Akash Hardik Memorial Quiz. And this is a grand quiz which we are organizing for this 20th ISVIR conference. And so this year the participants had really increased, and we had conducted a preliminary round. So approximately 70 teams had participated. So approximate number of participants were double of those, so 140 participants. And out of that, we selected 6 winners, and these are the finalists who are being done. So please give them a round of applause. So every year it was around like 45 to 50 teams, but since there is significant increase in the popularity of this quiz, it has been increased to 70 this time, and out of this, six teams have been qualified for this grand quiz. And we, as a quiz committee, thank ISVAR for giving us the opportunity to conduct this quiz again. And these are our quiz masters for the Dr. Sanjeeva Kalwa, who needs no introduction. He is a chair in Southwestern University, Texas. And Dr. Murthy, who is along with him, he's also in Texas. So they would be our quiz masters for today. And what we do, let's play Jeopardy. It would be in a Jeopardy format. Let's have some fun and earn. So the first prize the winners will get 50,000 rupees. The team will get 50,000, second would get 40,000 rupees, and third will get 30,000 rupees. Over to the quiz masters.
Thank you. Thanks for the introduction. Okay, let's go to some general rules. The participants, please switch off your mobile phones. And if you have any Bluetooth, please remove them. And in the audience, please try to switch off your phone so that there's no disturbance while the quiz is going on. Most important thing, if I can't hear your answer, I can't give you points. Okay? Speak loudly and clearly so that I can hear. I have some deafness, so if you don't speak well, then you lose the points. And then of the 2 members in each team, only one gives the answer, not both of them. You can decide who is going to give the next answer and be ready with the answer. Answer only on your turn. If you answer out of your turn and the other person picks up your answer, the other team will get the point, not you. And the decision of what I say is final. Okay, you can disagree with me, but what I say is the one at the points. And I request the audience not to prompt the answers. I know these are very easy questions for you, but we are testing a DM students here, so please don't answer them. Okay, so we have mainly 2 components, not 3. First is Jeopardy. We have questions for different points, 100, 200, 400, 600, 800, and 1,000. We will give 45 seconds for the question. Time starts after I complete the question, either I or Murthy. Only one answer for the team, and no negative marks if you give a wrong answer. You can give an answer or you can tell pass. Once the 45 seconds passes, I will tell pass. Once one of us will say pass, all other teams can buzz if they know the answer. It doesn't go to next team. Whoever buzzes first, they will get the chance to answer. Okay? If that person tells wrong answer, it goes to next buzzer person. You follow me? If all that 6 teams fail, then we'll ask the audience to tell the answer. If they fail, I will reveal the answer. The first team who gets the question, if they answer, they will get 100% of the marks. If it is passed to next teams, then they'll get only 50% of the marks. We will have a second round called rapid fire. You have 90 seconds. You can answer as many questions as you want. If you don't know the answer, I recommend quickly deciding and pass, so you have more chances to get more questions. And each question carries 200 marks, and there is no wrong answer. No marks for wrong answer. So, all good? Everyone ready? Murthy, are you ready? Audience? Okay. The first question goes to... Yeah. The chance is team A, right?
A should be okay, because any which way there's no, it's buzzer.
Okay. Team A.
You need to choose one of that.
Which question you want? You can help. Yeah.
We'll choose procedures or treatment.
What number? Okay, procedures 200.
Procedures and treatment 200. Okay.
What are the indications for this procedure? Your time starts now.
It's a bilateral internal iliac artery balloon tamponade used for invasive placentation.
Very good. The answer is bilateral internal iliac occlusion for invasive placenta such as placenta previa, accreta, percreta, increta. Good job. And team A gets 200 points. Okay. Now team B, you can choose your question. Be quick.
Anatomy and diagnosis, 600.
Anatomy 600. Okay. What is the diagnosis here? Review the entire movie. I will tell you when the time starts. Okay, your time starts now.
Segment 3 hemangioma with supply from left hepatic artery.
I can't hear you. Loud.
Segment 3 hemangioma with supply from left hepatic artery.
Say it again.
Segment 3 hemangioma, sir. With supply from left hepatic artery.
So the answer they mentioned was segment 3 hemangioma supplied by left hepatic artery. That is the wrong answer. Buzz. Okay, buzz by team
D.
For D?
D.
D. Okay, tell the answer. You have only 10 seconds.
Hepatocellular carcinoma.
Hepatocellular carcinoma, wrong answer. Buzz again. Okay, team A.
Hemangioma in left lobe supplied by left gastric artery.
Wrong answer.
Team C.
Hepatic adenoma, sir.
Hepatic adenoma, wrong answer.
Ruptured cavernous hemangioma.
Ruptured cavernous hemangioma, that's a correct answer. Okay, the team E gets the half points, 300. Okay, next question goes to team C. Okay. Procedures 600.
HIFU, prostate HIFU.
Loud.
HIFU, high intensity focused ultrasound.
For
prostatic cancer.
Prostatic?
Cancer.
Very good. Murthy, you want to give the answer to them?
600. Huh?
Describe the answer.
Yeah, HIFU for prostate cancer. That's the right answer. So the team gets 600.
Very good. So team C gets 600. Okay, next chance goes to team D.
800. Procedures 800.
Procedures 800. What is targeted during this procedure? Your time starts now.
Cryoablation for cystic lesion in the vertebra.
Wrong answer.
Basivertebral nerve ablations.
Very good. The answer is basivertebral nerve ablation. You want to talk about it? What is it done for, Murthy? Go ahead.
Pain related issues.
Any back pain. It's one of the new procedures that's coming in, very effective to control pain for the back. Okay. And the team C gets 400. Okay, next chance goes to E team.
600 device drugs.
600?
Device and drugs.
Devices and drugs 600.
So,
what is the device used here? What is the advantage?
Spine jack is used for vertebroplasty. And the advantage is that there won't be, we can increase the height of the vertebral column.
Very good. The answer is a spine jack. The main advantage is it increases the vertebral body height, and also it limits the chances of fracture of the subsequent vertebral body. Very good. Team E gets 600 points. Okay. Now it is a team F. What do you want to choose?
Procedures 400.
Procedures 400. This is a 50-year-old patient, cervical cancer, post-radiation, comes with pelvic pain. What IR procedure could help her? Your time starts now.
Not sure.
So sacral plexus block.
What?
Sacral plexus block.
Sacral plexus block. Wrong answer. Pass.
Sacroplasty.
Sacroplasty is the correct answer. This is the team. C gets 200. So sacroplasty in these patients with radiation-induced fractures, using cement to stabilize it and decrease the pain. Okay. F is over. Now go to team A. Okay. Let us check the points.
Team A 200.
Oh, is this disconnected? Oh, on the Excel sheet.
Okay, I can read it. Yeah. Okay.
Are you guys comfortable with the format so far? Things are going okay for you?
Okay, so the scores are Team A has 200, Team C 1200, and Team E is 900. So Team C is leading right now.
Okay, Team A, chance goes to you next.
Anatomy 800.
Anatomy 800. Anatomy, not history, anatomy. Okay, what's the diagnosis here? Time starts now.
नहीं पता है.
Pulmonary AV fistulas.
What is that?
Pulmonary AV fistula.
She's saying AV fistula. Wrong answer. Pass. Who is that?
Team E.
Team E. Go ahead.
Partial anomalous PVA. Pulmonary venous connection. Partial anomalous pulmonary venous connection.
It's incomplete answer. Wrong. Pass.
Okay. Yeah.
PA PVC with brain abscess left-sided.
PA PVC with the brain abscess. I can give the mark, but it is called, go to the answer, levoatrial cardinal vein, where the left pulmonary vein joins systemic veins there. It's a type of PA PVC at the end. So levoatrial cardinal vein with the brain abscess secondary to shunt. Okay. Team F gets how many points? 400. Thank you. Okay. Team B, next chance.
Device and drugs 800, sir.
What?
Device and drugs 800.
Devices and drugs 800. Okay. What drug is used in this procedure and what is the indication for this procedure? Time starts now.
It's used in metastatic melanoma, sir. Used in metastatic melanoma. The drug is doxorubicin. Melphalan, sir.
Very good. The answer is the drug is melphalan. Indication is metastatic uveal melanoma. This procedure is called percutaneous hepatic perfusion, where there are two balloons are placed in the IVC to isolate the liver, and hepatic artery directed melphalan is given very high dose, and the hepatic veins, the melphalan is removed from the body, and the normal blood reperfused back into the body. So percutaneous hepatic perfusion, it is now recently FDA approved for uveal melanoma. It's a very effective, and it is being now launched all over the world. It was available in the Europe before it was approved in the in USA. Okay, very good. How many points to you? Team B 800. Okay, next is Team C.
Procedures 1000.
Procedures 1000. What is the technique used in this procedure? Your time starts now.
I'm not sure.
That's an electrode there.
Okay, pass.
Buzz. Buzz.
Okay.
Team
What do you think?
E.
So IR.
Huh?
Irreversible electrodes. Bipolar IR.
Loud.
Bipolar IR.
Bipolar IRE. It is incorrect.
Buzz. Buzz again.
Buzz. Okay.
Audience.
Nobody is buzzing. Audience, anybody? Oh, somebody buzzing now. Okay. It's too late, but fine. I'll give you points if you correct it.
Pulse wave ablation.
Well, it isn't exactly pulse wave, but it is starts with pulse. Pulse electric field ablation. Go ahead and answer. Show the answer. It is a type of electroporation, but it's not bipolar. It's a pulse electric field ablation. It's a single needle that you can ablate it. It's much more easier to do compared to a regular IRE where you put multiple 4 or 5 needles. So high voltage, short duration electrical pulses sent selectively to the tumor to target the cells. Okay, nobody gets the answer. Who is the next person? Team D?
D.
Okay, D.
Devices and drugs 400.
Devices and drugs 400. What drug is used for treatment of this condition?
Melphalan, topitecan, and carboplatin.
Wrong answer. Buzz. Nobody? Okay.
Melphalan, topotecan, and carboplatin.
Wrong answer. Anybody buzz? Okay, nobody buzzing. Audience? Huh? Loud. Cisplatin is the wrong answer. Bleomycin. Very good. Who got the answer? Okay, Viru gets the prize. So it's a venous malformation of sinuses, which classical hyperintensity on T2, and angio is a puddling of the contrast in the venous sacs. Treatment is direct percutaneous injection of bleomycin or doxycycline or STS. Okay, and you get no points. Nobody gets points. You lose your chance. Now is team E.
What's the name? Who answered it?
Viru, the boss.
600 history and inventions.
History 600. What is the link? Your time starts now.
So this is lymphangiogram, and with the interlocking pigtail in a Cope, Constantine Cope invented.
Stan Cope, he described lymphangiography, Cope loop, and gastropexy sutures. Very good, congratulations. So, he was a professor at University of Pennsylvania, one of phenomenal interventional radiologists, described so many techniques in IR, phenomenal teacher, medical students love him, and he recently passed away, unfortunately, but he's contributed so much to IR. Stan Cope. Okay, team E gets 600 points. Now team F.
Anatomy 400.
Anatomy 400. A leg amputee presents with the left upper extremity finger gangrene. What's the diagnosis here and what is the cause? Your time starts now. Unfortunately, the second image is not projecting on these TVs.
It's there here. It's there seen here. It's seen here.
It's there, but on none of the screens it is seen. And not on there either. You don't need the second image.
Yeah.
You can still diagnose the first image itself. So they are that one doing it?
Yes.
Okay.
Team F.
You want to tell pass when it goes to 0?
Okay, guys, buzz.
Who's buzzing? A. Okay, go ahead.
Brachial artery aneurysm.
Brachial artery aneurysm is a diagnosis. What's the cause?
With embolic occlusion of the
No, what is the cause of the aneurysm? Wrong answer. Okay, next.
Quadrilateral compartments compression.
Wrong answer. Quadrilateral compartment syndrome. Wrong answer.
Buzz again. Anyone?
Buzz? No more buzzes? Okay. Audience. That's wrong answer.
They got it.
Crutch-induced pseudoaneurysm with distal emboli. Good answer. What is your name? Naveen. Naveen gets the prize.
Two people
So
answered
crutch injury. Who is the next person answered?
They're right there. That's
And you are? Huh? Preeti? Shriti. Anyway, both of you get half prizes. Okay, crutch injury of axillary artery with distal emboli. That's the reason. It's very common in the past. Now it's improved because of more cushioning now. Okay, who is the next team?
So I think
Who is the next team?
We can start from that.
scores.
So, okay, F is done. Scores, please. So we're going to reverse the order now. Okay? We did 2 rounds from A to F. Now we're going to start F to A now. Okay? Next 2 rounds. So be ready. What you want to do?
Okay, the scores: Team A 200, Team B 800, Team C 1200, Team E is leading with 1500, and Team F is at 400.
Okay, good. Congratulations, all of you. We still have a lot of questions to make it to the first level. Okay? Okay, let us start next round. Team F, choose a question.
Anatomy 1000.
Anatomy 1000. What surgery did the patient undergo? Your time starts now. Sorry. You got 8 seconds more, but anyway. What is that? Don't worry about the text on the image. The answer is on the images itself.
Okay.
So gastrectomy, after that there is a colonic pull-up.
So colonic interposition following esophageal resection. That's the correct answer.
That's an awesome job, guys. We
That's
thought
very
this
good.
was one of the very difficult questions, and it will go to the audience, but I think Team E did
Team
an
E
awesome
killed
job.
it. So Team E gets 500 points. Okay, the next question goes to Team E.
History 800, sir.
Huh?
History 800.
History 800. What is the name of this trial? Your time started 10 seconds ago. Okay.
Caveat.
Huh?
Caveat trial.
Caveat, wrong answer. Buzz.
Cavent.
Caveat is the wrong answer. Buzz. Attract trial is the correct answer. Answer, please. This is Attract trial done by Suresh Vedantam from Malincrot University at St. Louis, which compared anticoagulation alone versus anticoagulation plus endovascular therapy for acute deep venous thrombosis. Overall, the trial was negative. There wasn't a big difference in the outcomes of post-thrombotic syndrome between the two groups. However, the people who got endovascular therapy had less severe post-thrombotic syndrome compared to the people who got only anticoagulation. The subsequent analysis suggested that people who have thrombus above the inguinal ligament tend to benefit much more with endovascular therapy. Okay, next team is going to be Team D. What do you want to choose?
Anatomy and diagnosis 200.
Anatomy 200. 30-year-old man with right leg claudication. What is the treatment? Your time starts now. Hey, you can do that. We'll disqualify you if you do next time like that. You'll only buzz after I say pass.
Popliteal entrapment, so surgical release.
Surgical treatment is the right answer, but the diagnosis is wrong. We'll give a point to anyway because the question was what the treatment. Okay. Anybody wants to answer what the diagnosis here? Cystic adventitial disease of the popliteal artery. Treatment is surgery here. So team
100.
D gets 200, right? 200, yeah. Okay, now your turn, team C.
Research and innovation 400.
Research and innovation 400. What was the outcome of the IR trial associated with this?
Emerald trial, which was a trial for HCC with systemic immunotherapy.
Very good. This is Emerald 1 trial for chemoembolization versus combining with the Durva plus bevacizumab. The trial was positive that if you combine bevacizumab with Durva and TACE, the outcomes are much, much superior compared to TACE alone. They also have a third arm where they compared TACE plus Durva alone, which did not meet any statistical significance. So they found that bevacizumab is critical component when you do TACE procedures. So Durva plus bevacizumab plus TACE is much better than just TACE alone or TACE plus Durva. Very good. How many points you got?
400.
400. Okay. Next, team B.
Device and drugs 1000.
Devices and drugs 1000. Okay, what procedure or device is described here? Your time starts now.
E-stent.
Huh?
E-stent.
What?
E-stent for idiopathic hypertension.
Idiopathic?
Idiopathic intracranial hypertension.
Wrong answer.
CSF venous shunt.
Huh?
CSF venous shunt.
CSF venous shunt is the correct answer.
For raised intracranial hypertension.
Huh?
For intracranial hypertension.
Yeah, but what is the device? Okay, pass.
E-shunt.
Huh? What is called?
E-shunt.
E-shunt? I don't know what E-shunt is. I don't know, maybe you call E-shunt, but I call different name for that. Anybody in the audience? Okay, can you just show this answer? It is the endovascular transdural shunt using a biomimetic stent for treatment of hydrocephalus. So CSF to venous stent is the correct answer. Huh? Okay, E-shunt. But he said the answer is in hypertension, you said, right? But hypertension is not the indication, right? Okay, that's wrong. Huh? You can say hypertension as well? Which hypertension? Systemic hypertension? Idiopathic intracranial hypertension? So how many wants to agree with that answer? Because I don't know the answer. I thought only this is the correct answer. Okay, let us give the full points to these guys. Team B, 1000. Okay. No, they got the first time, correct answer. I passed it to next. Okay, who is the next team? Team A? Okay, you choose.
Research 600.
Research 600. What study assessed the clinical role of IR physicians in improving patient satisfaction?
Start timer, please.
Okay, your time is 10 more seconds.
Buzz, please.
Who is that? Nobody? Okay, we'll pass on to the audience. Anyone from audience? What? Nobody Googled it? Okay, let's show the answer. It is called a CLINT interventional trial, a randomized controlled trial with patients seeing radiologist first and some patients not seeing radiologist first. And they found if the patient sees the radiologist, they had better satisfaction of the procedure. So it clinches the role of a clinical role of IR person. So you must see patients before doing any procedure. And they augmented the communication with videos to show the procedure, and it decreased their anxiety after the procedure. Okay, we'll start with team F now.
So scores?
Scores, okay, go ahead, scores.
Okay, guys. Team E is still leading with 2,000 points. Team B and C are very close, so good luck on the next rounds. Team B with 1,800 and C with 1,600.
Okay.
Team D is 200, Team A is 200, and F is 800.
Fantastic. You're doing great job here. Still you have more questions to win. Okay, team F, go ahead.
Quality 200.
Quality 200. So, what is the treatment for this complication after failure of conservative therapy?
Start timer.
Start timer.
Okay.
Sclerosant injection at the site of wrist.
What is that?
Sclerosant injection at the site.
I didn't say pass.
Wrong answer. Pass. Buzz, please.
Okay.
Sir, bronchoscopic embolization of the bronchopleural fistula using plug.
Very good. Endobronchial placement of a plug or a valve for treatment of a bronchopleural fistula is the correct answer. Okay, team B gets how many points?
100.
100 points, right?
Yeah.
Okay. Next team is?
Team E. Please
okay,
select
team
something.
E, you can choose.
History 400.
History
400.
400.
What is his association with interventional radiology?
Joseph Roche.
Wrong answer. Buzz. Nobody? Okay, go ahead.
Colapinto. Colapinto.
Huh?
Colapinto.
Wrong answer. Buzz.
Grunznik.
Huh?
Andrew Grunznik.
Wrong answer. Buzz. Audience. Huh? No, not Rush. Alexander Margulis. He coined the term of interventional radiology. It is shame on us that if you don't remember that. Okay? Next answer. Show the answer. So he introduced the term interventional radiology in March 1967 editorial of American Journal of Oncology. He wrote a fantastic book on abdominal radiology intervention. It's a red book. If you haven't read it, please read it. It's a phenomenal book he wrote. He's no longer alive. Okay, who's the next team?
Team D. Please select something.
Quality safety 400.
Quality and safety 400.
Okay, how do you treat this complication? Your time starts now.
MT with plastic, mechanical removal.
Wrong answer, pass.
Okay.
Team F.
Sir, infection.
They got the light bulb on. Okay.
Surgical removal of the stent, sir.
Surgical removal of the stent. Wrong answer.
Medical management with antibiotics.
What is that?
Medical management antibiotics.
Did you get the light on? Who is the light on? Huh? Okay, your light was on. Okay, go ahead.
Stent graft infection, medical management, antibiotic.
Very good. Antibiotics is the correct answer. And if the vegetations are present, you can reline the stent graft along with another one if you want. Okay, it's a tipsitis or infection of the tips graft. Okay, with the next team?
So 200 points.
200 to team B. Okay.
Team C. Select
Next
some
question goes to
category.
team C, right? So be careful, guys. Until I say pass, either me or Dr. Murthy says pass, if you buzz it, it is not counted.
Safety 600.
Huh?
Safety 600.
How to avoid this complication? Time starts now.
That is in stomach. Stomach or liver? Stomach. No, stomach is collapsed. How to avoid? Non-target. How to avoid? Sorry. There is non-target embolization, so prophylactic coiling of the falciform artery.
Very good. The answer is embolization of falciform ligament artery, because in this case there is the radioactivity uptake near the umbilicus. That area is separated falciform ligament. If you are unable to catheterize the falciform ligament and embolize it, you can put an ice pack there so that the vessel goes into spasm, the particles won't get there. Okay, very good. How many points you got?
600.
600. Team C got 600. Okay, Team B, your turn.
Quality and safety 1000.
Quality, safety 1000? Okay, 1000. Immediately following left chest tube placement, patient collapsed. Blood is noted in the chest tube. What is the complication? Your time starts now.
Most likely that only.
The chest tube is in the left ventricle, sir.
Huh?
The chest tube is in the left ventricle.
Chest tube in the left ventricle. Wrong answer. Buzz. Okay.
Intercostal artery injury.
Intercostal artery. Wrong answer.
F.
Go ahead.
Rupture of ascending aorta.
Wrong answer. Pericardial injury. Wrong answer.
Aortic.
Okay, Team A. Go ahead.
Drainage in pulmonary vein.
Pulmonary vein is the correct answer. Left inferior pulmonary vein is the chest tube is in. How do we know? You can see contrast injection on the left last picture with the left atrial enhancement with the contrast. That's how we can diagnose it. And the contrast did go to left ventricle as well as we injected very hard. How do you manage this one? So what we did was we placed a new chest tube and then exchanged the catheter for a sheath and embolized it with the coils. The whole left interpulmonary vein was embolized and then took the catheter out. Okay,
So
who got the correct answer?
Team A, 500 points.
Okay, Team A got the answer, 500. Who is the next term? Huh?
Team A.
Is the 2 rounds are over? Huh?
Last.
Okay, your turn. I thought you got the 1000 case, right?
They got it 500 points.
So you got 500 then?
Yes.
Okay, this team got 500. Okay. Next question, go ahead.
Quality and safety 800.
Quality, safety, 800. Okay. We want to know the diagnosis, complete diagnosis. Okay, your time starts now. You can play it again.
Abdominal aortic aneurysm treated with the stent graft with type 1B embolic from the distal.
Type 1B embolic is a wrong answer. Buzz.
Type 1C embolic, sir.
What?
Type 1C embolic.
Type 1C embolic is a wrong answer. Buzz.
Aortocaval fistula.
Aortocaval fistula is a partially correct but not a complete diagnosis. Buzz.
Type 3 embolic along with aortocaval fistula.
Very good. Type 3 embolic with aortocaval fistula. That's a complete answer. So team E gets 400 points, right? Very good. Any questions? So did we do 2 rounds with the F starting F? Yeah. Okay, we'll start from A. Huh?
We can start with same like before.
Okay, we can start with team C.
All should get advantage.
Okay, that's fine with me. Okay. So we will start which way? This way or this way? Anti-clock or clockwise? Doesn't matter. Okay, we'll start with the team C to choose the next question.
I'll just announce the scores very quick for the round. So team E is still leading with 2,400 points. Round applause. B and C are just behind few hundred points. Team B with 2,100 and team C with 2,200.
Very good. So the race is very tight between 3 teams.
Teams A
B,
and
C
F
and E.
are at 800 and team D is at 200.
Audience is doing good. I think they're not giving you chance much, which is good. Okay, let us start. Team C, pick up. Oh, team C, right? Oh, you're not team C, sorry. You're the team C.
Device drugs 200.
Devices 200. What property of a nitinol stents is described here? Say it again loud. Say it loud. You already said.
Yeah, conformability of the stent shape, re-expansion, like memory.
What memory?
Shape memory.
Because?
Like it conforms to the springs back.
Thermal memory. That's a good answer. Okay, show the answer. It is a shape memory effect or thermal memory of the nitinol. So you prepare the stent at the temperature you want, and at other temperature you bring it down or expand whatever you want. When you read it, the prior temperature will go back to exact same size. That is why nitinol became so important. Audience question: who brought nitinol to medical field? That's what nitinol stands for. Who is the physician who brought nitinol to medical field? Huh? I'll give one more clue. Google it. And the first described device is Simon nitinol filter. Tell me who brought it up. No, Morris Simon. He was the chief of IR at Beth Israel Medical Center at Boston. He worked on Navy or Air Force he worked. That's when Air Force got he worked for NASA actually. NASA introduced this nitinol into the planes or into the rockets. And then he thought, okay, it's a good idea to bring this to medical field. And his first work was to prepare the Simon nitinol filter along with the MRI guy, I forgot his name, who was a Mass General resident. And they both together designed this filter. Okay, C is done. Let's go to D. Your chance now.
Research Innovation 200.
Huh?
Research Innovation 200.
Research Innovation 200. What was the outcome of the randomized trial comparing PAE with medical therapy?
Prostatic artery embolization is non-inferior to medical therapy.
That's a wrong answer. Buzz. Team E.
Prostatic artery embolization showed better IPSS reduction as compared to medical therapy.
Very good. And it lasted for up to 24 months. So part-time trial. Do you guys know who led this trial? So Mark Sapowal, who was our guest speakers today. Okay, very good. Next team is going to be yours. You already done. Okay, E, go ahead.
1000 history.
1000, where?
History.
History 1000.
History 1000. What is the device used in this invention? No, don't answer. You're not giving the clues here. I could hear it.
Cerebral venous stent.
Wrong answer.
F.
It's a stent rod for approved for ALS treatment.
Stent rod is the correct answer. Okay, can you show the answer? Show the answer, please. So stent rod, it's a brain-computer interface. It's a minimally invasive brain-computer interface developed by the company called Synchron. It is designed to restore functional independence in patients with severe paralysis such as ALS, stroke, or spinal cord ischemia by allowing them to control digital devices using their thoughts. The stent is placed in sagittal sinus and there is attached a device into the chest wall. Okay, that's very good.
500 for Team F.
Team F gets 500. Okay, next turn is Team F?
F.
Okay, go ahead.
Sorry. Research 800.
Research 800.
Research 800. Okay, based on this trial, who would benefit from Y90 radioembolization? The
Time
trial is
start.
listed there. The time started.
No.
Patients having colorectal metastasis to liver who underwent tear and chemotherapy. So they have more benefit compared to chemotherapy alone.
That's partly correct, but it's not the patients who would benefit. So there's a specific indication in this trial. Okay, pass. It looks like nobody wants to answer this question. Audience? Nope. What trial is this? EPOCH trial. Very good. EPOCH trial. Who said that EPOCH trial? Very good. What's your name? Elangovan. Very good. Congratulations. So EPOCH trial tested colorectal patients who failed first-line chemotherapy and then randomized them to receive second-line chemotherapy versus second-line chemotherapy plus Y90. That showed patients who received Y90 had a better overall response rate. Okay, good. Who is the next team?
Team A.
Team A.
Research 1000.
Research Innovation 1000. What technology was used in the Hope for Liver trial?
Histotripsy.
Histotripsy is the correct answer. Very good. So this is a histosonic system which used the histotripsy to treat non-invasive liver tumors and found to be very effective in small tumors of 2 centimeters or smaller. Okay, very good. 1,000 points to Team A. And now Team B.
History and innovation 200.
History inventions 200. What is he famous for?
Joseph Roche conceptualizing TIPS.
Very good. First one to describe the TIPS procedure. In the audience, what else is he famous for? What? Embolization. Very good. Farah, you're awesome. Good. I think we finished the rounds. We want to go get the scores now. So we have 6 questions left, 1 more round left. So we start with C, right? We start with C. Start with the D? Okay, we'll start with the D next time.
Anatomy diagnosis 100.
No, wait a second. Scores. We'll get a scores first.
Okay, awesome. Okay, so we have changed the situation a little bit. C and E are both at 2400. Awesome job, guys. Team B is just 100 points behind with 2300. Great job. Teams A and F are at 1700 and 1400, and Team D is at 200.
Very good. It's the time to make it up. Okay, Team D.
Anatomy diagnosis.
Anatomy, 100. What is the anatomical variant described in this picture? Corona mortis. It is the aberrant obturator artery arising from the inferior epigastric artery, gets injured when the pelvic fracture involves superior pubic ramus. It's a very common injury, usually missed. That's why it's called corona mortis, the crown of death. How do you treat it? Embolization. Very good. 100 points to Team D. Okay.
Okay, Team E.
Procedure treatment 100.
Procedures 100. What
Okay.
procedure is performed here?
I'm so sorry, the image is incomplete.
Timer start.
Can you make it, move the image? Can you we'll stop the time. So can you? No. I want you to come off from the full display, move the image and replay it. Yeah, come out of that. Okay, move the image to center even more. It's okay not to see the brothers. Okay, now go ahead, play full, make it full. Okay, now play it again. Okay, now we can see it better. Thank you. Your time starts now. Who is the person doing it?
So, catheterization of lymph duct.
Cisterna chyli is the wrong answer.
Okay. F. Team F, go ahead.
Pelvic vein embolization for venous leak through ED.
Very good. It's a penile venography. Okay, correct answer by Team F will get 50 points.
50 points.
And who is the next person? Team F?
Team F.
Device drugs 100.
Devices 100. Okay, what is this device and what is the problem? Okay.
It's a chemo port inverted upside down.
Perfect. It's a flipped chemotherapy pump port. It's usually used for hepatic perfusion of chemotherapy drug, usually 5-fluorouracil for colorectal metastasis. Very
Team
good
F
answer. It should have been like this. Can you see the picture? That's how it should have been. It's flipped. Okay. Now Team F is done. Now Team A, next question.
Quality 100.
Quality 100. What is the complication?
Glue embolism.
Glue embolization is the correct answer. Very good. 100 points to Team A.
Research innovation.
Research 100. Name the trial that compared uterine artery embolization with hysterectomy for uterine fibroids.
EMI trial.
EMI trial is the correct answer. Very good. So this trial showed the cost effectiveness of UAE compared to hysterectomy. However, it also showed the reintervention rates are quite high with UFI, up to 28% of the patient required second procedure. Okay. Last question to Team C. You are left with one question. History invention 100. Name the legendary IR physician and what is he famous for?
Can I answer that? Dr. Kalva.
Not me, the one next to me. Okay, I'll give you a clue. Don't give a clue. Okay, I'm not supposed to give a clue. The clue is I'm not the one there. Okay. Okay, pass. Nobody.
Buzz.
Okay. Come on. When you buzz it, you should know the answer, right?
Kaufman.
John Kaufman is the wrong answer. Anyone else? Okay. Audience? Arthur Waltman. What is he famous for? Waltman loops. Can anybody describe what artery he catheterized with Waltman's loop? Left gastric artery. Murthy Channapragada from Australia. Fantastic. This is the original description of Arthur Waltman describing Waltman's loop. Did you guys know how he described it? At that time, all he had was, it was 1973. See the paper published. That means he has done this case in 1972. And when he was a faculty member at Mass General under Dr. Christo Athanasoulas, who was the chief there. You can say third author is the Christos. And the Stanley Baum was actually the original chief, and he moved to Pennsylvania after that. So he was using a 7 French catheter to select the splenic artery. He was pushing it. While pushing it, the 7 French formed a loop in the aorta, and the catheter came back and selected left gastric. Then he realized, oh, this is serendipitously found this very nice way to catheterize left gastric artery. And then now we utilize it for UFEs, prostatic artery embolization. So the main technical thing about this Waltman's loop, if somebody doesn't know, is it is used for selecting an upgoing vessel that comes off from a lower going vessel. So if you have a catheter that goes Z-shaped, you can always select that vessel with Waltman's loop. It is not limited to left gastric artery or UFE. Anywhere you can use it, even in the venous system also you can use it. Okay, that concludes Jeopardy.
Big round of applause.
Points. Okay, guys, something very interesting here. First of all, though, the teams have done amazing job. I think next time we should make it more tougher. Okay, they have answered probably all the questions, so excellent job, guys.
Excellent job.
Really awesome. And let me start with Team D, 300, Team F, 1550, Team A, 1800. But Team B, C, E, all of them are at the same level. They have 2,400 points.
Very good. Okay, the final round is to decide who will be the winners. Are you guys ready for rapid fire? The rapid fire will be super over now. So it's extremely rapid. Each team gets 90 seconds exactly. And how many you answer, each question will have 200. If you really answer at least 9 questions, it's 1,800. You can beat the other groups. Okay?
And we saved the best for the rapid fire, guys. They are the
very
best
simple
slides.
questions. And audience, please do not answer any question. We'll get the chance. Whatever the leftover will go to audience at the end. So who wants to start first? There's no negative marks. But if you don't know the question, if you don't know the answer, if you pass it, I can show next case. If you don't say pass, I won't show next case. Speak. Huh? Unlimited. You have 90 seconds. You can answer any number of questions you want. If you don't know, quickly say pass because next question comes to you. Right? Okay, who wants to go first? Okay, you want to take a lottery? Okay, where's the lottery? Okay, give me the papers. You threw away? Oh. You have a lot? Oh. Okay, can somebody write A in a small paper? Team A threw it away. I'm going to be mad at you. Thank you. Okay, who got A? Okay, team D. Are you ready? You're going to start now. Okay, rapid fire. No, please get that
Reset
time
it.
back to 90. Don't start now. Can you get back to 90 there, please? Okay, when I say start, then you only start. Can you open the slides? Okay, start now.
Right gastric artery.
Correct, next.
Next slide. Next.
Radial,
Next slide.
DR band, correct.
Renal arteriovenous fistula.
Next.
Very
next
good,
slide.
next.
Varicocele.
infertility.
Next,
good.
next, next.
Pleuris, malignant pleural effusion.
Next.
Correct.
Takayasu.
Wrong, next.
Methamphetamine toxicity.
Wrong, next.
This biliary stent retrieval. This biliary stone.
Biliary stone retrieval, very good, next.
That's it, done. 90
Okay,
seconds.
we're done. How many you got right?
6. Yeah.
6. So 1200 points to team D. Very good job. That's a very fantastic job. And who got the B? Okay, B got B. That's okay. One thing. Are you guys ready? Okay, let's go to next case. Go ahead.
Timer.
Timer on. Okay.
Pass.
Pass. Next.
I was.
Pass.
Judkin.
Judkins.
He's Judkins. What is contribution?
JLJR.
Okay, very good. Right and left coronary catheters. Next.
Temporary dialysis.
Dialysis, correct.
Pass.
Pass.
IVC filter. IVC filter.
Pass.
Size more than 4 centimeters.
Size more than 4 centimeters, correct. Next.
Pedal lymphangiography.
Pedal lymphangiography, next. Correct.
Chronic pelvic.
Okay, time is up.
Time is up. Chronic pelvic pain. So how many got right? 4 got right. 800 points for team B. Last was chronic pelvic pain. Yeah. Oh, 5 correct? Okay. 5 correct. Can you show the next answer? So chronic pelvic. Who got C? Okay. Are you ready? Ready? Ready?
Yes,
okay.
sir.
Timer start. Next question.
Left hepatic.
Correct. Next.
Pass. Intercostal artery, artery of aneurysm.
Very good. Next.
Flow for aneurysm. Pass.
Pass.
10 mm Hachi. 5 mm Hachi. IVS we can do, sir, and pressure measurement.
Wrong. Pass.
The pass. Thrombectomy for acute ischemia.
Which device?
Aspiration catheter.
Very good. Next.
TGLB.
TJLB, correct.
Hepatic venoplasty.
Butt Chiari.
Butt Chiari.
Next.
Hysterosalpingography. For FTR. Fallopian tube recanalization.
Very good.
Next.
Folfox, Folfree. Folfree trial. Nick, pass.
Pass.
Basilar artery aneurysm contour.
Done. Very good. Correct answer, contour. How many they got right? 7. 1400. Good job. Good job.
Next here.
Okay, who is the next one?
D. Here.
D, okay. Go ahead.
DF.
Are you guys ready? Can you show the answer? Okay, are you guys ready?
Yes.
Okay, time starts now. Next. Click next case.
Dry food, desert food.
Desert food, correct answer. Next.
Pass.
Pass.
Double keva.
Duplicated keva, good. Next.
Nutcracker syndrome.
Wrong. Next.
Pass. Web device.
Web, good. Correct. Next.
Rotational atherectomy. Stealth.
Orbitalis.
Correct.
Left gastric artery with accessory.
Wrong. Next. Can you play the movie? Can you hold the timer, please? Okay. Diagnosis. Okay,
Pass.
start the timer now.
Pass.
Pass. Next.
IVC filter.
Okay, done.
Done. That is a Mobin-Uddin filter. We can't give points IVC filter. It's IVC filter, but it's a specific name, Mobin-Uddin filter. Okay, how many you got right? 4 got right, so you got 800, team F.
Yeah.
Who has E? Team C, yeah? Are you guys ready?
Yes.
Yes? Okay, start now, timer. Okay, go. Okay, wait.
Restart the timer.
Restart the timer, please. Ready?
Yeah.
Okay, ready?
Bleomycin.
Bleomycin, correct. Next. Yes, moving.
Expiration.
Expiration, correct.
HHT.
HHT, correct. Next.
BRTO.
Correct.
Shockwave lithotripsy.
Good. What technology? Okay. Next.
Pass. Pass.
Pass. Next.
Pass.
Stent retriever.
Next.
Correct. Next.
Anaconda.
Wrong. Next.
Carpenter.
Carpentry, correct.
Pass.
Next.
Plantar flexion.
Plantar flexion is correct. Next.
Time's done.
Time is up. Okay. Audience, get this question. Splenic venous dissociation. Who said that? Very good. You attended my lecture then. Karthikeyan. Okay, who is the next team? How many? 8 correct answer. That is 1600. That's cool, guys. Fantastic. So, is the last team now? You're the team? It's the last one? Hey?
Yeah.
Everybody got the chance, right? All done? This is the only team left? Are you guys ready? Team A? Yes. Okay, time starts now.
FMD.
FMD, correct. Next.
Pass.
Pass.
IPSS.
IPSS, correct.
Dissecting aneurysm.
Wrong. Next.
Tips.
Correct. Next.
Transcentric biopsy.
Wrong.
Next.
Next.
Arteriovenous malformation, pulmonary.
Wrong. Next.
SM. SAM.
Sam, correct.
Venatic LP.
What?
Venatic.
Wrong. Next.
Pass.
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 SMV thrombosis.
SMV thrombus, correct. Next.
Mid-aortic syndrome.
Mid-aortic syndrome, secondary to NF.
Time done.
Time's up. We can't give the point for the last one, okay? Because you didn't tell the diagnosis. How many they got correct? 5?
No.
Wrong.
No, lots.
5. So 1,000 points to team A. Okay, Murthy, before we announce the marks, let us ask the audience next questions. So rest of the rapid fire goes to the audience. Or we can do buzzer of the count. You want to buzzer? Rapid buzzer?
Buzzer.
But no points. Okay? Rapid buzzer, no points. Okay, let's go and show. No timer, nothing.
Double vein embolization.
Okay, what is it called?
Liver venous deprivation.
Hepatic venous deprivation.
Hepatic venous deprivation. Very good. Next. Next. What is the indication? Occluded central veins. Good. Next.
Buzz, please.
Wide.
Huh?
Wide. More than 4 mm of the neck of the student.
No.
Absolute contraindication.
Absolute contraindication.
Yeah,
Arteriovenous
correct.
fistula is the correct answer. Next. What is the problem?
SVC obstruction.
SVC occlusion.
SVC occlusion, correct answer. Next. Diagnosis? Huh? ABC is wrong. RCC metastasis, good. Next. Paracentesis, good. Next. Diagnosis?
Persistent sciatic artery.
Persistent sciatic artery, good. Next. Premature menopause, very good. Because of Uterovarian anastomosis here. Next. Endo AVF creation for dialysis. Good. Huh?
What is Kiva? Can you tell us? It's an implantable coil. It's a nitinol coil with PEF coating, and it's an alternative to spine jack for vertebral augmentation, but right answer.
Very good. Next. Which anastomosis is the most common among genicular arteries? So A1, A2, A3, among those 1, 2, 3. Okay, answer is A1, DGA2, SMGA. Okay, next. The uptake in the duodenum. So the complication would be duodenal ulcer. Very good. Next. Name the tracer injected. Technetium labeled macro aggregated albumin. Very good. Next. What does OMAC stands for? Very good. These guys got it. Show the answer. Western Ontario and McMaster University's Osteoarthritis Index. Okay, next. It's a flow saver. Okay, good. Next. All done? It's the last one? Okay. You want to stop here, guys? I think time is up. It's already 7:15, so we'll stop here. So I give a big applause for the entire team. They did a fantastic job. Are you ready for the scores? Okay. And who is going to give the prizes here? Either leadership here?
Okay. So first announce these and then we can.
Do you have prizes? Shyam or our incoming president? Or Deepa? Anybody? Sanjay, yeah. President-elect is here, so he can give the prizes. You got it? And read? What happened?
I'm going to announce 6, 5, and 4, and then this 3, 2, 1. You want to announce the winner?
Sure, yeah, fine. So,
3, 2, 1.
I think you don't need to do that one, just announce. Okay. 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 Okay, the third place. Can you guess who is our third place? Huh?
Okay, got it.
Okay, the third place goes to KMCH Coimbatore with 3,400 marks. Venkatesh and Abrar Gauss. Shut up, yeah. Please get big applause for them. Good. Where's the prize?
They have trophies.
Come on, good friend. You have the honor of receiving the prize from the president-elect. Stay here. You will come. Come here. Give it. Give him as well.
At the very end, I'll announce it.
Both of them stand next to him. Take it and stand. The third, yeah. Both members get the prize. Murthy, come. Take another picture. Murthy, he's a quiz master. Thank you. Congratulations. Fantastic job. So Matthew won't scold you now. Okay. The second prize, who wants to? Okay. A second prize goes to Team E, PGI, Siva Chandar and John Alexander with 3,800 marks. Fantastic. Congratulations. Good job. Come here. Come to the front, please. Yeah, come here. Come to the front. Stand next to each other. Let them be the center. Yeah. I can go other side. Give a big applause. Okay, who will be the final winner here? Very good. It is Team C, NH Bangalore, Aditya Shetty and Anshul Varshni. Congratulations. The 4,000 to narrowly won. Please come to the front. Give a big applause to the team that won. Fantastic. Good job. Congratulations.
So, there were some audience answers.
You want to know the scores? There's scores.
There she is.
We have prizes for them.
We have?
Yeah, we do.
Okay. So can you call them on stage?
Okay. The next best team is Team A. 2,800 marks from Dikshit Verma, Snehal Isvir Kos. They deserve special mention because she's the only woman who volunteered here. Come. Any prize? Who's going to give this prize? I get the honor? Okay.
I got it. You can give it. Yeah,
No, you can give it.
Go ahead.
Congratulations. We'll stand together. Congratulations. Come on, stand.
Good job, guys. Good job.
You want to announce the next one?
Go ahead.
Give me is done. It's the next fifth one. The next in the line is a team from Gangaram, Vineet and Ravish Patel, with the 2,350 marks. Congratulations, good job. You can give it. Right.
Come on, come to the front.
Come to the front.
Thank you. Congrats.
Not but the least is Team D, Government Medical College, Nagpur, Aman Yusuf Khan, Shubham Yadav. Congratulations, 1,500 marks.
Congratulations. Good job.
Come to the front.
Good job. Come to the front.
Okay, give a big applause to all the participants. Great job, great job.
Yeah, the quiz is not over. We have got exciting prizes for the audience. And maybe call on stage Dr. Virender to receive his prize.
Virender, you get the prize. Come on. Get them quickly. Come on.
I saw you answered for penalty.
With the next one.
Mr. Naveen.
Naveen.
Naveen
Congratulations.
इशारा करिए सर. इशारा करना वहाँ से. Shrey. Yeah, please. Please come on stage.
Tell them. Congratulations. They're going to bring it, so wait. Okay. They're getting one?
No, we have got prizes.
Yeah? Fantastic.
Mr. Devesh.
Devesh.
Mr. Elangolan, Mr. Murthy, Mr. Karthikeyan. A huge hug for all three of you. Thank you so much.
Okay, all done. Thank you so much for the audience staying here and also being active participant in the quiz. You're awesome. Thank you all for participating in the quiz. You did a great job today.
Thank you so very much. A big round of applause to both our quiz masters, Dr. Sanjeeva and Dr. Murthy. And Dr. Kunal Gala, Dr. Preetham Chatterjee, Dr. Alok Mittal, Dr. Shikhar Garg, Dr. Harish B, Dr. Sridhar, Dr. Lijesh Kumar, Dr. Rangarajan Rajagopal. This is the team that put the entire quiz together. So give it up for the content team, ladies and gentlemen. Lovely quiz. And also, if someone had told me that on day 3 at 7:20, I will find a full house with a crowd clapping like crazy, I would not have believed. Give yourselves a nice big round of applause. It's apparent the thirst for knowledge is amazing. On that note, let me quickly remind you that the party is at WAF. Please join us there in your traditional outfits, and then it continues right here in this hall where dinner will be served after 10. So please make sure you come dressed well and get ready to party. Are you ready? Wonderful response. Are you ready? All right, see you at the WAF. Thank you. And also to the students who are on stage, your certificates are getting ready near the backstage. Please collect them. Once again, ladies and gentlemen, give it up for the next generation of IR professionals on the stage.
you.